sure. All right, good morning. I would like to welcome everyone here with us today, both here in the room and joining us by webcast to this public meeting on expanding access to effective treatment for opioid use disorder, provider perspectives on reducing barriers to evidence-based care. This event's being hosted by the Duke-Margolis Center for Health Policy, and it's supported by a cooperative agreement with the Food and Drug Administration. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, and we're pleased to have this timely discussion on a very important, a critical public health issue. As everyone here knows, there remains a crisis of opioid misuse, addiction, and resulting morbidity and mortality in the United States. Yet despite the high and rising burden of the opioid epidemic, millions of Americans still lack access to quality, evidence-based treatment. We're here today because we know that opioid use disorder is treatable and that recovery is possible. We also know that although there is no one-size-fits-all approach to treatment, there is strong evidence demonstrating the effectiveness of FDA-approved medications, buprenorphine, methadone, and naltrexone, as a vital part of a comprehensive treatment approach that also includes psychosocial behavioral counseling and sustained recovery support. However, substantial challenges remain both to patient access and to provider utilization of these effective therapies. Just last week, the Substance Abuse and Mental Health Services Administration released its annual survey of drug use and health. The survey this year included some positive news. Not only have we seen a decrease in prescription opioid misuse and new heroin initiates, but more than 100,000 Americans received treatment for opioid use disorder than they had in the year before. However, the survey also revealed some persistent gaps in our treatment of substance use disorders. Of the estimated 2.1 million people with opioid use disorders, only 30% of those individuals receive treatment at a specialty facility or private doctor's office. Additional studies estimate that medications for opioid use disorder treatment are routinely used in less than 50% of private sector treatment settings, and as many as 30 million people, many of them in rural geographic areas, live in counties without access to a single buprenorphine provider. So as we'll hear today, there are significant legal, regulatory, and payment issues and other practical challenges that contribute to the gap in use of quality evidence-based treatment. Addressing this treatment gap will require cooperation and innovative approaches across the healthcare system. Supporting development, access, and adoption of medications for treatment of opioid use disorder is a key priority for the U.S. Food and Drug Administration as part of its approach to addressing the opioid epidemic. And the Duke-Margolis Center for Health Policy is pleased to partner with the FDA today to better understand provider, patient, and health system perspectives on how we can address barriers to expanded access of these important medications. We hope that today will serve as a forum for providers, clinical experts, and other stakeholders within the healthcare system to come together to learn from current innovative models for treatment of opioid use disorder, identify barriers to such treatment, and discuss opportunities to further reduce stigma and to expand access to effective opioid use disorder pharmacotherapies. As you probably can tell from the agenda in your packets, we have a packed schedule today, and we're looking forward to our speakers covering a lot of ground, as well as the opportunity to engage with all of you here today, both in the room and on our webcast, on these important issues. To get us started, I'd like to introduce Greg Daniel, our Deputy Director for Policy here at the Margolis Center, who will spend a few minutes to quickly run through today's agenda. Greg?
Thanks, Mark. Good morning, everyone. I'd like to echo Mark's welcome to all of you for joining us today in this important discussion. I'm Greg Daniel, Deputy Director of the Duke-Margolis Center for Health Policy. Today, we're honored to be joined by Dr. Janet Woodcock, Director of the Center for Drug Evaluation and Research at FDA, who will help us kick off the day with some opening remarks. After that, we'll hear from Admiral Brett Giroir, who will be going over HHS priorities and actions to address the opioid epidemic, including expanding access to treatment for opioid use disorder. Before we introduce them, I want to spend a few minutes to quickly run through today's agenda. Following those opening remarks, we'll hear from FDA's Sarah Eggers, presenting an overview of key findings from FDA's April 17th public workshop on patient-focused drug development for opioid use disorder. Then we'll have a few presentations on the current state of knowledge on addiction, clinical approaches for identification and assessment of opioid use disorder, and evidence supporting the use of medications for opioid use disorder treatment. We'll then move on to session one, which will be moderated by Margolis Center Director Mark McClellan, who will explore innovative and evidence-based approaches to opioid use disorder treatment. We'll then take a small break at 11:15 and come back and jump into session two, which will be moderated by Larry Greenblatt from the Duke University School of Medicine, where we'll discuss legal, regulatory, and practical barriers to accessing treatment of opioid use disorder by patients. We'll then break for lunch at 12:35, come back for session three at 1:35, which will be moderated by the Margolis Center visiting fellow Regina LaBelle to discuss care models and challenges for delivering treatment to vulnerable and medically underserved populations. After another quick break at 2:40, we'll moderate our last session. I'll be moderating that session. We'll be discussing approaches to defining successful outcomes. So regardless of the treatment for opioid use disorder, what are the real outcomes that we're hoping to achieve and that we can hopefully measure? On how improved quality measurement can lead to alternative payment approaches is another topic. Improved quality and access, outcomes related to all of those things would be important to discuss. Before we get into all of that, just a few last housekeeping comments. I want to remind everyone that this is a public meeting. We're broadcasting live online. Everything will be on the record. We hope all of you will be comfortable engaging in this really important dialogue throughout the day. For our speakers and panelists, we ask that you please disclose any conflicts of interest from the get-go so that we can maintain a high level of transparency here today. These are Mark's and mine. As a heads up to speakers and panelists, Isha Sharma, who's sitting right here in the front, and Nick Fiore, who is not, will be keeping us all on schedule with signs to indicate how much time is left for your presentation. We want the audience here today. We're going to do some interactive polling with the audience in the room today, as well as those of you who are joining us online. For those of you in the audience, polls should be accessible via the smartphone or a web browser, and I think that there's a Bitly web address up there. So right now, if you're in the room, take your smartphones or your computers out and go to that website. For those of you who are not in the room and are joining us via the webcast, the link should be displayed in the link in the chat box. If you go to the chat box, there should be a link there to access this portal. Many of the polling questions that we'll get kicked off with and throughout the sessions, we'll ask you to choose questions about how you perceive priority issues or barriers to opioid use disorder treatment. And we understand that for some of these questions, there actually might be more than one answer. But bear with us. Just pick the one that that is most important for those, because I don't think we are able to have multiple answers. So go ahead and pick the one that best applies. And then I think what we're going to do right now is to kick things off with the very first polling question. Hopefully you in the room and online have accessed that site. So our first question, we know that the opioid use disorder is an issue that unites people across the country. And we know that many are coming to this conversation with a wide variety of perspectives and disciplines to help give us a sense of who's joining us online and in the room. We ask you to answer this first question, which is, which statement best describes you? The choices are healthcare provider, another professional who offers counseling or behavioral health services. C is a peer recovery support specialist or recovery advocate. D is I'm a patient, caregiver, or advocate for people with OUD, opioid use disorder. I'm a part of an organization interested in opioid use disorder treatment, government, community organizations, healthcare organizations, payers, academia, and so forth, or other. So I'm going to spend a little bit of time for you to go ahead and answer, and I think the results will be popping up automatically, or there they are. Okay, wonderful. We'll give a few more minutes for those of you to answer. Okay, well, this is Washington, D.C., so I suspect that second to last, any other organization that's interested in this topic would include policy folks, I think much of our Duke Margolis staff would be in there. But we do see a swath of perspectives that are joining us for this conversation today. You can expect more of these kinds of questions throughout the day on issues that are most important to you all. During the sessions, we'll also have designated time for Q&A. For those in the room, you can we're going to have microphones on each end of the seating, so you can go ahead and toward the ends of each session, line up there, and the moderator will get to you to engage with the panelists and others in the room. For those joining via the webcast, feel free to submit any questions throughout the day using the chat box. Our staff will relay those questions to the moderator. To keep things running smoothly, we will ask that you keep any questions and comments short so that the panel has time to get through as many questions and comments that you all bring as possible. Feel free to help yourself to coffee and beverages throughout the day, which are located right outside of this room if you're here with us. Lastly, lunch will be on your own. There are many restaurants nearby that our staff can help provide a list to you for some of those. And then with that, I'd like to ask Mark to come back up to introduce Dr. Woodcock. Thank you.
Greg, thanks very much, and thanks to all of you for participating in the polling as well as the rest of the event. I am very pleased to introduce Dr. Janet Woodcock, the Director of the Center for Drug Evaluation and Research at FDA. There, Dr. Research not only directs the center, but has also been the moving force behind a wide range of initiatives to advance the critical path of developing and using new medications and other medications effectively, ranging from the pre-market and even pre-human setting to all the way up to more effective post-market use of medications to meet the goal of safe and effective drugs that are available to improve the health of all people in the United States. Janet, we look forward to hearing more about these issues and how FDA is leading many efforts to expand development and access to medications for the treatment of opioid use disorder. Thank you.
Thanks very much, Mark, and good morning, everyone. I'm really happy that we're having this meeting. I thank Duke Margolis for really putting it on, and hope that we can move this forward. You know, the epidemic of opioid misuse ongoing in this country is a really multifaceted problem, as you all know. FDA, and in conjunction with HHS and many other government agencies, state, local, and so forth, have been pursuing multi-part strategies for mitigation because there's not going to be a single solution to this, and it's going to take time. A major effort at FDA has been to decrease the number of people who actually develop opioid use disorder by reducing population exposure to prescription opioids, which was clearly one of the initiating factors for this. At the peak of prescribing trends in about 2014, around 240 million outpatient prescriptions were dispensed for opioids in this country. And clearly, that's an excessive amount. The proper amount is not really known, but that has come down since, but probably not enough. And people, when they get a dispensed prescription, are still getting many more tablets than we've seen are needed post-operative or post-procedure for most of the people. And so adding up to millions of units that are available for misuse and diversion that are in the medicine cabinets of Americans still. So we have to do more to reduce exposure of the population to opioids, which is a big initiating factor. But even if we can dramatically slow the rate of people developing opioid use disorder, we still have millions of Americans with established disease now. And for them, our goal has been to make effective and safe medication available to treat withdrawal and to prevent relapse. And of course, as Mark said, a number of these are on the market. Now, these are most effective when dispensed as part of a multidisciplinary strategy to deal with each individual's situation and their root causes for having an opioid use disorder in the first place. And the marketed treatments are not ideal. Many people relapse. There can be tolerability issues of various kinds. But the major problem, the subject of this meeting, is that medical treatment is often not even tried in opioid use disorder, as Mark just said. And if you step back and think about it, failure to attempt medical treatment for a disease that is often fatal, that's not something you see very often in medical care, where the major issue is failure to attempt treatment for a often fatal disease. And you don't see that much outside of addiction. In most other fatal diseases, we, the medical community, step in and we attempt to treat these folk. Now, how could this be? Well, many of the barriers to effective treatment have been enumerated numerous times. People have talked about them. There are restrictions on prescribing. There's a lack of physician training and familiarity. We don't have enough physicians who know how to intervene appropriately. That's been well documented. There's stigma, and that's a lot of it. There's reimbursement problems and so forth. And probably there are not enough trained personnel of all the different kinds that need to help intervene when we have such a large number of people in this country with a potentially fatal illness. So today we'd like to explore the barriers in more depth and try to get from the community and the experts really what are these barriers, what could be done to mitigate these barriers, how can we move this forward. And so I'm not going to talk about that more because that's the subject of this meeting. I will say, though, FDA is also working with drug sponsors to develop additional treatment options for opioid use disorder. Because one of the barriers is we don't have a lot of convenient, highly well tolerated, we don't have a range of treatments for people. We recently issued draft guidance on endpoints, sort of a pathway for sponsors to develop new treatments for medication-assisted therapy. And we hope to finalize that guidance and hopefully attract more sponsors into this area. The field has not been very attractive for developers over the years, as you all know. And so although we have safe and effective treatments, we have a limited range. And I think if one thing would be the case in a disease like this, we need a range of options that are convenient, that are effective, that have different properties. People have many different pathways to developing substance use disorders, and they're going to need different types of interventions. And that's true in many diseases that we treat with medication. So understanding the needs of people with the disease is a central part of what we call patient-focused drug development. And so we have starting about 6 years ago, actually having meetings with patients, day-long meetings. And you're going to hear about one we had with opioid use disorder patients from Dr. Sarah Eggers. But these meetings have been very impactful in understanding that the medical constructs that we often use to do trials and create endpoints don't take into account really the needs of the patients, both on the burden of disease, the burden of treatment, and also often the trials don't fit in with what the patient's needs are to actually enable them to participate. So as a result of those meetings we have started a very large program that was initiated under the 21st Century Cures Act and so forth, where we will be, and the Prescription Drug User Fee Act, where we will be putting out a whole series of guidances on how to collect valid and reliable information from patients about what they care about in the disease, what matters to them about treatment, what they want to have treated, what are the most burdensome side effects and so forth, what are their trade-offs between benefit and risk, how do they calculate that as the people who actually have to assume the risks. So this, and we also, in this meeting, in this community, we need to hear from the providers, because I think unique in addiction, and one of the barriers is there are additional burdens on providers of care, and we need to understand that better, and hopefully we can through meetings like this, and then hopefully develop therapies that can ease these burdens both on the providers of care and on the patient, so that more people can utilize proven effective therapy. So I hope both the increased use of medication-assisted therapy and development of additional choices and modalities that meets the needs of patients' prescribers can be something that one of the outputs of this meeting that will help us as we craft pathways, regulatory pathways to develop more therapies. So thank you all very much for this coming and helping us address this really devastating epidemic. Thank you.
Janet, thank you very much. Now I'd like to introduce Admiral Brett Giroir, the Assistant Secretary for Health at the U.S. Department of Health and Human Services. For those of you who aren't familiar with the Assistant Secretary for Health job, this is a big job with a wide scope of responsibilities related to protecting and improving the health of the public. And reflecting the importance of the opioid crisis, Admiral Giroir is probably best known for leading the development of the HHS-wide public health policy recommendations and other activities overseeing 11 core public health offices to protect and advance the health and safety of our nation related to the opioid crisis. In addition, Admiral Giroir serves as the senior advisor to the Secretary of HHS for opioid policy and is responsible for coordinating these efforts all across the administration to fight the opioid crisis. His efforts have been critical. He's been right at the middle of all of the activities related to opioids, and we're very pleased to welcome him here today. Admiral.
So thank you, Dr. McClellan. I'd like to thank the FDA and the Duke Center for inviting me here this morning. It really is a pleasure to be here this morning. It's also good to be right after everyone has had coffee and are wide awake and ready to go. So I do look forward to giving you an overview of where we are. As Dr. McClellan said, when I came here to DC, I expected to be the ASH, the Assistant Secretary for Health, with all those responsibilities. About 6 weeks later, the Secretary organized the department around 4 major priorities, and he put a single lead in for each of those priorities. So I am the senior advisor for opioid policy, meaning I should be your principal point of contact to get into HHS, but also I'm responsible for coordinating and making sure there's synergism across a $1.5 trillion agency as diverse as the Indian Health Service, the FDA, CMS, and how we can all work together. All these slides are going to be available to you, so I'm going to go through them pretty quickly. Don't worry about taking notes. These are all public release and available. So I want to start out to level set where we are, because you hear a lot of numbers back and forth. On the graph slide, this is what was recently reported about a month ago as the final 2017 numbers for substance abuse, overdose deaths, and opioids. So in 2017, there were 72,287 deaths, staggering amounts. The predominant number of those were from opioids. So I want to give you sort of a different cut so you know where we are and you know where to follow. Each month, the National Center for Vital Statistics puts out the rolling 12-month mortality rates, including the overall death rate and that for many of the subclasses. What you see on the left side of the chart is the rolling 12 months from February 2017 to February 2018, which is really our most up-to-date data. It is 6 months behind. It is 99.8% complete, but still, even 6 months later, there are 0.2% of fatalities that have not been classified. The CDC uses an algorithm to predict what the actual remainder of those 0.2% are. So where we are, the latest statistics is there were 71,414 deaths. Those are predominantly opioids. It's up 5.1% from the previous year, and the overdose deaths due to opioids increased 6.3% from the previous year. So again, we are in the midst of the greatest public health crisis of our time. It is substance abuse, and it's driven primarily by opioids. This is the latest map. I advise you to go there. If your state is in blue, you are improving. In other words, your death rate is going down year to year from that 12-month period. If you're in yellow, you are increasing. And if you're in orange, you're in the throes of a major increase still as we go on. Again, 6 months behind time, but this is our latest data in terms of mortality. Now, if you look at that, it's very interesting to see where the trends are. We want to talk about opioids, and that is important. But if you look at the mortality year to year, the actual mortality due to heroin actually decreased about 5%. The natural and semi-synthetics, which really are the pharmaceutical agents primarily, the OxyContins, et cetera, are down about 4%. Methadone down 6%, but our big increases are really in the synthetic opioids. This is the fentanyl, this is the carfentanil primarily that is being imported primarily in the international mail via China, either directly to the United States or to Mexico and smuggled across the border. That's up 31%. Don't forget about cocaine. Cocaine is up 24% with 14,500 deaths associated with that. We see a lot of troubling statistics, particularly in pregnant women, and I'll go over that. And finally, the psychostimulants. This is meth primarily, but a number of other things put in there, again, up. So we have problems across the board. It's clearly fentanyl driving a lot of this, but don't forget cocaine, meth, and the psychostimulants. I pulled this out of the paper to give you an idea of the problem. I'm a pediatric critical care physician by training. Fentanyl was only allowed to be used in our hospital system if you were a critical care physician or you were an anesthesiologist in the OR. That's the respect we have for this drug. But now you see on the streets, just by good policing in Nebraska, there was 118 pounds of fentanyl just seized in this one arrest, which is enough to kill 26 million people. And that's just by good policing in a truck in Nebraska. So this is a major, major issue. The FDA, I know, is teaming up with Customs and Border Patrol in a very synergistic way to try to monitor the international mail and do everything they can. Because our job is tough. It's going to be even tougher if we have shipments that kill a tenth or a quarter of the U.S. population strictly in a single car. So what are the latest statistics? This is out of NISDA, and I can't see that back monitor, so I'm going to kind of turn around a little bit. Dr. McClellan talked to you about this, but the latest statistics from the National Survey of Drug Use and Health, published last Friday, it's on the web, and I'm going to give you a lot of statistics, is that there are 11.4 million people who misused opioids in the past year. 11.1 of those are pain relievers. Now, misuse is defined as any use that is not indicated by your physician. So if you're using it more frequently, if you're using it more, if you don't have a prescription and you use someone else's, it all goes into the misuse category. 886,000 people used heroin and 562,000 used both. 2.1 million people had an opioid use disorder. So not just a misuse, but a DSM-5 classification of an opioid use disorder, with about 1.7 million of those to pain relievers, 0.7 million to heroin. Now, very interestingly, still 53% obtain their last pain reliever from a friend or relative. So this is not you getting prescribed the drug, but you're getting it out of the medicine cabinet, or someone saying you're having trouble sleeping, please use some of this. That we have a major issue in education we still have to overcome. 36% came from a healthcare provider, and if you look at the sub-statistics, very few are doctor shopping anymore. I think the PDMPs have sort of clamped down on that. It's usually a single doctor that predominates with that. And I highlight this because it's not highlighted enough. The main reason for opioid misuse is pain. 62.6% of people said they misused it for pain. If we don't solve the pain crisis in our country, we don't develop new therapies that are non-opioid, that are non-addictive, or use adjunctive pain therapies, we are not going to get out of this crisis. And so we are very focused at HHS, not just on opioid misuse, but on the flip side, how do we solve the pain crisis? I am also very concerned, and I know that's not necessarily the topic here, but we have an astronomical rise in hepatitis C cases, primarily associated with IV drug abuse, probably a 300% increase over the past 5 years. We don't have good data to know exactly how much, but based on CD trends, that's it. HIV, we flattened across the board at about 38,500 cases, but we're seeing an increase in HIV among IV drug abusers. So all the progress we've made, we're actually at an inflection point that we can see that rate going up again in the United States. Very concerned about that. If you're in a hospital system, I know you're seeing a lot more things that we used to see back in the 80s, endocarditis from IV drug abuse, skin and soft tissue infections, and of course, the bugs are a lot meaner now because they're resistant to just about everything. So very, very difficult on the hospital systems. As a pediatric critical care physician, I'm very concerned about neonatal abstinence syndrome. This is a very important part about treatment because pregnant mothers need MAT treatment in order to stabilize their pregnancy, in order to avoid lots of the problems we see in the babies. And although we talk about jittery babies who have diarrhea and all those issues, and that's very important, we don't talk about some of the problems of drug abuse in pregnancy, meaning you have a 25-weeker or a 26-weeker. So prematurity, preterm birth, and preterm death is very, very important. And as we found out from some studies last month published in Pediatrics, independent of prematurity, independent of intrauterine growth retardation, all of that kind of stuff, it looks like babies who are exposed to opioids in utero have significant cognitive and psychosocial and executive function developmental delay. They're going to need lots of interventions in the school systems. I'm really concerned about this because the NISDA survey shows that drug use in pregnancy is going up substantially. From 2015 to 2017, illicit drug use went from 109,000 women up to 194,000 women using illicit drugs during pregnancy. Tobacco use and alcohol, let's not forget about that because those are still terrible for the moms and they're terrible for the babies. So what is HHS doing? I only have a short time here, so I'm going to run through a few things. I think all of you know our 5-point plan that overall describes the pillars. Strengthen public health data and reporting, very, very important. We have to know where the epidemic is. We have to know who's dying when so we could bring resources. We have to know trends that are going regionally so we could adequately respond. Advance the practice of pain management, very important. We have to decrease inappropriate use of opioids while preserving opioid use for those patients, particularly those who have intractable pain due to syndromes like multiple myeloma, cancer pain, sickle cell disease patients who need it intermittently while we're looking for other alternatives. Improve access to prevention, treatment, and recovery, and we have focused on this probably more than anything, and I'll give you a few examples, and we absolutely support medication-assisted treatment as an evidence-based essential component of therapy for people with opioid use disorder, whether that be naltrexone, buprenorphine, methadone. They're right for different classes of people at different times in their recovery cycle, but we are absolutely supportive of that 100%. Enhance the availability of reversing medications. Naloxone primarily doesn't cure your disease, but it does absolutely give you a second chance at life. Finally, supporting cutting-edge research. So yesterday, actually on Monday, this is something out of my group, we published about 90 sub-strategies to those 5 strategies, and what we really did is took about the 700 efforts that are ongoing within HHS right now, understood where they fit strategically under the pillars, and then iterated that specifically. It's kind of a geeky, wonky document, perfect for an academic center who's looking at policy, but this really outlines where we are in much more detail than the 5-point strategy. My internal goal, everybody asks me what success is. The Secretary asked me for what success is. This is not the administration's position. This is not the President's position. This is my position, is that my goal is to reduce drug overdose mortality in the United States by 15% by January 2021 from November 2017. There are a lot of other appropriate goals, but if we don't reduce mortality, save more people, give parents back their children, give brothers back their sisters, we are not going to be able to declare even an intermittent victory. So I am really focused on this as at least one of our goals. So we have lots of positive signs, at least since 2017. The number of opioid prescriptions have been reduced by 17%. If you look at morphine milligram equivalents, that's down by 21% by all the efforts we're doing, by FDA, by the CDC guidelines, by awareness, by PDMPs, by all the things we are doing. And actually, we are on the line to meet President Trump's goal of reducing by 30% by the end of his term. But again, we don't want to throw the baby out with the bathwater. We want to make sure that those who need opioids or prescription medications get them while we're reducing inappropriate prescriptions. Since January 2017, the number of unique patients receiving buprenorphine monthly is up by 16%. Again, this matches the NSDA data of 100,000 more people in treatment. And since 2017, the number of naloxone prescriptions dispensed have been up by 264%. Again, going in the right direction. If you look at the NSDA data, Dr. McClellan talked about this. In 2017, there were less and statistically significantly less pain reliever misusers and statistically significantly less people with pain reliever use disorder. Again, a very positive sign. And again, this is another geeky chart out of NSDA, but if you look at the top bar, that's the overall everybody 12 and older. This is new use initiates of heroin between 26 and 2017. We've had greater than a 50% drop in those first users of heroin. Again, very positive signs. Now, if you look at the 12-month overall rolling average, this is not 2017 compared to 2016, but this is looking at the number of deaths, the predicted number of deaths by the CDC on those 12-month increments. We are not claiming victory. We have a huge way to go because 71,000 deaths are too much. And again, this is 6 months behind. But I want to show this because people think this is a futile effort, that we're doing all this, but we're still losing. I think if you look at this curve, you can see that the overdose mortality is tending to flatten out, and some indications we have is that mortality is over the top and potentially going down. We're not going to let up for 1 second on trying to further treatment because 71,000 is too big of a number. But don't get fooled that what we're doing does not make a difference, because I think we're seeing a difference nationally. Things that are happening this week, and I'll finish up in the next 2 or 3 slides. This is heroin, Prescription Opioid Awareness and Heroin Week declared by the President. Yesterday we put out about $1.5 billion in grant awards. And related to this topic, I just want to say that the SAMHSA state-oriented response grants will reimburse for treatment, but we will only reimburse for treatment that offers MAT as part of their treatment program. It doesn't mean that every single center, like if you're in a faith-based organization, that you have to do it, but you have to be associated with another center and provide the meaningful opportunity for patients to get MAT. That's how important we believe it is. I also wanted to say, and I didn't put it up here, as we clarified guidance from DEA, and I put this out in a blog and we had many notices, that it is now acceptable to prescribe buprenorphine over telemedicine. What it requires is both people at the ends are registered with the DEA, but the person prescribing can have a waiver, but the person at the other end does not. So this is going to be a tremendous tool as we move to take care of people, particularly in rural areas, who do not have a waivered physician or prescriber to prescribe buprenorphine. The Surgeon General put out a report, just came out today. We've been working on that, Spotlight on Opioids. And I also wanted to announce that today the NIH is putting out, actually yesterday it was put out, a funding announcement for healing communities. This is a complete effort. It's going to be hundreds of millions of dollars over 5 years with the goal of taking highly affected communities and reducing overall mortality by 40% within 3 years. It's an all of government, all of local, all of state approach. We're very excited about that, and it's co-led by the NIH. Francis is working on this personally, as well as Nora Volkoff, together with SAMHSA, Dr. Ellie McCann's Katz. And just to let you know, we have our next pain interagency task force meeting next week. So very, very important because we need to solve the pain problem. This is DOD, VA, and HHS all working together. We invite public comment. Two last slides out of NISDA. Now this is not, well, one last slide out of NISDA and one out of the new literature. Now this struck me. Now when I talked to addiction specialists, they said this is not surprising at all. This is not specific to heroin or opioid use disorder, but across the board, 20.7 million people needed substance abuse treatment, but 94.3% who needed substance abuse treatment but did not receive specialty treatment did not think they needed it. So the number one reason why people are not getting treatment is because they don't believe we need it. This sort of opened my eyes to a whole nother educational, destigmatizing kind of campaign and work that we really need to do. Because no matter how many resources we pour into the system, if we can't help people get that on-ramp into treatment and convince them that they need it, we're not going to solve the problem. The second bit of information I will leave you with was published by Captain Chris Jones and Dr. Ellie McCants-Katz. It's online. It's not yet published. This is an addiction, September 8, 2018. What they did is survey, I think it was 6,000. They got 4,000 responses of people who had recently received their data waiver for prescribing. Now, it's not so recent that they couldn't have already had a portfolio of people, but they wanted to find out what are the main reasons that they are not prescribing or how are they prescribing. So only 75% had prescribed buprenorphine. So 1 out of 4 people who had received their waiver and could be prescribing buprenorphine had not even prescribed it yet. And if you look, clinicians prescribing at or near their limit was only 13.1%. Now this is important data. We may need to expand the prescribing limits for people in a specialty center who are bumping up against their limits. But what we're seeing here is there's still a lot of capacity in the system, particularly now that we have the telemedicine kind of buprenorphine, that we have to help physicians, clinicians prescribe. And the number one reason why they weren't prescribing is because there was a lack of patient demand. Patients are not coming into the system, which kind of matches very nicely with the NISDA data, but also time constraints in practice, insurance requirements, and just the difficulty of the patients. So this is a good article. Please pull that. So at the end of all this data, I do want to say, and I believe absolutely, and it was emphasized by Dr. McClellan, is success in recovery is possible. And it's made much more likely by safe and effective, proven medication-assisted treatment, which is the focus of this survey, of this meeting. On the left side, this is a little boy named Stetson. He is an NAS baby whose mom got into a medication-assisted treatment program, is in long-term recovery, and it's sort of life is good, happily ever after. So again, I hope this is the beginning of our conversation. If I can help in any way, I can be the single point of contact for you or your organizations to reach into HHS. And again, I really appreciate the opportunity to share some thoughts with you this morning. Thank you.
Good morning, everyone. My name is Sarah Eggers, and I'm in the U.S. Food and Drug Administration's CDER, Office of Program and Strategic Analysis. And as Dr. Woodcock mentioned, we conducted a patient-focused drug development on OUD, and I am delighted to be here today to share the insight of the people, the individuals who have OUD, who shared their experiences and perspectives with us, as well as the loved ones that care about individuals with OUD. The standard disclaimer applies, and it's even more fitting because I'm not trying to represent anyone today but the people who have the greatest stake in this issue, the few hundred people who engaged with us through this meeting. This meeting was an opportunity through our patient-focused drug development program, and Dr. Woodcock explained that very, very well. What started out as a commitment in the 2012 Prescription Drug User Fee Act, a commitment for FDA to conduct 20 meetings on 20 different disease areas has really blossomed into a multi-stakeholder effort to continue to engage patients and their loved ones and to develop more systematic methodologies to get patients' experiences, needs, priorities, and experiences captured meaningfully into drug development, into evaluation of those products, and into the appropriate use of those products. Okay. So on April 17th, we conducted a 6-hour meeting at our White Oak campus. The meeting was conducted both in person, there was a webcast, and we also had a docket open where people could submit, anyone could submit comments whether they attended the meeting or not. So we were really trying to engage as many people and reach them through whatever channels we could. This meeting was part of the larger and broader ongoing efforts that Dr. Woodcock described and really that we heard from the HHS at trying to facilitate the development of new treatments, new formulations of existing treatments, and then to facilitate the wider appropriate use of those treatments to help people with opioid use disorder. The meeting was supported enormously by the outreach and other efforts from our colleagues at NIDA and the many patient advocacy and community organizations that helped us really engage with a population that can be difficult to reach, that has needs and organizing buses or telling us what we would need to know to make sure that we were treating the participants with the most respect that we could. So we very much thank them. We heard from a spectrum of experiences from the individuals and families who came, and we were very encouraged by the strong turnout. We had over 100 individuals and family members. Over 85 provided input through the interactive website, webcast, and over 70 comments were submitted through our docket. The participants primarily were individuals with OUD, although we did have some family members who provided input, as well as individuals with OUD who are also caretakers of loved ones with OUD. These participants varied in age, race, and ethnicity, in their history of opioid use and stage of recovery. For example, people have been battling with a heroin addiction for more than 30 years, people who developed OUD following prescription use of medication, and people who started using recreationally pills within the last 10 years. So we really had a wide spectrum. We also had a spectrum of overarching perspectives on substance use. I mean, there were a lot of perspectives that we were capturing at this meeting. Our discussion was a town hall style, and we had 2 topics of priority. One was on experiences with the health effects and the impacts of OUD, and the second was experiences and perspectives on the approaches to treat OUD. For each of those topics, we had a kickoff panel of individuals who shared their stories. And then from that, we transitioned into a facilitated large group discussion, enabling anyone from the audience to participate. So we are now collating the input and pulling it all together from the various sources. Each of our meetings results in a patient-focused drug development Voice of the Patient report, which we put on our website. These reports really intend to capture participants' experiences and perspectives in their own words. And our report for this meeting is planned for release later this fall. So I'm going to now present a summary of select highlights from that report that I hope set the stage for the discussion today. And I'm very happy that we are able to provide this input now in the morning at the start of the discussion, because I think you'll hear things that will continue to come up throughout the day, and having the patient perspective captured is very important. Okay, so we first talked, and throughout the day, participants talked about how they got to where they were at this moment, their complex journeys of use, misuse, addiction, and recovery. They highlighted when they were in the severe OUD, being a prisoner to intense withdrawals, the drug sick as they termed it, the irritability, the skin crawls and spasms, and the obsession with getting the next hit, this all-consuming obsession. They also shared the devastating impacts more broadly to their jobs, their careers, their relationships, their well-being, and their safety. They highlighted the lasting impacts of OUD even in the various stages of recovery. This lasts forever, the scars, the insomnia that they feel, the urges, stigma, and the fear that they will be a prisoner again. I want to point out they had mixed perceptions about their risk of overdose, with many in the room saying that they really took to heart self-harm reduction or harm reduction techniques, always carried naloxone and always made sure they used single needle and all that. There were others who said, no, today is a different world, and I am not safe even if I use. And then there were, as illustrated in this bottom quote here, the interplay with the disease and their own sense of needing to take care of themselves, that this was brought up. There are other quotes that I've pulled here, just select quotes, to highlight how they spoke about the physical and social and physiological impacts, really in concrete terms, in ways that we might not describe them. So I think the quotes are very important. We were particularly interested in how they talk about what we called craving. They called it many different things. They used the term craving. They also used urges, fiending, obsession, etc. They talked about craving as being more than a physical craving for a substance that lasts well beyond the drug sick. And the feeling changes over the time. So in the beginning, it's this fight or flight to try to manage the fear of withdrawal. But over time, it can resurface with even the slightest trigger. And it was interesting that one parent indicated that while withdrawal is something that's easy to see and easy to wrap our minds around, the long-lasting craving is not, and that's something parents need to come to terms with. Here are a few quotes that illustrate this, but my mind telling me I need to manage anxiety, and this is how I will do it. The process of doing, of preparing, of consuming, it's all wrapped up there. It's not just the substance itself. And then another quote to illustrate that even 10 years into her recovery, when one participant goes to the ATM even today, that can hit the sense of what she felt when she was using and going to the ATM in the middle of the night. There was a lot of discussion about treatment goals, and overarching, they stress the need for an individualistic approach. This has been talked about previously, but they're saying this too. They had varying perspectives on the desired outcomes of treatment, and for some, abstinence and being in a long-term recovery is complete abstinence is their goal. But for others, they said that goal of complete abstinence is either not feasible or not desirable for them, and they want to focus better on controlling or managing their use. A common element for all of it was improved functioning, well-being, and safety, and so that was across the board. They also shared different views on the role of MAT, with some accepting the need to stay on it for the long term. Others hoping to detox off of it once they are stable, and some who said they do not see a role for MAT in their treatment. Illustrated by the bottom quote, we did hear this comment about exchanging the one addiction for another. But the top two quotes, I think, are the bigger picture, right? The goal to manage things the way that you can and the way that you need to, and facing that you have a disease. We did hear experiences with MAT, with some highlighting the benefits, controlling that rush or resisting the cravings and be able to regain life and functioning. The discussion touched a lot about the downsides. I'm going to get into the challenges and barriers in a minute, but the downsides being the intolerable side effects or the side effects that they have to take other medications to treat, the long-term need, and not addressing the underlying health issue that they face. Some participants did offer insight about why one treatment was worked for them at one point and then no longer, and then they switched to another. And so we did hear about that with some quotes here about, we did hear about methadone saving lives, but and we heard about what happens when they try to detox themselves. And then a quote that I think illustrates the need to continually reevaluate. Okay. They describe the challenges and barriers to MAT, lack of access. I'm not going to go into detail here, just to point out that they acknowledge these. Difficulty finding treatments, long wait times, prohibitive costs, the strict requirements, being kicked out if you do one thing wrong. One person said, if I hug someone, I can get kicked out. Unpleasant experiences or concerns about safety, stigma, the interplay with the withdrawal and craving, addressing comorbid pain and health needs at the same time, and their need to come to terms with the illness. Here's one quote saying, it took 8 weeks to get the appointment, and then when I did, I had to go out and score heroin in order to make it to the treatment facility. Again, these are their own, this is them speaking. Okay. They also gave insight, and I think this is important, about how to better help individuals, raising awareness, integrating MAT into primary care and holistic approaches, making it easier, reducing stigma, keep developing treatments or exploring the treatments, repurposing treatments that are out there. Don't forget the underlying cause of why they started using opioids in the first way, and really try to create situations of stability. Here are some quotes that illustrate that. All options should be on the table. We need to get rid of the stigma, and we need to recognize that individuals are in highly vulnerable states, and we need to help them where they are. So this input can help FDA and others, including here today, identify specific areas of unmet need, supporting medical development programs, informing understanding of how to best to assess the benefits of these potential treatments and how to conduct the benefit risk assessments, and then to facilitate wider and appropriate use of the medications. I also want to point out we had a meeting in July on chronic pain, and that meeting is, I think, as informative as the OUD. So for more information, please visit the website. And you can also email our team's website, or our email. So thank you very much for that.
Thank you, Sarah, for providing the insight that you're hearing directly from patients. We're going to move on. Understanding the biological basis of opioid use disorder and the clinical armamentarium of therapies for treating this disease is critical to our understanding of how we can advance evidence-based approaches. Our next two presenters will provide us with the basis for understanding the current state of knowledge on addiction and the clinical approaches for identification and assessment of opioid use disorder, as well as the evidence supporting the use of medications for the treatment of opioid use disorder. Please welcome to the stage Edwin Salsitz, attending physician at Beth Israel Medical Center, as well as Lisa Alexander, professor at George Washington School of Medicine and Health Sciences and president of the Physician Assistant Education Association.
Good morning, everyone, and I'd like to thank the organizers for inviting me, in particular Isha Sharma and Katie Green, in helping me with all my logistics. Thank you very much. So I'm going to talk, let me go back here for a minute. I'm going to touch on a couple of topics. Some of them will be talked about in more detail subsequently. I have no disclosures, no conflicts. Everything we're talking about today really starts with this beautiful plant that Mother Nature put on Earth, the opium poppy plant. This is growing someplace probably in Afghanistan. Has beautiful flowers. They bloom in the springtime, perennial hardy plant. You can see there's something called the unripened seed pod, which is on your left-hand side, lower left here. And if you cut into the unripened seed pod, you get opium. and opium contains morphine, codeine, and a few other plant alkaloids. If you don't cut into the plant, let it ripen and shake it out, you get poppy seeds. And some poppy seeds can produce a positive urine drug test for morphine and codeine. In talking about treatment of opioid use disorder, we have to mention some very important names, and the two most important names are Dr. Dole and Niswander. Dr. Dole was a research metabolic physician at Rockefeller University, and Dr. Niswander was a psychiatrist trying to help opiate-addicted people in the 50s and the 60s in New York City, working in Harlem. They started studying methadone for the treatment of opioid use disorder in the early 60s, and they were joined by Dr. Mary Jean Creek, who is currently the chief of the addiction laboratory at Rockefeller. And they had a couple of interesting observations. Dr. Dole said that the reason the heroin-addicted folks were relapsing all the time was that their brains lacked something that the heroin provided. This was 10 years before the endorphins were discovered. And what Dr. Niswander observed in trying to treat patients, she says, you know, they seem to function better when they're on heroin than when they're trying not to be on heroin. And these, again, may not sound like much 53 years later, but these were valuable insights way back when. And here was the first paper that they published on the treatment with methadone. Only 22 patients, but results like this had never been seen. People were doing well. They stopped craving other opioids. They stopped relapsing. And the focus, though, was on getting them jobs, getting them a GED if they didn't have it, getting them to a job interview, providing them with clothing to go to that interview. In other words, the methadone was supposed to be a means to an end, and the end was improving function and rehabilitation. The big thing on that title slide is a medical treatment. 53 years ago, nobody thought of addiction as a medical disease or a medical problem with any sort of usual medical solution. It was a character problem, it was a criminal diathesis problem, but it wasn't a medical problem. And that was really the big breakthrough, I think, of Dole and Niswander, saying, yeah, this is like diabetes and it can be looked at that way and treated that way. So a little bit about the neurobiology, the sagittal section of the human brain, looking at a blown-up version of, I'll call it the limbic system and the prefrontal cortex, frontal cortex, a dopaminergic rich part of the brain. And we're not going to talk in detail about this, but in a broad general way, the nucleus accumbens and dopamine levels in the nucleus accumbens play a key role in how addiction works in the brain. And this is a slide from Dr. Elliot Gardner, who's at NIDA, and I learned my neurobiology from him. This is the rat brain, and rats and humans have very similar areas of the brain that are involved with addiction. And the only reason I wanted to show this today is that when it says the word opioids in red, those are endorphins, there are dynorphins and enkephalins, so we make our own opioids, the endogenous opioid system. And I think one of the thoughts that Dr. Dole had was that after many years of short-acting opiate use like heroin or oxycodone, the endogenous system may be disrupted, and that the methadone or the buprenorphine, now being a long-acting medication sitting on the receptor, would normalize and stabilize the brain. And those were the key words that he used all the time, normalize and stabilize the brain. And he felt that until that normalization and stabilization occurred, rehabilitation was not going to be possible. This study came out almost 20 years ago. It uses a technique called phosphorus MR spectroscopy. And again, maybe, well, I don't know, I can't do it that well because there's no mouse. But the white boxes are normal controls. The box in the middle are people who have been on methadone for approximately, I think, 150 weeks or so. And the ones all the way over on the other side in the darker gray are people who have been on methadone for 37 weeks. And this technique is trying to look at certain brain metabolite levels, reflecting brain bioenergetic status and brain cell membrane integrity. And again, without going into a lot of detail, you can see that as the patients stay on methadone longer, the middle row, they more closely resemble the controls than the people who have been on it less long. And as a matter of fact, in the bottom two boxes, there is no difference now between the longer-term methadone patients and the controls in terms of some of these brain bioenergetic molecules. And again, the idea here would be, what the authors say is that the nearly normal metabolite profile in long-term methadone subjects should suggest that prolonged methadone maintenance may be associated with improved neurochemistry. This was exactly what Dole was saying, but the science wasn't there yet. The techniques weren't available to show that. In other words, people think that methadone, they don't understand the mechanism of action, but the mechanism of action is to ameliorate the perturbations caused by long-acting, usually short-term opioid addiction. And another study that was done in Philadelphia, 25 patients, been on methadone for about 4.5 years, adequate doses. They would come into the clinic, and at the trough level, before they got their dose, they were shown some heroin cues. They wanted to cue-induce craving. They showed them needles, they showed them powder, they showed them people injecting. And before they got their dose, when the methadone was at the lowest level, that's the top line, you can see a lot of orange. That's lighting up in different areas of the limbic system. And they also, on the craving scoring curve from 0 to 9, had increased craving. When they then got their dose of methadone, and the study was repeated 2 to 3 hours at the peak level of the methadone, there was much less activation in those parts of the brain that subserve craving and addiction when they were shown those cues, and they scored lower on the craving scale. So this points out two things. Points out that methadone is actually working and doing something good in the brain, but it also shows that even people who have been on methadone for 4.5 years still are likely or liable to get craving in the right situation, and they need to be protected by continuing to take their methadone. And that when people go off methadone, they are more vulnerable to relapse. Anyway, vulnerability to addiction, the usual genetic and environment combination. Culture plays a big part in addiction liability, so does stress, and social determinants, or what the Lancet calls syndemics, are really a big part of what goes on in addiction medicine. I'm sure other speakers will talk about it today. There are other things there called exaggerated responses. I like to ask people, what does it feel like the first few times you use an opioid? And you get this verbatim response: I felt like the world was perfect under a warm blanket. And if you like an opioid and it energizes you, you are vulnerable to opioid addiction. Most people don't like opioids. They get nauseous, dizzy, they throw up. But just liking an opioid makes you vulnerable. But ask people this question: what does it feel like the first few times? This is a slide on sexual abuse in women, and showing that depending on the type of sexual abuse, there are different risk ratios or odds ratios of developing a drug or alcohol dependence and some psychiatric problems. We all know how harmful sexual abuse can be. Besides patient vulnerability, it occurred to me that in this epidemic of prescription opioid prescribing, where it quadrupled in 10 years, there was also prescriber vulnerability, where we thought this was a reasonable thing to do based on a perfect storm that occurred. Opiate agonist therapy is complicated because not only does it involve knowing the disease you're treating and the pharmacology of the agents you're using, but it involves issues that don't come up in the rest of medicine: stigma, regulatory issues, the political things around methadone and buprenorphine, and also destitution or severe psychosocial problems. Stigma. My wife's opinion is that methadone maintenance treatment is as close to evil as you can get without killing someone. This is one of my long-term methadone patients, doing well, no problems, paying taxes, the whole thing, and I can't convince her otherwise. Saturday Night Live, Seth Meyers. This is the Christmas show a number of years ago. So Seth Meyers says to Mrs. Claus, "You must be excited to see him when he comes back." Mrs. Claus: "By the time he stumbles in at 6 a.m., Chris has eaten roughly 2 billion cookies, so he pukes for a solid day." She continues, "He then spends a week in a methadone clinic to come down from the sugar high." This is coming out of nowhere on a Saturday night, and I think about my patient sitting there with his wife and kids, doing well, successful, and they need that like they need a hole in their head. I've written to Saturday Night Live and I haven't gotten any response, but this is done all the time with the concept that being on methadone is futile, you're an idiot, it's going nowhere. Time magazine, 20 years ago, beautiful article about neurobiology of addiction, and we thought like, wow, what an advance this is, coming out of NIDA, the whole thing. Buprenorphine was in the development process. A few months later, they came out with their article about buprenorphine, and they called it a way out for junkies. There would be no way this could happen with any other medical disease. A pejorative term could be used, but there's no political correctness when it comes to the addiction space. Terminology, they use opioid substitution therapy in Europe and Australia. I think it's very misleading. It leads right into, well, aren't you substituting one addiction or one drug for another? Why can't we just call it, treating opioid use as sort of pharmacotherapy? Even MAT is a misnomer, because for many patients, it's not assisting the counseling, it is the treatment. And the people providing the medical management are doing excellent counseling, even though it's not called that because they're not psychiatrists, but they know what they're doing. And in many studies, you don't see added improvement with counseling. This is an important one. Physical dependence does not necessarily equal addiction. People who are doing well on methadone and buprenorphine are not addicted to it. They're physically dependent but not addicted. Really important for the patient, and more importantly for the significant other, to believe that. How long should people stay on this medication? If you look at the evidence over the last 50-odd years, the answer is indefinitely. Just like with hypertension, diabetes, asthma, the relapse rates are high when you get off. I've had people on methadone in my own practice for up to 50 years now, some of the original Dole Nice-Wanda people. They're doing well, haven't seen any big organ problems or any other medical issues that have come up. All treatments work for some patients. No one treatment works for everyone. A problem in addiction medicine is repeating the same treatment over and over again, even though it doesn't work, without switching to a different form of treatment. Why is all of this so important? Philip Seymour Hoffman. He was a very successful AA patient for many years. He'd have years of sobriety, go back to AA, and he was very into AA and a very good member. But he had this severe relapse a couple of years ago. It involved heroin. He was found with a needle in his arm, heroin on the postmortem toxicology. He died. I wonder if I could ask him now, do you think it would have been better off on buprenorphine than trying to be abstinent? Maybe that would have been a better strategy. He has a wife and 2 kids. So that's why this is all so important. Thank you very much.
Thanks so much, Ed. Good morning, everyone. Thank you so much for being here, and thank you for the kind invitation to participate. I certainly think that all of the topics that we're covering today are extremely important, and I think the materials that have been presented and prepared for you in preparation in conjunction with the meeting are absolutely essential. Much of what I'm going to cover this morning is repeated in some of the materials that you have with you, and as I believe I said earlier, we heard that the slides will be available. Just a little bit about my background. I am a primary care physician assistant. I am an educator. I've been a PA for almost 40 years, so I'm one of the very, very early PAs, and I've had a career in primary care. As we saw in the original poll that we did earlier, I think about 1 in 5 right now in this audience are clinicians. And so what I'll try to do today is not make this an overly heavy talk using a lot of pharmacology and clinical terms, but I do think that some of it is necessary to understand the scope of the illness and the treatment. So as a starting point, let's think about the why. Ask ourselves, why are we doing this? We know that the use of opioid agonists to treat OUD have been studied extensively, and they are generally accepted as standard medical practice. They're highly effective, and it must be remembered, however, that it is just not a pill. It is just not a treatment that you go into a program and are treated like Ed talked about for many, many years with a particular agent. It has to be part of a continuum of care. As clinical providers or public health folks, we must take steps to make sure that there's prevention, there's screening activities, there's treatment, and there's follow-up. This is a continuum of care. The mu opioid agonists shown on the slide methadone and buprenorphine address the two top objectives. The long half-life, as we know for methadone and buprenorphine, contribute to that third objective of the opioid blockade. Naltrexone, on the other hand, is an antagonist, a mu-opioid antagonist. So it's been demonstrated to reduce cravings and block the effects of these illicit opioids. So when used in an integrated approach, I think we can all agree behavioral health is an essential component. MAT significantly reduces the morbidity and the mortality, and I'll show you some of the evidence. But before we do that, a little basic review of pharmacology. If my students knew that I was going to cover pharmacology of opioid treatment in about 2 minutes, they would say, I'll go to that lecture. So when we think about the pharmacology, we think about methadone, buprenorphine, and naltrexone, as we've heard. So the daily dosing of methadone is in supervised settings. These are supervised settings that have wraparound services, if you will, and they're regulated at the federal and the local level by a set of standards that are absolutely essential. Methadone's also on the WHO's list of essential medications, and it is a synthetic opioid, as we know, with a long half-life. The buprenorphine is only a partial opioid agonist that has a ceiling effect different than methadone, but it is combined with a naloxone antagonist to essentially serve as a diversion strategy for illicit use. The available treatment programs are not as controlled. As we see, we are trying to get more primary care providers as prescribers for buprenorphine so that it increases access to treatment for those patients who would be seen as suitable for this particular strategy. And it does require a special training, as we'll talk about in a little while, regarding the DATA 2000 waivers. So the last one, naltrexone, is a full opioid receptor antagonist. And again, it's available in, through treatment programs and outpatient settings. No special training is required for this particular agent. So that was the basic pharmacology. Now we're going to talk about the evidence. So a recent PubMed search revealed about almost 1,000 studies that looked at the big three, if you will, the methadone, buprenorphine, and naltrexone. And this is a substantial and extensive evidence base from which to draw conclusions related to the effectiveness of these therapies. So I think we can agree that these, the depth of clinical evidence is there, and yet we still have so many barriers, whether it's stigma, access, and we can get into those in a little while. Specifically with methadone, the systematic reviews demonstrate the following: improved retention in treatment, reduced levels of criminality, reduced rates of injection drug use, which is so important because it then impacts the bloodborne disease transmission, which is essential from a public health and clinical standpoint. So in this country, there's approximately 1,600 opiate treatment programs nationwide caring for approximately 350,000 patients. So this ranges from no clinics in Wyoming to approximately 150 clinics in California. So the structured nature of these opiate treatment programs serve a tremendous purpose, and that purpose is the structure. The structure of directed observed treatment, along with incredible psychosocial wraparound services that are essential in the recovery of individuals with OUD. However, there are some studies that have been done in this country that have studied the feasibility of whether or not a patient can then maybe migrate to community-based methadone care without that structure of a sanctioned program like they do in the UK and in Canada. So this, I think, would be an area to explore as well, especially for patients who have achieved a level of stability in their life. So the next systematic review that has demonstrated the effectiveness of buprenorphine, the evidence demonstrates the following. It increases time in treatment, reduces illicit opioid use, and reduces the use of other illicit substances. But what you know is that the prescription practices for buprenorphine are controlled by specific training. And so I'll just get to this real quick. We all know physicians who are not trained in addiction psychiatry or haven't gone through the fellowship. They have to do an 8-hour program so that they are allowed to prescribe. PAs and nurse practitioners were given a time-limited waiver, time-limited eligibility for the waiver, and we now have a large number of PAs and nurse practitioners who are prescribing buprenorphine. Their training is higher. They have to do an additional 16 hours. And so I think that is an incredible augmentation to the pipeline of providers. We would, PAEA, myself as a practicing PA, would advocate for this to be a permanent waiver eligibility process and not just one that was piloted. So the last is naltrexone. Systematic reviews demonstrate that it assists in maintaining abstinence from illicit opioids, and also it significantly reduces the cravings, and we know that naltrexone does not alleviate the physical withdrawal symptoms. So naturally, with any drug therapy, there are always risks. I'd suggest that you review a British Medical Journal article from 2017 that talked about mortality associated with treatment for OUD. One of the, I think it was the editorial for that particular study used the phrase, the golden month. Okay, so in methadone treatment, the highest risk of mortality is in the first 4 weeks. So for clinicians, like we think about sepsis and the golden 6 hours of getting patients into treatment, it's the same for methadone. So treatment risks for mortality is always in the first 4 weeks of treatment during that induction phase, but also the first 4 weeks after patients unfortunately leave treatment. You'll be able to review these slides, but we can talk about long QT syndrome, but it's a relatively low risk unless patients are taking other medications that convey a similar risk. And then the one risk that often isn't talked about is diversion risk, and that's because we reduce that risk by directly observed treatment programs, as I mentioned earlier. And so in summary, when used in appropriately selected patients, we know that all 3 medications approved for MAT are effective at preventing relapse to illicit opioid use and also are increasing retention to treatment. And like any treatment, for any chronic relapsing illness, we need to individualize that therapy. And so I would echo what some of our other speakers have said, looking at the patient profile and what's going to work for them. And I'll share one very small anecdote. I teach students. One of my students went to a primary care setting down in a rural county in Maryland. He was working with the only buprenorphine provider in the county. He was impacted in a powerful way because he saw that there were no mental health providers in that community. So how could you prescribe buprenorphine without the services of trained psychologists? And he came back and shared his story with his colleagues, and it made a tremendous impact. So I think that as a PA, I'm all about the team, and I'm all about working collaboratively, and I think that these medications provide hope to patients, but we can't do it alone. So thank you very much.
All right, I'd like to thank Edwin and Lisa for those very informative presentations. Maybe you can take that back, Lisa, to your students and give them a much condensed course next time. I am very much looking forward to moderating this next session, which is going to feature experts who are currently leading innovative models of care. These models are in many cases combined with effective approaches for improving opioid use disorder screening and intervention, as well as these integrated treatment models, because screening, intervention, treatment, and support for recovery of opioid use disorder can occur in a variety of community and healthcare settings. We're also going to try in this session to identify lessons learned and address challenges to broader implementation that exists today. So we're going to start with brief remarks from each of our panelists, and we can keep those remarks tight. We're going to have time for a moderated discussion and some questions and answers time with the audience. That includes our online audience. So for those of you who are joining us online, if you have a question, please submit that, and we'll try to get to as many of those as possible too. Looking forward to an interesting discussion, but before that, I'd like to ask everyone to respond to our next polling question, which will close at the end of the panelist presentation. That question is, what is the biggest challenge for health systems and providers that would enable them to implement a coordinated approach to opioid use disorder treatment? And all of these have been raised as obstacles. I'm sure we'll talk about them during the session today, but we're asking you to pick a number one choice: need for additional evidence on which models work, need for additional funding resources, need for additional training or education, need for additional institutional support, need for regulatory or legal changes, or something else. So please go to the app. The instructions are on the screen if you're not still connected from earlier. And we'd like to ask you to pick the best one. We'll come back to this, tabulating the results after the remarks. So right now, though, I'd like to get to the panel, and I'd like to ask all of them to come on up and sit at the table so we can get going. First, you'll hear from Colleen LaBelle, the director of Boston Medical Center's Office-Based Addiction Treatment Program. Then Catherine Cates-Wessel, the chief executive officer of the American Academy of Addiction Psychiatry. Then Gail D'Onofrio, professor of emergency medicine and chair of the Department of Emergency Medicine at Yale Medicine. And then Ingvild Olsen, medical director at the Institute for Behavioral Resources at Reach Health Services. So Colleen, let me turn to you first.
Good morning. Thanks for having me today. It's a pleasure to be here with all of you. So I'm going to talk just a little bit on the utilization of a nurse care manager model in expanding access to buprenorphine and injectable naltrexone treatment in our office-based practices. I have no disclosures to report. So back in 2003, when buprenorphine was actually FDA approved and hit pharmacy shelves, we began looking at how do we do this, how do we get providers to take this on, because our patients are complicated. This is a complex treatment population. And so we looked at taking a nurse care manager model, integrating it into a primary care medical setting. What did that look like? That was a ability to make the nurse the glue person, that central person that would be there to take care of the patients, to provide all that complex care management wrapped around the provider who had the waiver to prescribe buprenorphine care, and an attempt meeting their social determinants of health and taking care of the whole person. So what does the nurse do? What did they do then, and what do they do now? It's that frequent follow-up, seeing that patient when and where they need to be seen, because the providers are not in care and in clinic all the time, providing care management, addressing pharmacy issues, prescription issues, doing that initial assessment, the education, the treatment consents and agreements, dealing with pregnancy and pain and criminal justice and Department of Children and Families, and their housing and their social supports and their insurance barriers and co-pays and the different issues that would happen. So that's essentially that nurse took on that piece, so sees the patients more frequently with the providers, as little or as much involved as they want to be in the care of that patient. So when we integrated it into other settings, sometimes that looked differently. So what happened is we did it in Boston, at Boston Medical Center. it actually worked extremely well. And then the state looked at this and said, wow, maybe we should look at expanding this into community health centers. So they put an RFR out to model our model into community health centers, with us doing the training and technical support for that model of care. So what happened initially when we did this in 2007, as an RFR went out and 14 health centers signed on, and over time that increased in small increments. It was really hard to get providers at that point to take this on and to want to treat those patients in their practice into a community setting. But over time, more RFRs went out and more folks got engaged, and people saw that this was a population they were taking care of. It made sense, and this provided wraparound services for the patient, as well as kept patients engaged in care and providers satisfied at the work they were doing. So now we're servicing 34 health centers across the state of Massachusetts that are funded under the Bureau. There's actually 43 health centers that have nurse care manager models, but some of them are funded by HRSA and other measures, so we don't collect data from them, but we do provide support to them. This cumulatively shows you the numbers of patients that have been serviced in the community health center since we started the grant in 2007, with 174 patients being serviced, and now greater than 16,000 patients in the community health centers in the state of Massachusetts. This is just, again, in the Department of Public Health funded sites, because that's the only sites we collect the data for them. So there are actually more patients being serviced. In doing this, we looked at utilization and outcomes in these OBAT sites. So this shows you patients in care less than 12 months, and then patients in care greater than 12 months. And the longer folks are in care, the more they're retained, the decreases in emergency room and hospitalizations that we've seen. So patients did better, they had less costly health outcomes. In addition, we saw decreases in positive urine toxicology screens, that being illicit, cocaine, as well as benzodiazepines. So again, the longer somebody was in care, the better they did, and the less likely they were to, in fact, have a positive urine. We also saw that patients stayed in care. Greater than 55% were in care at 12 months. Obviously, our goal is to keep people in care as long as we can, and we want to improve that, but we're able to keep folks in care utilizing this wraparound nurse care manager model. What also has happened is Massachusetts is now sharing our experiences, and we've been sharing them with the HRSA grants and helping other states get started through AHRQ, publishing our model in that system, where SAMHSA has dubbed it the Massachusetts model, and recently started a NIDA CTN clinical trial where this model is being implemented into 6 health systems across the country, and we're actually into the phase where we're actually just started enrolling patients. So again, others are looking at the different models, different systems work for folks depending on what resources one has. So again, we need to be flexible, we need to be open-minded, we need to change our systems of care, we need to address more harm reduction, helping folks engage in treatment when and where they appear. So we're continuing to evolve with what we're doing in our care and trying to figure out how do we get folks into care and how do we decrease those barriers. But the nurses are at many of these places where folks end up, given it's the largest healthcare system of providers, so utilizing them to the scope of their practice is a benefit to all of us. And so what makes things work? Models, systems of care, reimbursement, but the most important thing I think in my world is the people. This is my team that I am so fortunate to work with, and they were actually honored at the Boston Globe this year as the Salute to Nurses, but it's the people that are passionate, that are engaged, that want to do this treatment, that want to take care of patients, that truly make the difference. And patients today, it's that being treated by their healthcare team that treats them for their substance use is it's actually the most important thing to them in their lives. And that's it. Thank you.
Thank you very much.
Hi. First of all, I just want to say I feel humbled to be amongst this group. And I told Mitra, I'm not sure I'm the right person for this. But I do want to say also it is wonderful to hear everyone talking so openly and honestly about substance use disorders. I've been in the field for 30 years. It's been a long haul. So to hear people talking about all the integral things and how complex it is just very rewarding for me. So thank you for letting me be a part of this. So I'm a representative of the American Academy of Addiction Psychiatry, but even more so, I'm going to talk about two initiatives that we are part of, and it's not just our organization. We are the convener, we're the lead organization, working with a large majority of the people, everyone at this table, lots of other people in the audience. So I don't want to leave anyone out, so I just want to make sure I clarify that. I have nothing to disclose either. So the American Academy of Addiction Psychiatry is made up predominantly of psychiatrists who specialize in addictions, and that is our mission, to focus on evidence-based practices, looking at prevention, identification, and treatment of all substances, and looking at the impact of co-occurring mental disorders. And I want to emphasize that because more often than not, we don't talk about mental health. And so that's kind of our niche in the area that we're most interested in. Another thing that we're really focusing on is the need for collaboration. And I mean everybody. Our primary focus has been on health professionals, but we know it goes well beyond that. But we're trying to stay as much focused as possible. So when SAMHSA came out with an opportunity to bring teams together and to provide support system, we jumped on. We said, this is where we want to be. And so the model is called Providers Clinical Support System. Initially, it was called Physician Clinical Support System. And then from there, it went to Prescriber Clinical Support System. And actually, through our coalition and our steering committee, we went back to SAMHSA and we advocated and we said it's not just the physician, it's not just the prescriber, it has to be the full team. It's all about multidisciplinary. So just to give you a sense of the nature of our coalition, this is what it's about. So what we're about is more than just the MAT waiver training. We do provide that free of charge. Everything is free, free, free. If I don't remember to tell you, everything of this is provided free of charge. So we have all kinds of resources. Who is our target audience? All healthcare providers, anyone, not just the prescriber. It takes a full team, and so we really want to emphasize that. Who are our partner organizations? I'm not going to go through every single one of them, and you'll see why. And we feel very strongly. So we have all the major players in primary care. Who is the physician or the nurse going to go to? They're not going to come to addiction psychiatry. Trust me. You talk about stigma. They're not going to go to those people. They're going to go to their primary specialty. So the American Medical Association, the American Dental Association, the International Nurses Society on Addiction, the American College of Emergency Physicians. So we went out and we brought in all the addiction groups and the primary care groups, multidisciplinary too. So collectively, we represent over 1 million health professionals, a huge coalition, because we feel very strongly that's who people are going to listen to, and that's where they're going to go to get their information. And that's really important to hear that. So what do? We provide webinars. We provide online modules. We do the flipped class. We do podcast, we do mat chats, we do O-chats, we do anything you could possibly think of to try to make it easy for the health professional. They want to do this in the middle of the night when they can't sleep, okay, they can go online, they can pull it up. They want to participate in a live discussion, we can do that. So I think it's really important to be flexible, and that's a lot about what we're hearing is meeting people and organizations and approaches in where they are. You can't just say it's going to be like this and it's a cookie cutter for everybody. And so we recognize that and we want to make it flexible. We have a tremendous amount of resources online. If you have not gone to our website, please, please, please do not waste your resources and recreate the wheel. We have the best of the best in the field out there. So we have webinars, we have everything you could possibly want. We have also the other thing that's really big is our mentoring program. You can be matched up with an addiction specialist. You can be matched up with a pain specialist. You can be matched up with a primary care provider who's just been providing medications and knows how to treat people with opioid use disorders. It's all free. Did I mention that it's free? So I think it's really important to know these are resources that are already in play and available to everyone. So how much do we have? So just to give you some general statistics, we have a huge number of webinars and materials, over 600. We also have small group discussions. We find that health professionals tend to like to have clinical case discussions. And so those are private. They're up to 10 to 15 people on a call with an expert on a specific topic. The clinicians can provide a clinical case in advance, and then the expert can be prepared, and then they can discuss on the call, like a round table or a journal club that you would in a lot of other settings. That way they get that kind of one-on-one. So we try to do those probably twice a month. We have waiver trainings. Please, 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 do not pay for waiver training. It's all free through this grant. It's for nurse practitioners, it's for physician assistants, it's for physicians. We have 8-hour online, we have half and half, we have 8-hour live. So again, if you don't see what you need, let us know and we'll try to meet those needs as well. And then we have the mentoring program that continues to grow and makes it available to people. So again, a big part about PCSS is bringing collectively the resources together, the experts, and how can we bring what we all do best and make it as best for you as possible and easy for you as possible. So, okay, so we spent a lot of time training the individuals, okay, the support team, the prescribers, a lot of it's on the prescribers, but we also know there's a lot more involved. And so I call it connecting the dots. We need to go local. We need to find out what you're up against and what your challenges are. So another part of our initiative was an implementation project. We hear more and more. I'll have a doctor call me, take the waiver course, and they'll call and say, hey, Catherine, I got the waiver. Now what do I do? And I go, I don't know, what do you do? I mean, you do what you prescribe, you take care of the patients. But they don't really know how to get started because what? Their team doesn't know what to do. They're not really comfortable with the patient that has a substance use disorder. It's new to them. Their billing office doesn't know what kind of workflow. I mean, it's a systems issue. So how do I go back and practically apply this in my setting? Providers don't work in a vacuum. Their team needs to be on board. So we said, okay, well, why don't we go out and find out what we can do to help them? So we started out with 5 states. Don't ask me the criteria of how we decided there were 5 states because Inglewood is on one, Colleen is on a couple of them. And we looked at places that we had champions, addiction champions, and we knew that settings that we could work in easily to start out with. And so we chose 5 states. We're now in 7 states. And we went in and first thing we did is we identified one clinical site. They had to have the willingness to join effort with us. They bring on a multidisciplinary team, and we bring a technical assistance team into them, led by an addiction specialist. And the first thing we did is we did a needs assessment, looking at that local setting. What are your barriers? What are your strengths? What is it you're dealing with? And then how can we help you identify goals of how to overcome the barriers and how to expand the use of evidence-based practices in addition to the use of MAT. And I say that because a lot of people, particularly in community health centers, don't say you want to increase MAT. It's really about substance use. And if you don't get into the substance use disorder piece and just focus only on MAT, they're like, this is not going to work. But then the more they learn, the more they realize that they have to go beyond that. Here's an example of one in Pennsylvania that we did. They started out with a mentor on PCSS. They require all prescribers to take we have a core curriculum on pain. Every prescriber has to take the core curriculum. They have now gone from 2 clinics with 2 people prescribing, and now they've gone out to 12 clinics, and now they're integrating it into a large medical system. One of the prescribers, Dr. Peck, is a OBGYN. She says, I find this more rewarding than delivering babies. And I'm like, wow, that's huge. And they said this has been a tremendous asset to them to moving forward. So STR grant, I'm going to talk quickly, is a new grant that came out. We took the same model and we took the same coalition. Don't recreate the wheel, build on, enhance, expand what we've learned through PCSS, working with the Addiction Technology Transfer Center because they're already working in the states with the single state agencies, and we wanted to expand what we're doing. Again, huge number. I love coalitions. I love partners. Building on that, again, expanding and making use of what we already know. So everybody at the table is working with me on a lot of these. Thus far, within the first 60 days, we had to do a needs assessment of every state and territory in the country. The first 90 days, we had to have a system put in place with prevention, recovery, and treatment consultants in every state and territory in the country. World Peace is next. But right now, we've had over 200 and some requests, and that's not only from single state agencies with STR grants, but individuals. So it's really huge. We're getting a huge response from individuals, from a grandmother in Rhode Island who wants to start a program for other grandparents raising children whose parents have an opioid use disorder. So we have a huge opportunity there. Again, technical assistance is provided free of charge, so if you know anybody that needs technical assistance, go to STRTA and you can get that information. So workflow chart here, I just want to go through that there's a process that's new for the field. something to follow and track where things are from the request to finally completing the task. The other thing is we don't want to duplicate efforts. So if somebody comes in and they want a mentor, we don't recreate the wheel and pay for a mentor. We send them over to PCSS and say, hey, we have somebody who wants a mentor, and then we close them out of the other systems. So we're not wasting resources. Huge issue. We got a lot of things going on right now, but we want to make sure that we're using things effectively and filling gaps and not recreating the wheel. So I won't go through those. So anybody can put a request in across the projects. Local is key. That doesn't mean you have to be in the room with them, but you have to understand their needs. Stigma is huge, huge, huge. And I'm going to show briefly, if I have a second, a video that we did. SUD, the basics of understanding. That's a huge reason why primary care providers don't prescribe waiver. You tell me how to prescribe, but I really need to know how to manage this patient. I don't know the basics of substance use disorders. Collaboration is essential. Love, love, love. You have to. It's everybody. It involves everybody. MAT is more than just prescribing. Some people think, oh, you get the medication, you got naloxone on you, you're ready to go. Whoa, no, you're starting, but you're not quite there yet. So it's really important to know that. It's not just one medication, and different people need different things. So you have to look at the individual and focus on that, not just what is easiest for you to get out. Systems are needed. Simple, practical templates, business plans, charts are really, really important. Multidisciplinary team, one size doesn't fit all. Mental health cannot be ignored. It takes time, but it's vital to making real change. Together, we can make a difference. Now, I don't know if I have time to do the thing or not. Did I go over my time to show the? Okay. So we did a project on stigma, and it's talking about how we can get health professionals to feel good about working, because a lot of people say, well, I don't treat those patients. Those are not my patients. They're like, well, you have those patients, you just don't know it, and you're not treating them. So we wanted to show them kind of the reward, and maybe we won't, but we did. On the PCSS, there's a section on resources on educational, and it talks about stigma, and it talks about how rewarding it is to transform a person's life and how to be a part of that process. And so it's not a big deal. But if you go onto the website for PCSS, and see there are some videos from the patient's perspective of what it means to their recovery to have someone who cares about them, who's non-judgmental, and who welcomes them and treats them like any other patient and calls them by their first name. Tom Hill's a part of that. He's been very involved with us. We also have the health professional talking about how rewarding it is and how meaningful and how much they enjoy working with this population. So thank you very much.
Thank you.
My sort of first memory of it was being there as a nurse with 30 patients, all sick, in a line out the door waiting to be dosed with methadone.
It was quite frustrating because I didn't know how to deal with these men and women. There was a lot of guilt. I didn't know how to provide the best care, and a lot of blame. And I'm embarrassed to say that I often blamed the patient rather than me understanding what was really happening.
It is a disease like any other disease, but unfortunately, it is not treated like any other disease.
It was not uncommon for me to hear doctors talking about patients as crazy or addicts or things like this, and realizing that there was a lot of stigma within my community, the medical community. We have to really start having open, honest conversations within the field of medicine about how we are understanding addiction in the first place.
Addiction is a chronic medical disease, a disease of the brain. It is not a sign of moral weakness or failure.
It truly is possible for all of us to develop this disease, which is what makes it so scary.
Once I started to understand the neurobiology, that there was a way to actually understand what the drugs were doing in the brain, then it was much easier for me to treat them and relate to them.
Particularly for opioid use disorder, we have excellent medications that are available, and that has to be the foundation of treatment. We need high quality, evidence-based behavioral treatment.
In opioid use disorder, medication-assisted treatment has been shown to have great benefits. People realize that medication-assisted treatment is safe, that it's reliable, that it makes a difference.
I have changed tremendously since working with this population. Despite the fact that patients are very high risk, it's very rewarding on a daily basis.
I see them doing well, putting their life back together, being able to get back to their baseline, being able to support their families, being able to take care of their mental health, being able to get back into treatment. That really inspires me.
Their recoveries are just as compelling as the recoveries that take place in a cancer center or in a burn center or in any other traditional medical facility. I think I've had the benefit of really kind of going on the journey with them towards recovery.
For every intervention that you do with a person, you are having a direct impact on their loved ones and their family. For everybody who doesn't die unnecessarily, that's one more child that still grows up with a parent, and that's very moving and gratifying.
Thanks very much, Catherine. Thank you very much. And so next we'll hear from Gail.
Okay, thank you very much. I'm very happy to be here. I have no disclosures except one thing that Aetna has helped us produce some videos that we've done for our websites with NIDA and Yale. So most of you know about emergencies, but we are the 24/7, 365-day option to help fight the opioid crisis. Most of us are seen as people who actually work with immediacies, whether that is anything that is life-threatening, and it's been somewhat of a struggle to seeing that this is life-threatening, as well as the heart attacks and as well as the strokes and the traumas. So emergency departments and emergency physicians can do all these things. Identifying patients are not really a problem. They hit us in the head. They're there. They're there for overdose. They're there seeking treatment. They're there for infections due to injection drug use, et cetera. So many of the times they really are right there in front of us. We can provide treatment. That treatment is not only psychosocial, small interventions that we do, but also initiating medications such as buprenorphine. And we can directly link patients to care and preventative services. So what is the evidence? We at Yale, a whole group of us, have completed this study and published it in JAMA in 2015. We were looking at different models of treatment for patients that presented with opiate use disorder. So that you know, these are all patients who came in. Only 9% were overdoses, about 30% were seeking treatment, and the rest were identified during the course of this day. And what we found with this is that if we offered buprenorphine at the time of the visit, along with a very, very brief intervention of motivating patients to care, that people were much more likely to be in formal addiction treatment at 30 days than they were if we gave a brief intervention and a direct referral on its own, or if we just gave them a referral, which was more than standard care, but based on their preference and their insurance status. So we found that almost 80% of people went to the referral that we gave them, which was primary care, office-based treatment, along with our initiation of buprenorphine. 50% of people were initiated at that time. 50% received home induction because they were not withdrawing, which went very well. It's very feasible. We also have one of our team, Dr. Bush, who is a health economist, that was able to show that really for every dollar willingness to pay, things did well, and this was very cost effective for engagement and treatment, as well as each day free of opiate illicit use. So now the latest research shows that we really should do something with all this research, and so we have been doing it. We have implementation projects. Thank you, NIDA, for helping us with that, and we're doing it everywhere on the world. We're doing it through our national organizations, and we really are integrating it. At Yale New Haven Hospital, every single one of our attendings have been waived. This is a big bar to reach, but we've done it. We also have Project Assert, which are health promotion advocates that help our team partner with community resources and get people there. We have nurses on board. We have, advanced practice nurse practitioners and PAs as well, all of which are helping to say this is a great patient. We should start initiating something. So we know that this can work. We were fortunate even to be in the head of the New York Times on the front page just recently to show that EDs really can make a difference. Dr. Andrew Herring from Oakland, California is really one of my big heroes because he's taken the research and he's done it in practice, and he is offering this to all of his patients who come in. There are many other people who are doing this, from Camden, New Jersey to Syracuse. All over the country, people are really working on doing this. So we're part of a system of a major comprehensive approach. So one of those things are access to care, and the ED really offers that access to care. In addition, we often do many other things, such as talking to patients about reducing their OD risks. We do safe prescribing. We share our data. We try to reduce stigma in any way that we can. And so we have tried often to reduce many of these barriers and find solutions. I actually hate that word barriers, but we're forced to use it in many ways. We have 2 websites that are up, and that's for you to please look at. One of those we just created at Yale because we were waiting for the other website to go up at NIDA, but it has just gone up this week. It's all the same data in there and all the information. So anything that anybody needs to know to practice this in an emergency setting are there, from our algorithms to our home discharge with home induction to videos that are there, and these are the ones that we had help with to film. A filming crew came down, and those are 3-minute videos on how do you talk to a patient who doesn't want anything? How do you talk to a patient that you just saw overdose and doesn't want treatment, but there can be harm reduction techniques? What do you do when it's an adolescent who comes in, which is a little bit of a longer video? And so just about everything that you need, frequently asked questions are there. So please use those. There are many concerns that emergency departments practitioners have, and these are those. We've talked about them some, so I'm not going to go into all of them, but one is that addiction is a moral failing, and of course it's not a moral failing, and the reality that you can see here is that it is a relapsing disease, and we need to understand that, and we know that we can do that. Another thing here is that, and we can provide specific feedback to emergency department personnel about what's good is great, because in emergency medicine we only see failures, right? We only see the people that come back. So we constantly are telling our providers about patients who have gotten into treatment who are really doing well, and that's important. Diversion, as you know, is always, people say, well, I'm going to divert. Well, as far as we know, yes, there are some diversion, but it is less than most other things. And if you really look at, again, what was used in that SAMHSA of misuse was not receiving a medication from a physician. Most all of the diversion of buprenorphine is that so people will feel better out in the street. If they feel better, the way I think of it, and most of us in emergency medicine, is that's one less time that they've used an injection drug. That's one less time that you die. There is no other disease that if you mess up once, you may die. You know, if you are diabetic and you have diabetes and you come in with hyperglycemia or there's something that set it off, you're generally not going to die. We're going to help you, we're going to get back, and we're going to continue it. So this is just as important as we are here. Other things are that initiating, this is hard to see this, initiating buprenorphine in the ED, it's crowded and it's chaotic. That's very true, but this is quick, and we can do this with the protocols that we've outlined. You can do this very, very quickly, and in fact, you can get people in and out very soon. If you use other cocktails of medication without using evidence-based treatments, you'll be there forever, and everybody will be disappointed. So we give limited supplies, and we integrate this in our pathways. We have Epic, or people have electronic health records, and people are integrating all of this along. So again, it's not going to increase your length of stay. In terms of lack of referral sites, many people think that there aren't referral sites, but yet when we go into the community, we find tons of them. And as you can see, there are lots of doctors who have received their waivers, so they are there. So it's a matter of one person taking the time to collect that information. Patients will return. Well, we have not found that. All of the people that we know who are using it, we have not found that. Although if people do return, again, we know this is relapsing disease and we'll treat them again. And we do have protocols for people that have chronic diseases who lack primary care in the outside and often will see us. And this is no different than anything else. People will come back for redosing. We have not found that, neither has anybody else who's doing this in a concerted effort. So many patients don't want treatment. It is true that there are patients who come in, particularly those after overdose, because they're kind of dysphoric from the Narcan that maybe they have been given, but we do talk to them. We do give them some harm reduction strategies, and in our emergency department, we actually hand them a Narcan kit. And we talk to them about safe using with other people around, using with places that you would have Narcan available, and where they could go for treatment should they decide to go for treatment. And then finally, obtaining a waiver is too difficult. Obtaining a waiver for us is really a heavy lift. For emergency physicians, we have lots of things that we have to do, stroke protocols and preparations for education that we have to do all the time. But it can be done, and everybody knows that it's free, all right? So it's free, and we're doing it. And we have offered payment in my institution. I happen to be the chair, so it's a little easier. But I do offer a day for our community docs who are working 40 hours in the ED, which is 50 hours. For the academic docs, they go on their own time because they tend to have more schedules that can be flexible. So while this is a problem, and when I go around the country, that is the #1 rate problem. It's not only that you have to take the program, but the program is not tailored for emergency physicians. We're not people who are going to have people on a regular basis on our panel. We're doing stuff in the emergency department, and what they learn there is not really what they need to do. So we're working on doing special modules for emergency physicians. In addition to taking care of patients who come in or need treatment, we also have patients who come in with major trauma, even minor trauma, who are on these medications. And these medications are really difficult when people do need management of their pain. So there's a lot that emergency physicians need to know about it, and it's a lot that we talk to people about. So some of the policy things that we really need are enhanced training that are specific for emergency medicine. It would be really nice not to have a waiver. As I go around, physicians will say to me, my goodness, I can open a chest without any special training than my emergency training, and now you're requiring this, or I can, prescribe 1,000 oxycodones in my lifetime, and now I have to do this. And we're also looking forward to hopefully some availability of some longer acting preparations so that we can use those. And that's it. Thank you.
Thanks very much, Gail. And next is Ingvild.
And I know we're running behind, so I think I'm going to try and talk really fast. So you've heard about a number of different models. I'm going to tell you briefly about, do I have to advance this?
The slide's up. That's the other way.
Other way. Oh, because I'm holding it this way. That's why. No. Okay. Sorry. Okay, here we go. Okay. All right. So, so I'm going to address another model that actually now really connects general medical settings and specialty addiction treatment settings, otherwise known as kind of the hub and spoke model of care. And right now, Vermont probably has the most well-known such model. California is also embarking and has been since 2015 on really expanding hub and spoke models across their state. But I actually want to go back a little bit in time to 2006 because Baltimore actually pioneered the hub and spoke model at that point. And yeah, the light doesn't show up too well, so my apologies. But essentially, back in the late 1990s, early 2000s, Baltimore was ravaged with a heroin opiate epidemic and overdose. And when buprenorphine came out in 2002, Maryland Medicaid actually opted to add it to its pharmacy benefit, but only in general medical settings. And so there was very, very, very little uptake. Even with lots of push and training and kind of everything else, people said, you know, and there was research done in Baltimore and elsewhere, that some of the key barriers were that induction was too hard, it was too difficult, it took too long. Sound familiar? That there weren't enough counseling services. And essentially, I think kind of a nice way of really saying, we don't want to treat those patients, we don't want those patients in our offices. And so the Baltimore City Health Department, in partnership with the local addiction authority and an implementation specialist, essentially went to all the healthcare facilities, hospitals, outpatient specialty addiction treatment settings, all of the FQHCs in Baltimore, and the health commissioner at the time said, we really need to do this. We have an epidemic on our hands. We've got more heroin overdoses than homicides. You know, we really need to, and you guys need to get on board. And what they ended up doing was actually recruiting 9 drug-free, kind of medication-free specialty outpatient addiction treatment centers, and with state and federal grant funds, supported the inclusion and integration of physicians, nurses into these addiction treatment settings that had not had any medical practitioners for decades. And they were able to then actually get patients inducted and stabilized on buprenorphine. And once that happened, then with case managers really actively linking people to then identified primary care physicians who essentially had been told by their healthcare facility administrators, no, you guys have to get waivered, and we've got to do this. And at the time, because these were stable patients, the idea that like, oh, I don't have to start them? Oh, I don't have to like manage all their difficult problems? Oh, and, you know, there's a case manager that's going to help me actually kind of work through some of those challenges. There was a huge expansion in access to effective treatment. At the same time, the initiative realized that, you know, this wasn't just about access. This was also about quality. And that there were clinical guidelines that were developed both for the specialty addiction treatment centers as well as for the practicing kind of primary care practices, because this idea that you can shift from an acute detox kind of model of care to a chronic maintenance model, that was new to the specialty addiction treatment centers. And so the counselors and the physicians, and even the physicians and nurses in the primary care practices, really needed more education and more support around how do I actually support somebody in recovery? How do I now actually take care of this whole person and not just immediately discharge them from care if they start using opiates again, or cocaine, or if they continue to struggle with cocaine? What do I do about that? And ultimately, that really paid off. Between 2006 and 2009, the number of patients that actually were now being treated across Baltimore with buprenorphine increased from 577 to over 7,500. And most impactfully, this is a study from Baltimore that really shows that that expansion that included both methadone and buprenorphine really led to an overall over 50% reduction in heroin-related overdose deaths. So it had a population impact. So, well, why am I sharing this history with you? Well, I think that there are a couple lessons that I really take from this. So one is that Baltimore actually had to quadruple its opioid agonist treatment receipt. It wasn't just the access, it was actually people getting the medications. And we know that in France, that when you really dramatically expand access and get people to take the medications, that's when you see the reductions in the overdose mortality. But I think it also highlights that need for that quality of care. And we've heard some of that this morning, and I'm sure we're going to hear more about that. And so those lessons, Maryland and now Baltimore, as well as learning from Vermont and California, are now embarking on building out Hub and Spoke version 2.0, using OTPs as hubs. Because there have been a couple of financing changes in Maryland that have led this to happen. So in 2010, Maryland Medicaid actually launched the OTP, in 2013, Maryland launched the OTP Behavioral Health Home Initiative that became available under the ACA. And over 50% of the OTPs in Maryland that have a health home now are in Baltimore City. In 2015, Medicaid also added buprenorphine and depo-naltrexone reimbursement to its OTPs and changed the financing system that incentivizes now more medical care. So OTPs are now really paid for physician visits and nurse practitioner visits and other medical care that can be provided. And last year, the organization where I work, IBR, where I see patients, we got then a grant from the Baltimore City Health Department to pilot this hub and spoke model in Baltimore. So now that means that patients have access to all 3 medications and are able to choose which medication might work best for them when they start treatment. So over the last 6 months, we've started over 100 new patients on buprenorphine, 180 new patients on methadone, and a handful on depo-naltrexone, according to also what the patients want. And we have found that between 25 and 30% of those patients who started buprenorphine actually switched to methadone because they really weren't able to stabilize their opiate use disorder on buprenorphine alone, plus all the wraparound services we provide. But because of the federal regulations and the restrictions around methadone, we can't transition those patients to the spokes that we're working with like we do with our buprenorphine patients. But the model has enabled us to create a broader primary care specialist network in which complex patients with multiple substance use disorders and co-occurring conditions such as chronic pain, psychiatric conditions can obtain better coordinated care using our health home. Although it's been difficult to engage traditional mental health clinics, I will tell you. And we treat hepatitis C, we provide some limited primary care, but there are currently no innovating financing models for supporting OTPs becoming patient-centered medical homes, actually as the primary care homes, for people who are really difficult to engage in typical primary care. And about 25% of our patient population falls into that category because they have often significant trauma histories that so they have difficulty with trust. They've had bad experiences with traditional primary care. They have multiple substance use disorders and medical and psychiatric conditions that all together make it really hard for them to navigate the traditional primary care system. And we've seen a significant culture change that's been necessary, both in the hub and in the spoke, to really embrace and think about ourselves as part of a network where we're co-managing patient care, and communication really is critical to that. The HITECH Act many years ago left out behavioral health clinicians and providers from innovation in IT. And so we've been doing a lot of faxing, phone calls, lots of kind of old-fashioned ways of meetings to review shared patients because we don't have the technology to actually be able to really effectively share information, even with the appropriate consents. So we certainly have had challenges, but I think that the hub and spoke model really presents another opportunity to engage patients, improve their health, and save lives. And we really look forward in Maryland and Baltimore to continuing to expand on hub and spoke version 2.0 so we can get back to, in the era of fentanyl, more population-based impacts. Thank you.
Thank you. All right, Ingrid, all of our speakers, thank you all very much. They covered a lot of ground in a limited amount of time. We did start a little bit late. I promise we will have a break, but I may go a little bit past our scheduled break time to have chance for participation by some of you. First, though, I think we have the results for our survey, and it looks like number one on the list is the need for additional training and education ahead of regulatory and legal changes, additional funding resources, and lower down, additional evidence on what works. I heard a lot of evidence today on models that do work. Let me start this by first asking people who do have a question to go to the microphones. Please keep them concise. But let me start by asking you all, you've highlighted some further policy steps, but can I ask you to highlight maybe one really important step to scale effective medication-assisted treatment models for opioid use disorders? One.
I would say to increase the reimbursement issue, resolve the reimbursement issue, as in providing parity for substance use disorder treatment, as well as coverage for all disciplines that have licensure to provide this treatment, so that it doesn't create more barriers.
Great. Thank you. Catherine?
Require all health professionals to have substance use training. It has to be integrated into all treatment.
Required.
As I said, my important thing is to start having alternative ways of education besides one for all people. It's not going to work.
In addition to all of those, I think I would also advocate for really re-looking at the regulatory structure around opioid treatment programs.
Great. A lot of comments around regulatory issues. So I go to a couple of questions from the audience. I have some from online. Please tell us who you are when you ask the question, and for any responses, let's please keep them concise too. Thank you.
Hi, my name is Peter Strump. I'm from Amygdala Neurosciences, and I have a question, I guess, for Dr. LaBelle or Olson. I was wondering, patients being treated with buprenorphine, how frequently do they come back? Every day, once a week? And how has the introduction of depot formulation buprenorphines changed the practice?
I'll answer first, Colleen. I'm not a doctor, just for the record, nurse. So we see patients weekly for the first 4 to 6 weeks until they've stabilized. If they haven't stabilized, we continue to see them weekly. It's really important to stay engaged with them and help them with their chronic relapsing disease. We decrease frequency as they progress in their disease. Some people stay on weekly for a long time or forever. Others progress rather quickly. We have not started the depot formula yet. We're putting systems in place. We're making sure we have storage and security measures in place. If this comes into people's office practices, how do you keep it? How do you regulate it? How do you train staff on it? How do you put your protocols in place? So we're working through pharmacy and that. But it will, in fact, decrease the frequency in which you may see folks, depending on who we use it for, the stable patients versus those that may be struggling.
And I work in an OTP, and so we're really fortunate because we can actually then see people, whether it's once a day, daily, to once a week, to once a month. I mean, and it all really depends on how people are doing in treatment, and particularly with their opiate use disorder. The injectable, so we've actually had a couple of patients who have had the implantable buprenorphine. Most of them actually, the two that we've had came to us on it. It's challenging because the dosing limitation has been a challenge. Many patients actually are stable on higher doses than the 8 milligrams that are required for the implantable. And Maryland Medicaid, while it has put the new injectable on its formulary, we also still are working through the practical issues, as well as it is going to be more expensive. And so having higher copays. And so right now we haven't really been using that.
Okay, thank you. Michael?
Hi, I'm Mike Miller. I'm the Senior Policy Advisor for an organization called Healthy Women. And we've been working with some state legislatures around the country collectively, helping them figure out ways to address this. We put together a toolkit, actually limited resources. But getting to the video you guys showed, one of the first thing we have on our list is how to address stigma. And for not a technical audience, but just sort of lay conversation, if you guys could talk about word choices, because in putting this together, we tried to avoid using the words addiction or abuse, tried to go back to substance abuse, substance use disorder, opioid use disorder. Can you talk about those word choices? I'm not advocating that NIDA change its name, but just how you manage that or how you get to those.
Do you want to take that one?
Sure. This is one of the hardest things on our websites too. We have some better words to say than others, but we're using the wrong words. All right. So, for example, medication-assisted treatment is ridiculous. All right. We don't say that insulin is the medication-assisted treatment for diabetes. All right. And diabetes has a lot of behavioral issues resulting with it that primary care doctors and others address with any chronic disease. So it is a medication. We have shown time and time again, there's a huge Cochrane review, that it's the medication that works with or without counseling. Does that mean that it's not good to have counseling? No, I'm not saying that. Because it's good for a lot of things, right? But it is the medication, and we are perpetuating that. SAMHSA has perpetuated it. So we're asking that it is medication for opiate use disorder, all right? That is a better way of saying it. That opiate agonist treatment is methadone and buprenorphine, and right now those are the two evidence-based treatments that have worked and that have shown to decrease all-case mortality. In terms of other things, we like to say that people return to use. It's not a relapse, it's not a failure, it's return to use. We like to say that, trying to think of some of those other words. So,
Anybody have other
So
favorite terms?
Yeah, and just, I mean, the word abuse, I think there is very good evidence. John Kelly has done just a really innovative randomized trial that found that mental health professionals treat and think about people differently when you use the word substance abuse compared to substance use disorder. Addiction is a little bit of a harder one. I also wear a hat as the secretary for the American Society of Addiction Medicine, and we do use the word addiction because we actually have a definition that it's a primary chronic brain disease. And so I think really understanding kind of what addiction is and how it's defined is also kind of part of the key. There's a big difference between addiction and physical dependence, and I'm so glad that Ed Salsitz really made that point, because we absolutely very often find that even my patients will get that confused and not understand that, the medication that they're on, they will develop physical dependence, just like many other medications that people take, blood pressure medicines, antidepressants, right? And so that when they would like to try and come off it, we need to do that in a monitored way, and a medically monitored way.
Great. Thank you. Great discussion. I do have a question from one of our web participants asking if one of you could elaborate on some of the challenges and successes associated with partnering with non-medical groups in these integrated approaches. We've heard a lot of that on this panel. Anyone want to take that?
We work with a lot of non-profession groups. We work with the recovery community facing addiction and some other groups that work with us. We find it, I think with the most recent project we're working with, the STRTA, we're expected to have prevention, recovery, and treatment together. One of the first things we all agreed we had to do was come up with guiding principles. This is what we all agree on. So any consultant that works on that project, be it prevention, recovery, or treatment, has to agree on common approaches. One, it's a brain disease. It's someone in recovery can be on medication and still be in recovery. So huge steps like that where we all can agree on certain things. There's some things we're not going to agree on, but I think that has been a huge step in bringing us together, is focus on those areas that we all agree on.
So I think some of the struggle is the recovery community is, a lot of them is still focused on the abstinence, and we're working on the evidence of the medication, so we're kind of battling that. So I think the more we can engage them, the more we bring them to the table. We're using a lot more recovery coaches in Massachusetts, so really trying to educate them on the science and trying to get them to understand there's not one pathway. So bringing them to the table, getting them involved, having them as part of our coalitions. We're also building an ECHO-type model for the inpatient addiction treatment centers, those that do detox, and then the other step-down levels of care, and working with them to talk with them and have them as part of the panel, to being the experts to treating patients and working through cases. So I think it's just about how do we help them understand and how do we give them these tools, and we need to all come together. So, I mean, it's hard.
Yeah, great examples that you also talked about during the panel. In terms of collaborations with medical partners, you all have described a lot of those too, but I heard the comment about difficulties with mental health professionals and organizations. Any brief comment on how to address that?
It's a great question, and it's not entirely clear to me kind of why we've had such difficulty engaging with them. I will say that I think that the education that we talk about in terms of physicians needing education around addiction, all healthcare professionals need training around addiction, because I think part of it is that when there are social workers or counselors or psychiatrists, whoever kind of the peer recovery specialists, we have them working in our program as well, that people get various different educational experiences and they have different life experiences. And so we can't just focus on the kind of medical schools. We really need to focus on nursing schools and social work school and all the curriculum kind of across the board.
Thank you. Time for one more quick question, please.
No pressure, huh? Hi, I'm Kaylin Klee. I'm family medicine and addiction medicine in Colorado. And my question is probably from all of your different perspectives, especially those who are working across multiple disciplines, how you have navigated some of the particular privacy requirements around substance use. This was highlighted when I realized I was signing a release of information with my patient to myself from family medicine to addiction medicine, right? And so for those of you who work across emergency room to primary care, OTPs to the spokes, how are you navigating that? And if you have any lessons learned that you would be willing to share?
Anyone?
So we have patients sign releases to as many places as possible on the first visit. And the way we explain it is really that, we are all about kind of holistic care, really treating the whole person. We can't necessarily do that ourselves within our four walls and a roof, but that we then coordinate care. And that it's not, because a lot of times people have a lot of questions about, what are you going to tell this other provider? What information are you going to, to give over here? And we really try and make this is about their health. And if we can also be then advocates on their behalf in having those conversations, that's kind of the other way that we message it.
Great. I'd like to thank all of our panelists for this session on effective integrated approaches for opioid use disorder treatment. Thank you all very much. Now, we are running a little bit behind. If you could maybe take an 8-minute break or so, and we'll try to restart around 11:35 this morning. Thank you.
I'm between you and lunch. Looking for my panelists. Welcome back. My name is Larry Greenblatt, and I'm a general internist at Duke, and I have dual appointments as a professor of medicine and also professor of community and family medicine. And I'm actively involved with the Opioid and Prescription Drug Abuse Advisory Committee in North Carolina, and I'm also a waivered physician, as you wouldn't be surprised to hear. I'm very excited to be moderating the second panel of the day. We have a terrific group here. We've heard so much rich conversation already. It's going to be a high standard to try to keep up, so I'm putting the pressure on my group here. We had a phone call, and I know that these folks have a lot of great ideas and interesting things to talk about. In this session, we're going to take a deeper dive into some of the legal, regulatory, and practical barriers that hinder greater health system utilization of medications for OUD treatment. And these barriers, of course, might potentially interfere with access to treatment for our patients. Some of the major issues that we're hoping to address in this session include major legal, regulatory, and cultural barriers to access, the role of stigma in limiting access to treatment. And we realize we've heard some of these themes touched on already, although I think you're going to get a somewhat different perspective from our panelists. We're going to talk about patient perspectives and difficulties in navigating the treatment system, and also what gaps are there in the behavioral health workforce and payment policy that interferes with treatment. So we're going to start out with a poll, and we'll discuss the results following the panelists' presentations. So that this time I'm going to ask you to use your cell phone or your computer to answer the third question. I guess it's on the screen behind me, and then you can also see the questions on your device. So take a minute and look at that. We're going to ask you about what is the most significant opportunity to expand access for medications for OUD when we think about what can policymakers and health systems do. So the answers are in front of you. We'll certainly address many of these barriers today, but we're going to pick whatever comes up top and kind of try to explore that a little bit more. So for now, we're going to go ahead and jump into our presentations from our panelists. I want to introduce them briefly. To my left is Tom Hill. He's Vice President for Practice Improvement at the National Council for Behavioral Health. Sharon Stancliffe is Medical Director for the New York State Department of Health. Jessica Hulsey-Nickel, we've all met on the phone, but not in person, is the Chief Executive Officer of the Addiction Policy Forum, and Sarah Wattenberg is Director of Quality and Addiction Services at the National Association for Behavioral Health Care. So Tom, I'm going to turn it over to you and allow you to present.
Good morning, everybody. I'm going to time myself, because when we talked on the phone, I said, well, maybe we can all do it in 6 minutes so we'll have more time for conversation. And then I have to make sure that good for my word. So my name is Tom Hill. What I'd also like you to know about me is I'm a person in long-term recovery from addiction. Yeah, I say addiction. I don't say I'm an addict, but I say that I'm in recovery from addiction. And I think that when we look at people, when we look at recovery in general, and we look at people in recovery from addiction, and people that are looking for addiction, it's really important to look at how our services and systems and community supports are in place. Because if they are in place, the likelihood of people getting into recovery is much, much greater. And I think we also often have a tendency in this particular disease to blame the people who are trying to access the services. But if they've been failed by the system before, or they're continually failed by the system, we need to look at the system and not the people who are accessing the system. Really, really important thing that we always look at as we're moving forward, that we don't take cheap shots on the people who need help the most. So today I want to talk about some regulations with medication-assisted treatment, especially OTPs, as we talked about earlier. I want to talk about 42 CFR Part 2, and I want to talk about the Ryan-Haight Act. So we talked about the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to treatment of substance use disorders. And research shows that a combination of medication and therapy can successfully treat these disorders. And I want to add an element of the third leg of the stool, which is recovery supports, because the combination of those three things is what enables people to access a full life in recovery, or at least to consider themselves candidates for recovery. And in the past, that wasn't true for people who were on medication-assisted treatment. So the idea of medication-assisted recovery, a new concept, is something to think about in a new way. So we talked about terminology on that last panel, and we talked about the term MAT, medication-assisted treatment, as being misleading. And I sometimes think that I'm not dyslexic, well, I am dyslexic, but I think maybe TAM is the way to think about it, is treatment that's assisted by medication. And I think if we think about it that way, we don't lose the treatment. We don't lose the psychosocial supports that are really, really important part of the equation. Now, some people will say that just medication alone will save people's lives. It does. But medication with the other supports will not only save lives, but enhance lives and have people fulfill self-actualized lives, that they become community citizens, family members, and productive people all over again. So let's talk about opioid treatment programs. To become an OTP, a program must be approved by the state opioid treatment authority, that's the SOTA, and the approval process is different in every state. They need to be registered by a regional office of the DEA. They need to be certified by SAMHSA, the Center for Substance Abuse Treatment's Division of Pharmacological Therapies. And they need to be accredited by one of 6 SAMHSA-approved accrediting bodies. Those are 4 levels of regulations and requirements that an OTP needs to go through, and there's a reason for that. So throughout the evolution of OTPs since the 1970s, these requirements have ensured quality measures that monitor dispensing and dosing of methadone, lower the risk of diversion and overdose, and ensure connections for psychosocial therapies. The connections are all there. I don't know why that happened. We're just going to get rid of that. So another thing we're hearing right now is this idea of decentralizing OTPs and dispensing methadone in diverse primary care settings. And I think before we go too far with this idea, we really need to consider all the unintended consequences of dispensing controlled substances without assurances of a four-point process of approval, registration, certification, and accreditation across federal, state, and private agencies. Those layers really safeguard what the dispensing of medication looks like, and especially the dispensing of controlled substances. And so a wiser approach may be to reinforce the infrastructure of OTPs to be centers of excellence, where patients can access all 3 medications, to plant OTPs in areas that desperately need them right now, and to make advances, and we talked about the hub and spoke model, to make advances in that model and applications that are regionally focused that will fit a more diverse regional and geographical areas, especially rural areas, right? So I'm just going to talk about Data 2000, but I think we covered that enough in the last section. So I want to talk a little bit about 42 CFR, and this is an issue that has really galvanized the addiction field. And it raises hairs on the backs of many, many necks. And it's something I think we need to talk about in terms of often the elephant in the room. And so it came about to ensure that a patient receiving treatment for a substance use disorder in a Part 2 program is not made more vulnerable than an individual with an SUD who does not seek treatment. And we know that that vulnerability of seeking or not seeking treatment is one of the big issues here of whether people access service or even look for services. So it applies to federally assisted SUD programs. Its patient-informed consent must be obtained before sharing information from a program that is subject to Part 2. And upon disclosure, no redisclosure is permitted without the patient's consent. And then there's some limited exceptions for disclosure without consent, like medical emergencies, scientific research, child abuse reporting, things like that. So these regulations came about in 1975. They were updated in 1987 and then updated again in 2016. And the proposed rules in 2016 were intended to modernize Part 2 rules by facilitating the electronic exchange of SUD information for treatment and other legitimate healthcare purposes, while ensuring appropriate confidentiality protections for records that might identify an individual directly or indirectly as having a substance use disorder. So we talk about stigma a lot. We use that word a lot in all of our conversations. We rarely use the word discrimination. And they're not the same, but they're intimately connected. And when we talk about discrimination, we have to talk about what potential discrimination can happen as a result of releasing records. Always has to be there, especially in an age now where we're going back to criminal justice solutions or thinking about criminal justice solutions that many of us thought were long past. So the proposed rule is intended to modernize Part 2. The addiction field is divided on this issue of 42 CFR Part 2. The House passed a bill earlier this year to align Part 2 with HIPAA regulations. But the way that's divided is that those opposing Part 2 argue that it creates unnecessary barriers to care. It impedes new models of integrated care that rely on information sharing to support care coordination. It blocks electronic information exchange, and it hampers a recent focus on performance measurement and value-based payments. Now, on the other hand, others argue that a breach of privacy information protections can lead to civil and criminal consequences for patients, including loss of employment, housing, child custody, discrimination by medical professionals and insurers, and arrest, prosecution, and incarceration. So you see, these are two very differing sides of the fence. Each has their own point of view, but we need to come to some resolution in how these things are going to be figured out as we move along, because it's often the elephant in the room. Last thing I want to talk about is what we call the Ryan Haight Act. It's the Ryan Haight Online Pharmacy Consumer Protection Act of 2009. It was designed to combat the rogue internet pharmacies that proliferated in the late 1990s, selling controlled substances online. Regulations were issued at that time, imposing a federal prohibition on form-only prescribing for controlled substances. So unfortunately, the exceptions do not align with direct-to-patient service models in frequently sought areas such as telepsychiatry or substance use disorder treatment. And in addition, there's a nationwide shortage of psychiatrists and board-certified addiction specialists, along with the opioid epidemic, making telemedicine services a vital resource, especially in diverse geographic areas and rural areas. So there's two acts that are currently on the Hill. One is Improving Access to Remote Behavioral Health Treatment Act, and this would allow certain community mental health centers and addiction treatment centers to obtain DEA registration as a clinic, would allow telemedicine providers to prescribe controlled substances to patients present at those sites without the need for an in-person examination. Think rural areas, very, very important, and would expand treatment sites beyond the current DEA-registered hospitals and specified non-hospital clinics, so it would broaden the base. And then coupled with that is Special Registration for Telemedicine Clarification Act. It's released simultaneously, and it directs the Attorney General, along with the Secretary of Health and Human Services, to, within 30 days of the passage of the act, release regulations regarding the issuance to practitioners to use telemedicine to prescribe controlled substances without the in-person team. So these amendments to the Ryan Haight Act, National Council has been working diligently for 2 years on, really hopeful that these things get passed and move along so that we can open up telemedicine in our field, especially in areas where it's direly needed. That's what I've got. I think I've used my time up, and I'll turn it over to my next speaker.
Good morning. I have no financial disclosures, but I do have one disclosure. I'm actually only an associate medical director at the AIDS Institute at the New York State Department of Health, but it's a cool title, Associate Medical Director of Harm Reduction in Health, and I hope that kind of comes through in some of my slides here. So there's not a huge extensive body of literature on stigma and substance use like there is with HIV and stigma, mental health and stigma. So what I'm going to do here is tell you stigma is bad, tell you a little bit about that. Then I'm going to talk a little bit about what we know about trying to reduce stigma and hopefully give you some fairly concrete examples of that and part of why it's a barrier for us as providers providing care to people that need the care. So stigma and substance use, this is a review that happened of it a few years ago, but we know it's reduced with poor physical and mental health. We know that it's reduced with poor access to services. For example, in some substance use programs, providers, there's the people that really aren't going to work out very well, and these are the ones we like. We even know that there's internalized stigma both about myself, but also, well, I might inject drugs, but I'm not like that person over there that's injecting those drugs. So it's pervasive from the general public, which includes medical folks, to people directly providing services, to those that need the services. And we know that it has an impact on poor outcomes for people. Here's a slide that I also can't see that actually does discuss the discrimination versus stigma going on. And so this is specific to the opioid crisis. This paper just came out this year. So we're looking at, people think that people that use opioids are dangerous and criminal. So people begin to feel like, I'm dangerous and criminal, and people are going to think that, so I'm just actually not going to go there. And people say, well, the actual outcome is I'm not going to provide services. I'm not going to give this person who tests positive in their urine a job, even if it's at McDonald's. And then people begin to feel like, well, I'm not worthy. Why should I try to do this? I don't want to be part of that label. I don't want to do anything that will give me that label. So it's on multiple levels. And I didn't learn much about substance use in medical school, but the funny thing is, there wasn't as much stigma. They forgot to tell me that people that use drugs don't take their medicines. So until I heard about that with HIV, I was like, okay, yeah, so these people use drugs, but they do other things too. So there was a good side to that, I suppose. So we've already talked a little bit about making changes to language, and I think that it makes a big deal. I get to say what I think MAT means right here, I guess. So I think it's medication as addiction treatment, which I got from Kelly Clark, the president of the American Society of Addiction Medicine. Not to run down counseling. I need counseling. Well, I'll probably need counseling. And people that have had their lives really disrupted by drug use can often really benefit from it. But what I want to say is the people that are using drugs are not that helpless. We need to start changing how we talk about them. It's not just the people in recovery that are going to carry the message to providers. We're not like trying to get the people in recovery already into treatment. They're already in treatment. We need to make providers feel like the people that are using drugs are valuable, interesting people, and they are. So, language is certainly part of that. Addiction is sort of on the line there, but getting rid of addict, abuser, and talk about people who use drugs, maybe people who inject drugs, certainly junkie, crackhead, tweaker, those actually have no place in our vocabulary. I know that people that use drugs will talk about themselves as having clean or dirty urine, but I'm a professional. I'm going to talk about negative or positive urine. A lot of my patients are going to refer to themselves as junkies, as dope fiends, but I'm a professional. I can hear what they're saying, and sometimes we have some really interesting discussions about it. It's like, clean is when you have it together enough to get a shower every few days, not when your urine doesn't have any drugs in it. And in fact, I don't know if urine drug screens really measure stability at all, and that's a question I would like to ask of folks. People that use drugs have major contributions to our world. And I think I could go on, but I'm going to talk about a few that are really relevant to where we sit today. It wasn't public health people, well, I guess you call them public health people, it was like the first public health people that came up with syringe exchange. They called themselves the Junkie Union in Holland. Like, people aren't letting us have access to needles. This is dangerous. So they started needle exchange just before the HIV epidemic hit. Some countries adopted it sooner than others. It's become a major public health measure, but that's who came up with it. A needle exchange in Chicago noticed what they were doing in Italy, making naloxone available. So people that use drugs in Chicago said, oh, well, people are dying of overdoses. We're just going to give them naloxone. They didn't wait for any laws to change. They didn't ask any permission, and they fortunately didn't get punished for it. But that's where that came from. And then people on methadone, of course, are stigmatized, but the way the first methadone treatment program in a jail in this country at Rikers Island came about is 2 of the patients that had been hired as research associates said, gee, why don't we have methadone, not just detox, but why don't we have it actually as a place where we begin it when people come in with substance use disorders and send them out? So, like, we've got emergency room, just do it. They just sort of figured out how to do it. But those were people that are on methadone, and they're highly stigmatized. And since tomorrow will be in Maryland, I just want to mention Dr. William Halstead, who is said to be one of the fathers of modern surgery, who was a founder of Johns Hopkins School of Medicine, who struggled with morphine and cocaine addiction through his life. So, I think we need to make these patients sound much more interesting. We want the people that are using drugs in our office, and throw away those treatment agreements where you sign to say you're not going to steal anything or kill anybody while you're in the office. I have a really minimal treatment agreement, but those are incredibly stigmatizing. So I think this is a direction we need to start to go. If I could, I'd work in some of the fear that providers have, not only of the people that use drugs, but of the people that oversee the system. So I guess I'm kind of working it in there. People are very afraid of the DEA, and they're probably over stigmatizing it. I don't know, but I just want to throw that in there because I want to. So finally, I just want to end with some social media campaigns. In reducing stigma, that we know probably that the best thing is good contact with the people that are stigmatized, whether it's because of their behaviors or because of how they were born, whatever. The contact is important. We can't always supply contact, but I think we talked about people going back to the emergency room to say they're doing well. I want to send my patients back to the detox where we finally got them stabilized on buprenorphine to say, hi, I'm doing well. Send the people that are doing really well back to the jail to say, I don't drop in and visit you all the time because I'm on methadone now. But seeing those people is important, changing our language. And I love this social media campaign run by the New York City Department of Health. You can see we've got one on methadone, who happens to be somebody I know, not professionally, but socially, and then the other one on buprenorphine throughout the subways. And I'm hearing people that don't know anything about this stuff talking about these posters, and they've got vignettes you can see on TV too. So I think getting some of the positive images out there, whether it's through videos, through these, 2 minutes means that I've got until 8 minutes, because I'm going to end at 6. So I am basically about done, but I think getting these social media things out that are really positive can help. Getting your patients to go back and talk to places where they spent too much time before can help. And maybe people will start to feel a little more comfortable coming out of the shadows, because it's really hard to do that. I know a lot of people on maintenance that just don't tell. So thank you very much.
Hi there. Moving forward. My name is Jessica Halsey-Nickel, and I'm the founder of the Addiction Policy Forum. We have a very interesting network of members. We represent both patients and families. So we have folks in long-term recovery, but we also have a growing number of patients with an active use disorder that are a member of our organization. We have lots of family members, families who have a loved one who is currently struggling, families who have lost someone, all sorts of folks that come together. Our goal and our aim is to work towards a world where fewer lives are lost and we have more resources and tools available to treat and to survive this illness. We also are trying to build a patient advocacy organization to really advocate for our patients and where they stand. Even it's not just cancer and diabetes and Alzheimer's and autism, even the rare diseases have had a patient advocacy organization, like a whole national organization of rare diseases. And then each of the rare diseases have had their patient advocacy group. And yet we have 20 million Americans struggling with this disease. And we need to be fighting for research funds and new medications, right? Not just the ones that we have currently, but new medications, new developments, make more information available, better patient education. All these pieces are a core part of what the Addiction Policy Forum does. I wanted to come at this from sort of a different perspective and talk a little bit about some of our families and about what happens when we don't get it right. About what happens whether it's stigma or lack of access, lack of integration in our healthcare system, what this means to so many of our families. So this is my friend Amy and her son Emmett. Emmett loved BMX bike riding, super smart, was studying computer science in college. His mom was the Sunday school teacher at their church. He was a really good big brother to his two younger siblings. He started experimenting with K2 Spice, synthetic cannabinoids, in high school, early initiation, and he relapsed when he was in high school, and she did not know that. After she lost her son at the age of 20 to an opioid overdose, she found out that he had had 7 overdoses reversed in area hospitals. 7, right? HIPAA did not prevent notification of his primary care physician or to college health services. They could have asked, hey, can we call your family? Can we call your mom? You just died and we brought you back to life. There was a misinterpretation of what the HIPAA laws were. And we had 7 opportunities to save Emmett that we missed. This is Courtney. Courtney's dad, Doug, and her mom, Pam, are amazing. Really, really close family. They tried everything that they could to get Courtney help. She struggled with a heroin use disorder. When their insurance company told them that it was not life or death, so there would be no coverage for IOP, intensive outpatient or inpatient, they got advice from a local provider, a local stakeholder, that if they went across the border into Massachusetts and she was homeless, that she could get public care. So on the advice of that person, they kicked their daughter out of the house so she would be considered homeless for at least 48 hours. And that night she died on the streets by herself. She was 20 years old. Terry and Annette, like so many others who have a heroin use disorder, began using when they were 12 and 13 years old. They came from homes with an alcohol use disorder, a severe alcohol use disorder. They come from homes with domestic violence and abuse that is a result, oftentimes, of having an AUD. And their illnesses progressed very quickly into a heroin use disorder. In and out of prison and jail. My mom, Annette, went to prison when I was 4 as a result of her heroin use disorder. My dad was in and out of jail for most of his adult life and ultimately homeless in Los Angeles. My mom found a recovery path. I don't say sobriety and I don't say recovery because I don't think it's fair to sort of reject someone's, give them credit card when you ultimately have relapses on this path, because this is a complicated chronic illness. But she found wellness and better health care through a methadone program. Methadone saved her life. I had 19 years with her before she passed away at the age of 50 from a sudden heart attack. We do not talk about the long-term health consequences of this disease, the long-term health consequences of 2 heart attacks as a result of cocaine use disorder, the long-term health consequences of untreated hepatitis C because of IV drug use. My dad didn't find his way out of this disease. He died when he was 48 years old, homeless. Luckily, I found him at the end. About every 3 months, I would sort of go figure out where he was and clothe him and feed him and, say a prayer and find him again when the next time came around. But there were so many opportunities. There were so many missed opportunities for both of them when they were young, entering the criminal justice system, within the healthcare system, reaching out and seeking help. This is my why. This is why I do the work that I do every day. Addiction Policy Forum is my love letter I write to my mom every day. We can't bring Courtney or Emmett or Terry or Annette back, but what we can do is use our voices to make sure that we have better care for those that are struggling with this disease today and their families. So a little bit about understanding patient perspectives. And I'm going to use we terminology here because I love my members who have an active use disorder today just as much as I love my families who've lost someone, just as much as I love my staff and my families who are in recovery. We still have a lot of struggles when it comes to accessing care, to finding treatment. And I'll go through a little bit of them. First and foremost, our assistance for families. This is a pediatric brain disorder, right? So this is an illness that 90% of the time is going to begin in adolescence. Yet we have created a treatment program that's largely made for adults. So technically we have the only disease in America where we wait for it to worsen before we intervene. It's sort of like waiting and you'd be like, okay, I'm so sorry, Susan, but until you've had an amputation, we're not really going to address your type 2 diabetes, right? So we need to make sure that we have more resources available when this illness begins, and we need to take on dangerous myths like rock bottom, right? We have a inherent uneasiness about talking to even our own colleagues or loved ones about their drinking, right? Our substances of first use are alcohol, marijuana, and tobacco. And yet we have this like, well, maybe it'll just go away, instead of having systems and training in place, whether it's in our pediatrician's exam room or within our families and caregivers or our school system. 90% of the time, use begins in adolescence, and we need to make sure that we are intervening there. The other piece about the family component, when this is a disease that begins when you're largely an adolescent, we need to make sure that families have the right information, right? When we Google and we are looking for help and information, the first 83 pages are of bad actors and patient brokers that are more likely to take advantage of my families than they are to connect me to treatment. We have to really take on some of these myths and misinformation that we need a bed in Arizona, right? If this is cancer or Alzheimer's, you don't think, oh my gosh, I hope I can find that bed in Florida and liquidate my 401k account quick enough, right? We find you. We find healthcare, we find doctors. How do we change this so our families know to find a physician, that we find someone within the healthcare system that is going to help us navigate this disease, screen, detect, and intervene early so we have better health outcomes? That is what we need to work towards. The other part of I have 3 sons at home. 2 are teenagers and one's 10. And I can tell you from firsthand experience, there is nothing more powerful than a worried mom or dad, right? So if we start equipping our parents with the right information about how to prevent, right? This is a preventable illness. We can't say that about every disease that we're struggling with, but we can prevent substance use disorder. So if we start equipping families with more information and better information, I think that we can start to see much more informed families who are advocating on behalf of their loved ones to demand better care. Now, shifting a little bit to the patient perspective, there's some tricky parts of this, and I think we have to sort of meet that head on. We, as patients, we are not always very well behaved, right? When we are in an active use disorder, we're not always the easiest patients to have on your hospital floor. But that is the same for other patients, right? When you have cancer or you're in pain or you have the flu even and you're sick, not necessarily the best behaved patients either, but making sure that we talk about the physical consequences and changes within our healthcare system about our patients so you understand changed behaviors, changed priorities. You understand that this is a brain disorder, and it is also treatable. We need as much culture change and awareness within our healthcare systems as we do within our families and within our criminal justice system. The other tricky part of this is we largely don't think that we need help, right? We might have 20 million people struggling today, but about 95% of us don't think we actually have a problem, and it's usually an intervening moment or a person that is going to engage. So that means that the levers that exist that can help for early engagement need to be there. That's parents and families and employers. As we start to shift this earlier on, we have so much better outcomes. Navigation is very, very tricky, right? And it also is you have a disease and illness that is affecting the function of your brain, your limbic system and your prefrontal cortex. And yet I have to go to either this OTP or this OBOT or this doctor to get an MAT, but I don't know how to get the psychiatry help I need. I don't really know where I'm supposed to get cognitive behavioral therapy. Mind you, I don't have a place to live or a job, and the IOP structure they just put me on means I'm not really employable because I have to show up for a 9 to 12 session 5 days a week. We make this very complicated for our patients. We don't make this as complicated for other patient groups and other diseases, right? Other patient groups that don't have cognitive impairment. So how do we start to break down those barriers in that? I wrote a word down here. This is my speech for today. And I wrote one word down, discombobulated. That's what it feels like. It's like not a linear path. I love hub and spoke. It's like, here is how you get stabilized on your methadone program. And here are all the things that we have identified in the community. Because you know what most patients need? They don't need one medication if they have an opioid use disorder. If it was my mom today and I had a chance to redo this, I would stabilize her on methadone, and then I would move her to buprenorphine. And then I would probably do a medically assisted detox, so then I could put her on a long-acting injectable of naltrexone. And then I would make sure along the same time that I would get her into a CBT program, cognitive behavioral therapy, maybe CBT for CBT. You can do it online and at home. I'd make sure there's a contingency management component, so we're working with that same reward system within her brain to reward the good behavior change and make sure that there are quick sanctions that aren't about losing her children and they aren't about going back to jail. I would make sure that she had access to all the things that we need in the layered approach, similar to the things that we started to do differently with cancer treatment in like the 60s and 70s. We started sequencing and combining treatments for better results. And we need to do the same for our patients. We have so many tools in the toolbox, but we do nothing to simplify or explain that to our patients and their families that are trying to navigate such difficult care. So that's it. Thank you so much for having me today.
Hello, everyone. I'm Sarah Wattenberg. I'm from the National Association for Behavioral Healthcare, and we represent large health systems that run more than 1,000 programs in almost every state. I'm not going to talk about medication today per se, but about the system that surrounds and supports the use of medication. With that, the first thing I want to say is to remind and or urge everyone to understand that in order to strengthen treatment for individuals with opioid use disorder, we need to bolster and sustain the entire treatment system for all individuals with all types of addictions. The fact is, polysubstance use characterizes most substance use disorders. 80% of people with an opioid use disorder have another substance use disorder, and polysubstance use characterizes most fatal overdoses. 88,000 people a year die from alcohol-related deaths, and many emergency department admissions and deaths from opioid use involve alcohol. We also have something of around 40 to 60% overlap between mental health and substance use conditions, and opioid misuse is associated with higher rates of suicide. This is not to say that we shouldn't improve on broadening the use of opioid medications. They are not used enough, period. We should employ every technique and every strategy we have to improve uptake for this evidence-based practice. However, if we focus on opioid treatment alone, we will not solve the problem we are here today to solve. Similarly, if we focus on addiction alone without addressing mental health, that too is not going to be enough to solve the problem that brings us here today. The gold standard of care for treatment for opioid use disorder is to couple medications with psychosocial treatment and recovery support services. This model is the one that needs broad implementation. As we've heard, by the time a person has developed an addiction, they are in need of more than just medication to stabilize their physical dependence. People have lost their jobs, houses, families, friends, and medication alone can't address those problems. Psychosocial and recovery support services are also needed. This means that we need to support treatment models in which all medications are available and in which all of these psychosocial services can be delivered. There are two significant barriers to implementing this comprehensive gold standard of care. One is the workforce, and two is the financing and payment system. First, to the workforce. HHS projects, the U.S. Department of Health and Human Services projects a shortage of up to 250,000 behavioral health practitioners by the year 2025. Suffice it to say, we need more of everything, every discipline, every degree, in every setting. But equally important, and a big problem, is that we don't really know what we have in terms of a workforce, and therefore we don't really know what we need. The HHS projections do not account for geographical distribution of providers, which is a real problem for rural areas where they are already strapped for health providers and have high rates of overdoses. The projections do not include addiction medicine specialists, peer counselors, community health workers, or care managers. We don't know the extent to which mental health providers, like social workers and family therapists, provide addiction treatment. There is a misconception that all mental health providers can or do provide addiction services. Many do, but many don't. One study showed that many psychiatrists who medicate a patient for a mental health condition do not necessarily medicate that very same patient for their opioid use disorder. All of this is to say that the stats and our understanding of the workforce is very unclear. The other problem is that even if we knew what we had, we don't actually know what we want. We don't know what the ideal workforce looks like. How many providers do we need? And how does that change based on the treatment model, the setting, the region, and the availability of medications? Not all addictions have medications that can treat them. I can't underscore enough how important this is. We have a lot of money going into communities right now to expand treatment. But if you don't know who to train and how to train and educate them, you really can't expand your capacity. Payment policies are the biggest threat to the workforce and to treatment capacity for opioid use disorder. There are three main issues. First, payers do not cover the continuum of providers and types and levels of care. There are routine limitations on residential and intensive outpatient treatment, even where ASAM criteria suggest that they are necessary and provide the best hope for long-term recovery. Many payers do not cover medications for opioid use disorder or do not pay for all types of opioid use medications. There are Medicare, commercial, and state Medicaid policies that still will not pay for methadone in opioid treatment programs. Counseling sessions are too limited, but counseling helps people get onto medication, adhere to their medication, assess risks and benefits of the medication, help them get into mutual support groups, all of which are associated with better long-term outcomes. Peer Peer counselors and community health workers are typically not even eligible for reimbursement, even though there is evidence that they too contribute to long-term recovery. The second issue is that when services are covered, they are not covered for a long enough period of time. Payers put time limits on OUD medications that force patients to taper off when that is not clinically desirable and could be downright dangerous. Reimbursement continues to be modeled on an outdated notion of short-term episodic treatment when in fact substance use disorders are long-term chronic conditions. It can often take 5 years for someone to settle into a relatively stable period of recovery. Third issue is that providers are not paid well enough. Historically, behavioral health providers have received far lower reimbursement rates than other specialty providers with similar education, training, and experience. Recent studies show that these discrepancies continue to exist. This is true for psychiatrists and social workers and other workers in the workforce. Rates are so low that addiction providers don't want to collaborate with payers. They don't take Medicaid or Medicare, and they don't enroll in insurance networks. A vicious cycle ensues in which payers complain that they can't find qualified providers, and qualified providers drop out of the system because they are not compensated fairly. Low rates have made it difficult to recruit a high-functioning workforce, but without a high-functioning workforce that is accessible through insurance, we're not going to be able to expand treatment capacity. On a happier note, there are some new payment methodologies that are emerging that are trying to address some of these issues, and I think that we will hear about that at our next session. Many of the issues that I've talked about today, and in fact that others have talked about, are in a paper that NABH issued. It's on their website, nabh.org/pathways, and the paper is Pathways to Care. Thank you.
Well, thank you very much for those wonderful presentations. Okay, we're getting some questions. So let's go back to the poll. Can we bring that up? All right. So, all right. So, Sarah, your point there at the end. So the biggest issue that folks agreed needed work was the examining coverage and payment strategies for the kinds of services that our patients need. So let's start there. We heard a lot about recovery support, something that I think maybe doesn't get talked about enough and is really important for so many individuals with opioid use disorders and other substance use disorders. And I was going to just turn to the group and ask, what ideas do you have, what models do you have for how do we make these services available? How do we parse them out so that we can make sure that these individuals who provide these services are adequately reimbursed? Because it seems like much of what's needed is kind of broad and diffuse and not as nicely defined as the standard kind of diagnoses and treatment visits for medical conditions. Anybody want to?
Well, I'll start and say, we fund an awful lot of services out there that are, I'm from New York, and we fund a lot of services in New York, more so than many states, I will admit. But we fund a lot of services that are not evidence-based. And, I think insurance companies balk, I'm not defending them, but I think they can balk at what are we actually paying for. So I think guidance on this is what people actually need. We know the medications are there. We know that some behavioral health services are more effective than others. We know that most people need meds, not beds. They need, they really need good outpatient services. Instead, we're spending a lot of money on inpatient services for people that do have adequate housing. So I would say that there is a problem, that there's too much paid for that's really not evidence-based, and switching over will be hard, but I think that's the place we need to go.
And are you saying that we need better research on these interventions, or you think we have the research, we just need better payment policies?
I think we mostly have the research.
We have the beginnings of research, but it's been sort of a resource issue. A lot of recovery services came out of the grassroots on the community level. They've been evolutionary, mostly in the past 20 years. We know that if somebody can go to the best treatment in the world, and if they leave treatment and go to back to a community where there are no recovery supports, their chances are not great. So we're talking about recovery housing, we're talking about peer support workers doing coaching, we're talking about non-clinical support groups, we're talking about collegiate recovery programs and recovery high schools, we're talking about recovery employment programs to help people connect back into their life, into the community. So yeah, we don't have evidence-based practice yet. We have practice-based evidence, because we know what's working on the ground. We just have not had the gauge and the resources to develop promising to best to evidence-based practices. So, but I think that is something that is holding back the sort of full embracement of recovery support services, even though we know that they do work over the long haul.
So a couple things just to talk about why this is so critically important to make sure that our patients are successful. And we do have actually an amazing amount of research about this, but we usually just apply it to a different population group. We know that prosocial engagement and attachment are two important protective factors for adolescents from a variety of things, including developing a substance use disorder. This is also why recovery services or other programs, whether it's a recovery high school or a collegiate recovery program, why that's so incredibly important. Many times when you are coming into recovery, you have to make an entirely new peer group. And that is not hard to do. Imagine today if you left this room and you couldn't be friends with any of your current peer group. You had to build it from scratch. Imagine on top of that, if part of your issues that you had to work on with your psychiatrist was some of your family connections, maybe use patterns within your own family, some difficulties that are there in the home. So this is a complicated road that you are on when you are starting to complete treatment and build your long-term recovery plan. And the attachment and prosocial engagement, fancy words for saying you need to belong to something that is healthy to you and have other healthy peer relationships. There are programs that are low cost. There are the clinical pieces with a peer recovery support specialist. I agree, we need to make sure we're following evidence and have clinicians that are trained. That can be incredibly helpful. But for the long haul, having community organizations, like recovery community organizations, programs in your colleges, your high schools, it doesn't sort of matter where this is, but we need to make sure that we have the long-term care to help form positive attachments for 23 million folks that are trying to navigate this disease in the recovery phase.
I'll just speak quickly to the peer recovery and sort of ways to build out that as a workforce. Part of the issue is that different states credential people differently, especially in the peer space. But more and more states are now recognizing peers as eligible for reimbursement under the supervision of licensed professionals. And I will just plug a favorite program of mine, the Department of Labor Apprenticeship Program, is known for helping to sponsor the skill development in a range of job classifications. And they have recently started to try and build out using the apprenticeship program to train medical assistants, certified nurses, and others in mental health and substance use training. And it's a great program, and it can lead to national certification for peers, and there are ways in which they can help fund it, partnering with the employer. And I always think about those programs when I think about developing peer recovery coaches in hospitals, because hospitals work very closely with their unions, and the unions are very familiar with working with the Department of Labor in training people to raise their level of skills. So.
Some of us work in the South and we don't have unions. That's just a little poke at North Carolina. So I'd like to have a few minutes for questions. Here's one that came up, and I'm going to encourage folks, if you have a question, to line up on either side at the microphone. But I'm going to put this one to Sharon, but anybody can help her out on this. Why is naltrexone not used as widely as Suboxone or buprenorphine, given recent studies showing comparable effectiveness without physical dependence?
Well, I think there's a couple things going on. The studies that have shown comparableness showed that not on intent to treat, but on the people that actually
what does that mean now?
able to start it. So because you were required to have 7 to 10 days of abstinence from opioids before beginning naltrexone, it can be really hard to get from here to there. And so in this clinical trial where people were supposed to get this one versus that one, many of the people couldn't even begin the naltrexone. So for those that did begin it, that was fine. For the period of time they looked at them, it did well. But we still don't have the body of evidence showing that naltrexone reduces mortality, reduces HIV, reduces hepatitis C. Maybe we will get there, but for the moment, we're in a crisis, and so using the evidence-based medicines makes the most sense. That being said, there are places such as Vermont, such as some of the prisons that offer, well, not many of the prisons, but Vermont, and some other places that offer, Rhode Island actually, offer all three, and they get really low uptake. Some of that might be because the patients aren't properly educated about naltrexone, but there's myths about all three medicines, but the interest just hasn't really been there. So even in places where they're all offered, it's just not getting the uptake.
Okay. Let's take a question.
Yeah, hi. A comment and a question for you. The comment
If you could identify yourself as well.
Syra Sultan with Connect4 Strategies. I actually do some work in Alzheimer's as well, and a couple of you have made references to Alzheimer's. We pay for, there may be not enough evidence at this point on some of the other interventions, the social interventions, which is very much a deal in Alzheimer's as well, but we do cover the medications. And so to the point about evidence, is there enough evidence on the medications? There's broadly sort of widespread agreement that there is strong evidence for the medications, buprenorphine, as well as the others you have mentioned, and yet we find states, for example, over and over limiting access to the medications and cutting them off in not evidence-based ways, right? We stop them at 30 days, at 60 days, require more paperwork to be able to stay on them. So that I do think there's a policy focus on that piece that's important because the evidence is there to support rigorous use. My question is, no one today has talked yet about pharmacists. I wonder if there's any role you envision that pharmacists could play in this space. Thank you.
I want to just clarify, just to make sure I understand your first comment. When you say states are limiting duration of therapy, I imagine you mean state Medicaid programs, because in general, states don't control drug prescribing. State Medicaid programs, right. Okay, very good. Okay, a role for pharmacists, that's something I could address, but I'd be happy to hear from our panelists. Okay, I get to say something. All right, so I know NIDA is investigating this possibility, and I personally am participating as a clinician in a research trial. Right now it's just a simple feasibility study where at our setup we have 3 different practices that have each partnered 2 clinicians with 2 retail pharmacists, not hospital-based or clinic-based pharmacists, but retail pharmacists. We trained them in how to do MAT, and they're doing MAT under our supervision. So I have 2 that I work with. My patients who enroll in this will get 6 months of treatment there, and specifically they show up there, they get a urine drug test there, they're checking our state PDMP, they go through a checklist looking for withdrawal, cravings, they look to see has the person had any use, any worrisome prescriptions, and then they communicate back with me, and then we provide the prescription of the medication. It's filled immediately for the patient. The dropout rate so far, for what we're seeing, we've had about 55 or so patients between the 3 practices who've been enrolled. Only 1 has dropped out. It's amazingly low. And that individual had a parole violation. He was one of mine. I don't know why he violated his parole, but he cut off his ankle bracelet. They caught him, and then he could no longer participate in the study because he was incarcerated. But he was doing okay in the study, not great. But it's been really quite remarkable to see how well it's done. It was terrifying, I think, for the pharmacists to get started in this business, but they were people who volunteered and stepped up. And I think this is a potential model. I understand that NIDA is going to fund a full-on randomized controlled trial looking at a traditional model versus a retail pharmacy-based model. So stay tuned for that.
Could I just add a little, that's really exciting stuff. On a lower level, all over this country, pharmacists can provide now naloxone to people without them coming in with a prescription. Some places they can sell needles. So in New York State, we're trying very hard to get pharmacists educated, not as exciting as that, because they may be the source of information about these medications. They are partners in care.
And they often have a standing order that they can operate under when they identify somebody who's, for example, maybe not getting insulin but buying syringes, or somebody who's getting a dangerous combination of an opioid with a benzodiazepine. They can suggest, hey, you could really use some naloxone. I can provide it to you under a state standing order and train you or your family in how to use it.
Important
I
partners,
absolutely
for
agree.
sure.
Yeah, and certainly clinical pharmacists, can play a tremendous role. Okay, we have very little time left, and I want to allow for your question, and then we're going to wrap it up.
Just quick question. So sometimes we talk about kind of recovery and treatment as being two separate things, and I wonder if you could just comment on kind of how recovery and treatment actually integrate across kind of the continuum of services.
So I think the distinction that's often made is that treatment is in a clinical arena and recovery is not. But I think, like, when does recovery begin? So ideally, it begins in treatment. The difference between a recovery plan and a treatment plan is really who generates it and who owns it. So if it's, the recovery plan is really more person-generated with the assistance of a peer or a professional, but the person owns that plan and sort of takes that plan with them, as opposed to a treatment plan that is sort of in a treatment context. So I think it's a really good question. Where does one begin and the other end? I think they definitely overlap. But we also have a lot of people who don't go to treatment and go right into a recovery arena. So it's complicated, but worth thinking about, worth drawing a diagram for.
So one of my favorite programs that we have a spotlight series for our families where we spotlight innovative things that are happening all over the country in lots of different categories. And a program called Aware Recovery Care that Blue Cross Blue Shield in New Hampshire and Connecticut actually helped design with a provider on the ground. So it's the home visiting nurse model, which we actually are seeing an uptick in using that within child welfare cases, CPS cases that are related to a parent's substance use disorder. So you have that home visiting nurse who is the medical home, but in the house. But it's not, I think we make mistakes when we disaggregate treatment and recovery plans. When my grandma broke her hip last year, there wasn't like the treatment and the surgeon who replaced the hip and then a whole separate, oh, you probably should do these things or not do these things to make sure that you can walk again. This is an integrated plan to make sure that the patient outcomes are positive. Right? It is no different from our patients that have a substance use disorder. So Aware Recovery Care, it's not just the connection to the MAT provider. They might need to go to an OTP, they might be in an OBOT, whatever that might be. It might be not a very severe substance use disorder, so maybe a medication's not necessary, but they need to have counseling and some psychosocial components that are there. But it is that practitioner, it is that nurse that builds the entire plan that is at least 12 months long, if not longer. We know that our current average dosage, 28 days, is sort of this mythical, magical number that you walk out of an inpatient center and you're magically fixed. But having sort of the long-term plans that combine treatment and recovery for the holistic look at what that patient needs to be healthy and well. That's what I think our goal needs to be moving forward.
Could I add one thing?
Okay, this is the last word, then we're going to wrap it up.
Oh, okay, I'll let you have the last word.
No, you can have it.
I just want to point out that I have patients and colleagues and folks at needle exchanges that actually don't like the word recovery because it just doesn't include what their experience is. And so I think it's a great word for some people, but I think that's just something to be aware of, that it doesn't describe everybody that has stopped using drugs, and there are those that continue to use drugs that use it on themselves. So it's a fluid word.
I want to thank my 4 outstanding panelists for some really enlightening thoughts and conversation, and thank you for your attention and your great questions as well. Greg, are you going to come up and we'll get some instruction about timing and lunch and the like? Just here.
You need to write your question before because I have one
pertaining to this right here.
Okay. Can you come up after?
Sure.
We're between this group and lunch, so yeah, come up and talk to us. Yeah, okay. Want us to make a few comments? Yeah.
Okay, thanks. It was a great panel, great session. I just want to, we are going to go to lunch right now. As I said before, lunch is on your own. There are a lot of restaurants and areas right outside of the building, and I think we have a list at the table out there of some of the restaurants. We'll be reconvening back here at approximately 1:35 sharp. We'll look forward to a great conversation with the afternoon sessions. And if you want, you're welcome to bring back food into this room as well. So have a great lunch, and we'll see you soon.
and welcome to the moderated discussion about various populations that are served in the opioid, need service in the opioid epidemic. I'm currently, my name's again Regina LaBelle. I'm currently a visiting fellow at the Duke Margolis Center for Health Policy and also do work through LaBelle Strategies. So we spent the morning talking about innovative approaches to opioid use disorder treatment and access, and some of the barriers that providers and patients may face. And so in this session, we're really joined by some great people who do excellent work among special populations, and many of whom are kind of typically underserved or overlooked in the opioid epidemic. So we have providers who are working on delivering care to adolescents, pregnant women, American Indian and Alaska Natives, and then incarcerated populations. So our panelists will provide some brief remarks as we did earlier today, and we'll check in on our audience polling, and then have, at the end of the discussion, have some moderated Q&A, and we'll try to keep everybody on, keep us back on schedule. So the polling question that we wanted everyone to, I'd like everyone to weigh in on is, it should come up now. It's basically recognizing that there's no one-size-fits-all approach to opioid use disorder care delivery. What's the highest priority issue that must be addressed first? So if you log in, this should come up, and it has a variety of responses to the question that you can see. Does everybody take a look at that? And then the poll will close and we'll talk about the results following our presentation. So I want to save a lot of time in giving the broad, a lot of detail about each of our esteemed panelists. So first we're going to start with Mark Fishman, who is the medical director at Maryland Treatment Centers, who focuses on issues relating to juvenile populations. Kayleen Cly, who's an assistant professor in the Department of Family Medicine at University of Colorado, and she'll talk about pregnant and parenting women. Kaylee Fretland, a clinical pharmacist with Indian Health Services. And then lastly, Jennifer Clark, who's the medical director for the Rhode Island Department of Corrections. So I'll turn this over to each panelist then for some remarks. Thanks.
Well, good afternoon. My name is Mark Fishman, and I'm an addiction psychiatrist. I am medical director at a Maryland regional community behavioral health provider. So there I do both clinical work and program administration, and then I'm the faculty at Hopkins where I do research in SUD, mostly OUD. And I'll focus in the special population of youth, or Utes, as they say in Brooklyn, right? In both adolescents and young adults. I'm not sure exactly where adolescence actually ends these days. Does it go to 25? Does it go to 35? Does it go to 75? But anyway, the idea that it's not so much a chronological cutoff, right, but it's a developmental span that encompasses those issues that you all know too well. And why do we have to care? Well, for a couple of reasons. One, because in this current opioid crisis, young people, particularly for this statistic, young adults 18 to 25 are disproportionately affected by the crisis and are the area in the lifespan that have the highest per capita involvement, both in illicit use, non-medical use of prescription opioids and of heroin. So they really are at the forefront of this epidemic. And then the second reason, and I think we heard Jessica Nichol talk a little bit about it, is that we think of SUD, or we ought to be thinking of SUD, as a developmental disorder of pediatric onset. And where do most people start using? It's in their youth, in the second decade of life, mid-teenage to young adult years, and SUD prevalence across all substances peaks somewhere around age 20, at the beginning of the end of second decade, beginning of third decade. So in the sense of our belief that intervening early before the disorder progresses to its most stage 4 or most severe forms, the earlier you intervene in a chronic, progressive, remitting, relapsing illness, the better we can do. So that's why we have to care. What are some of the barriers? Well, young people are not just short adults, right? They have their own developmental needs. They are in some ways similar to older adults, but in some ways dissimilar. The issues of maturation or immaturation, as the case may be, the sense of young people's being invincible and having waxing, waning, maybe mostly waning motivation about care, being disproportionately, I think, burdened by how unengaging and uninviting and how un-youth welcoming and youth friendly care typically is. A sense of their developmentally normative, but still problematic, pushback against what they see as the subjective restrictiveness or intrusiveness of their parents' or other adult caregivers' involvement in their care. Their sense that I'm 18 in one day, I'm all grown up, and this is none of mom's business, and I've got this, and leave me alone and the like, when they certainly, as we know, do depend on developmentally on the support of adults. And also a barrier being that we don't do as good a job, anywhere near as good a job, I believe, as involving families as we ought to. We talk about addiction in treatment circles as a family disease, but I think mostly it's lip service. And it's hard to do, and there isn't sufficient training and competence, and it's difficult to have the dual agenda of dual stakeholders, families and young people. And one of the areas where that particularly comes out is what I believe to be an over-rigid concern for confidentiality, not to say that confidentiality isn't a core value of what we do in addiction treatment, and investing in the emerging autonomy of young people to carry out their own journey into recovery, also a core value. But I don't think it has to be incompatible to be able to empower families to be involved and think through these complex communication issues. And just to make a maybe oversimplified joke about it, what is the thing I hear so much from families is little Johnny or little Susie is living at home, mom is paying for the treatment, mom has dropped them off at group and sitting in the parking lot, and then calls the counselor to say, how's little Johnny or Susie doing? And they get the stock answer, we can neither confirm nor deny that a person by that name is receiving care at this institute. And I'm being silly, but the notion that we're not only not youth welcoming, but we're perhaps not family welcoming as well, and I think we can do a better job. So just for the next minute or so, talk about some programming that we're working at our center in Baltimore to try to address some of these barriers. Whether we're successful or not, stay tuned. But the notion that if we focus on longer-term enduring care, as was talked about before, in which we think about this as a marathon, not a sprint, that we don't have surgically curative approaches, so that 28-day rehab does, although maybe very useful and bed-based care a necessary part of the continuum, by no means a sufficient part of the continuum, that is enduring longitudinal treatment, which we don't really have a model for, I think, when you think about young adult and adolescent care, in which a delivery system quarterbacked by somebody, maybe it's a doctor, maybe it's a counselor, I'm agnostic, but quarterbacked over time in the sense of being able to follow people waxing and waning, dropping in, dropping out, which is the rule, not the exception, over time, just as we might manage any chronic illness, with a reluctant and difficult to engage sick person who isn't always the best master of their own ship in terms of seeking, utilizing, and making good judgments about treatment. So 3 areas, we call this youth opioid recovery services, or yours, just because you got to have a brand name, right? And so the 3 principles for us are family engagement, so thinking through the issues of how to get families involved and encourage them, using assertive outreach, that is, rather than passively waiting for people to reach bottom and come to get care and access clinic-based care when they're ready, reaching out to them and doing social marketing and chasing them. And then the third, which is kind of a new thing for us, is adapting and adopting stuff stolen, if you will, from assertive community treatment in chronic and persistent mental illness, say for the treatment of schizophrenia, where we're doing home delivery of long-acting injectable medications using either naltrexone or buprenorphine, and going into people's homes and saying, not ding-dong Vivitrol calling, or ding-dong Sublocade calling, or that kind of thing, just as you might do with long-acting injectable antipsychotics. And on the assertive outreach, it means calling and texting and Facebooking and spending a lot of effort trying to engage patients and their families. And on the family engagement side, it means paring it down to very concrete elements. And we focused for the moment, kind of as the thin edge of the wedge, on medication adherence. Not that medications are the only tool or even the most important tool, but we certainly see relapse prevention medications as critical in an integrated, holistic kind of implementation. And one of the things that's clear to me in my experience over time is that people who aren't in treatment or treatment providers get kind of bleary-eyed about what is it we do in treatment. Everybody sits around and holds hands and talks about their feeling, and who knows what the secret handshake is. I'm being silly, but every mom or dad, but mostly moms, have had the experience of having to wrestle with a 4-year-old with a fever and an earache who didn't want to take the pink medicine. And although it may be different, somebody who's this height versus somebody who's 250 pounds and this height, it's a familiar kind of territory of negotiating medical service utilization with a person who's sick and a person who is truculent and irritable and not themselves and doesn't know how to access care and needs guidance of a mom or a dad. And so that's kind of before we get to structural family therapy and other things that are very difficult, although important, just the basics of medication adherence as a starting point. Anyway, we've published a small case series. We had some preliminary positive results, and we're now in the field with a small randomized controlled trial, and we'll see. And if, as I suspect, we'll see some benefit for at least a high severity group of people. I mean, it sounds like a very expensive and very intensive kind of intervention, and just like ACT is not for everybody with a mental illness, parsing out who needs the step up to that level of intensity, I don't know. But if we can demonstrate that it has some merit, then the next question is, well, how do you scale it? How do you pay for it with Medicaid pennies and the like? So anyway, that's a little of where I've been thinking, but just to come back to first principles, this is a really critical target audience, a target patient population. Got to include families, I think, if you're going to reach them. Got to think developmentally in terms of specialty services that target young people in a way that can engage them different from the way that you target adults. And enough. And go ahead.
Nice job. I'm going to use my slides. Somebody beat me to the punch. Well, thank you so much for having me, and I have to thank my colleague, my nurse practitioner and partner in crime at home, and our nurse, Anna. So for any of you in clinical practice, you know that actually your clinic nurse runs the ship, and so she is manning the ship today, and I am indebted to them for taking care of our patients in my absence. So I get to talk with you a little bit about pregnant and mothering women. And I just wanted to start with a few, although I sometimes feel like we get a bit numb and a little fatigued with watching all the climbing graphs related to opioid use and overdose death. I think that there's some really important data that's come out of our work in Colorado and several other states regarding the specifics of substance use in pregnancy. So a few select highlights and data points. We talked a little bit about, in one of the earlier presentations, really about the high rates of trauma, co-occurring trauma in people with substance use disorder. And we see even higher rates of co-occurring childhood sexual abuse, childhood physical and emotional abuse, neglect, and intimate partner violence, either previous or ongoing, for women, pregnant women with substance use disorder. We also see women who have, with a substance use disorder and specifically opioid use disorder, sometimes unpredictable fertility. So it's very normal for a woman with an opioid use disorder and or alcohol use disorder to stop menstruating. And so she believes that she cannot become pregnant and so has very low uptake of reproductive health care. Many women are dismayed when their menses return within the first couple months of being sober, kind of a a return to health that's not always welcomed. But really many women, because they have not had a need in their mind for reproductive health care, have not had utilization of contraception during their time of active use. The recommendations that you see here have been widely accepted by almost every group that is interested in providing prenatal care and perinatal care to women, is universal screening. And so universal screening should mean a conversation, not a urine or biological sampling toxicology test. There still persists kind of this idea in some groups and in some practices that we should start just including a urine toxicology test with women's first prenatal care visit. And that's in existence, and it is fraught with problems. Urine is not perfect. It has many false positives, and it serves for many women, especially women that I'm taking care of now will describe, that really scared me, and so I never went back. I didn't go back for prenatal care because I saw those results come up, and I didn't want my provider to talk with me about them. So when we have toxicology testing that precedes a screening conversation or a screening tool, a validated electronic or paper and pencil tool, I feel like sometimes we've already shot ourselves in the foot with keeping that woman engaged in care. The recommendation, as for almost all of the people groups that we've been talking about today, is use of pharmacotherapy, not recommendations for detoxification. There still persist some programs that offer detoxification for women in pregnancy, and the difficulty has been obtaining follow-up data to see really if we use the endpoint of delivery as our target, as we'll see in a moment, hopefully a quick moment if I can speed myself up. You're going to have to tell me when I'm bumping up against time. That really, if we don't extend and in fact increase support into that postpartum period, we sometimes are at higher risk for losing a person either to treatment, having that person fall out of treatment, but also potentially at higher risk for overdose death, not only after detoxification from opioids, but also as detox as the only intervention in pregnancy. And then all care providers. So I love the multidisciplinary vibe that we've had going today, really that everyone has a stake. And our program in Colorado, we've really kind of had no wrong door as our tagline, right? That however this woman shows up, whether it's in an incarcerated setting, if it's with social services, if it's in the emergency department, however she appears on the radar, that really there's no wrong way that she can present to be able to be funneled into treatment services as she chooses. Okay. Some of the barriers, stigma for pregnant women, I would kind of posit, is even greater than stigma in general for people who use substances. I've even heard from other treatment providers that, talking about their own feelings of taking care of a pregnant woman, how can she do this to that baby? Doesn't she care about the baby? And I wish that pregnancy was the cure, right? So pregnancy cures one thing, and that's infertility, right? So pregnancy, for the rest of us, doesn't cure what ails us, right? It's a motivator. It's often a very strong motivator to make behavioral changes or health changes that we've been meaning to for a long period of time. But it's not the cure, and we shouldn't confuse pregnancy, particularly pregnancy as a temporary state, with treatment, right? It can never substitute for treatment just because it's a strong motivator. Okay. Many women, I'm going to skip down a little bit, but many women associate any detection of use with immediate removal of custody. And so for many women, actually, that I take care of, they were removed from parental custody, and they maybe are first or second or third generation of people who've had some kind of social service involvement in their family. And so for them, the reality is, if the social worker knocks on your door, you may be leaving that day with whatever you toss in a bag. And that's a very frightening reality if you are now the parent and wanting to maintain custody not only of maybe your current pregnancy, but other children at home. And so this is from Colorado. Some other states have also been recently publishing their mortality data. So I have the honor really of sitting on our Colorado Maternal Mortality Review Committee. And so we review every death in pregnancy and 1 year postpartum that occurs in Colorado to really try to make sense of what happened and then come back with system and provider and patient care recommendations so that death isn't in vain. And what we found is similar to other states, that our number one cause of maternal mortality was and continues to be accidental drug overdose. And I really think of this as like kind of the warning sign, right? So when we're seeing women die in pregnancy or 1 year postpartum who are probably at the peak of their motivation for change and maybe at the peak of their ability to access services, there really is something going on that we're missing, right? So if we have all of our kind of data about increasing access to care for pregnant women, but this continues to be a leader of maternal mortality, it makes us kind of need to relook at how are we doing with really bringing women into treatment and life-saving treatment at that. So this timing is everything really is true for postpartum women. So this concept of the 4th trimester, so ACOG, has come out with new recommendations really that we should not let someone have a baby and then see her 6 weeks later in clinic, right? We should see her much more quickly, especially when we think about the risks within those first couple weeks for mood changes, difficulty with breastfeeding, pain, right? And so that's a start. But we can see for our women who died from overdose that really that 4th trimester needs to extend to the full year postpartum. And so when you look at this graph, that green and blue portion are deaths that occurred within a month to 1 year postpartum. And in fact, the further you get out from delivery, the higher the risk seems to be for relapse. So this makes us question, how are we doing with having pregnant women as a priority population? Most states have said we really want to have women be, no barriers to treatment. They can be first in line. In fact, that sometimes truly means cutting the line for admission to a methadone treatment program or buprenorphine care. But so far, the data has not been as reassuring as we had hoped. And we're indebted to Dr. Turplin, who published some really important data showing that although we have many mandates that women should be able to access treatment, their utilization of treatment is no more likely than if they were not pregnant. And so what we need is further integration of services, really making it impossible for someone to show up pregnant with an opioid use disorder and not access, or at least know where to access services. So comprehensive and integrated services continue to be where we're all headed. And this needs to include reproductive health. So when women are using substances in pregnancy, I would say almost 0% initiated substance use during that pregnancy, right? What's happening is women are using substances, becoming pregnant, often unintentionally, and then continuing on and showing up as these numbers. Okay. A quick note, these are some of the integrated model cares that are out there, but really for women who are pregnant, and as we've spoken about, pregnancy, thank goodness, is not it's not a permanent state. So women move in and out of these circles, right? We have some really beautiful integrated service treatment models that across the nation that I think we could learn from, but taking the best parts of all of those programs and trying to come up with an even more extensive network of care providers, much like we have for things like reproductive psychiatry, so mood disorders in pregnancy and postpartum, I think really needs to be our next step. We also need more research about naltrexone in pregnancy. This was one of the recommendations that has come out recently that we really just need to know more so that we can offer pregnant women potentially an expanded armamentarium of medication-assisted treatment. And then continued policy reform that continues to remove language and remove punitive measures for pregnant women who use substances so that they'll have decreased barriers and decreased difficulty accessing care as they're ready. Thank you very much.
All right, good afternoon, and thank you guys for having us here as a panel discussion. And this has been a very valuable afternoon with the multidisciplinary discussions, discussing the opportunities and barriers. But my name is Kaylee Fretland. I'm a clinical pharmacist for the Indian Health Service, and I'm here today on behalf of Indian Health Service, representing the Indian Health Service's National Committee on Heroin, Opiates, and Pain Efforts. I have no disclosures. The mission of the Indian Health Service is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. So who is Indian Health Service? I want to give you just a brief overview. So Indian Health Service serves members of 573 federally recognized tribes within the United States. This is approximately 2.3 million American Indians and Alaska Natives. Of these, IHS is divided up into 12 regional or geographic areas providing these services. And these are provided at either federal facilities or tribally run healthcare facilities and make up a mixture of healthcare clinics, hospitals, there's 134 Alaska Village clinics, health stations, and urban programs. So we're a diverse program. The American Indian and Alaska Native people have long experienced, I apologize, this is really difficult to see this slide. But the American Indian and Alaska Native people have long experienced lower health status when compared to other Americans. Lower life expectancy and the disproportionate disease burden exists because of broad quality of life issues rooted in economic adversity and poor social conditions. The Indian healthcare system approach to opioid use disorder treatment must be grounded in principles of trauma-responsive care and social determinants of health, similar to what we've already heard today. This slide captures a depiction of the impact of historical and vicarious traumas, poverty, as well as common stereotypes inflicted on the American Indian and Alaska Natives, and the potential impact on their health outcomes. The IHS awareness of these factors is interwoven into our opioid strategies to foster autonomy. The higher burden of health disparities increases the risk among American Indian and Alaska Natives for serious persistent mental illnesses and increases the risk of substance use disorders. We have well-published data from the CDC. This particular data comes from was reported for 2015, but it indicates in 2015 that American Indians and Alaska Natives had the highest drug overdose death rates. For metropolitan areas, this was 22.1 per 100,000, and non-metropolitan areas, it was 19.8 per 100,000. Additionally, they also had the largest percent increase in the number of deaths from 1995 to 2015 amongst all racial and ethnic groups in the United States. In non-metropolitan areas, this was a 519% increase. So today's discussion focuses really on HHS strategy number 1 and the collaborative approaches Indian healthcare is using to improve access to prevention, treatment, and recovery services. So the Indian Health Service developed the National Committee on Heroin, Opiates, and Pain Efforts Committee in 2017, and this evolved from the Prescription Drug Abuse Work Group, which was started in 2012. It's a multidisciplinary team made up of physicians, pharmacists, behavioral health providers, nurses, epidemiologists, and injury prevention specialists to promote appropriate and effective pain management, reduce overdose deaths from heroin and prescription opioid misuse, and improve access to culturally appropriate treatment. So as part of the HOPE Committee's goal to improve access to culturally appropriate treatment, access to medication is a vital component. The first is to increase access to FDA-approved medications in support of recovery. IHS has added buprenorphine, naloxone, and naltrexone, both the oral and the extended release formulations, to the National Core Formulary. This now requires federal Indian Health Service pharmacies to have these available and dispense these medications pursuant to a valid prescription from an authorized prescriber. The second is to expand and share best and promising practices surrounding MAT. Collecting and publishing these promising practice examples from the field fosters and promotes collaboration and support for service units and providers. Thirdly is to encourage development of local action plans to coordinate access to services. These local action plans should evaluate the current MAT capacity and identify local strategies to facilitate and coordinate across access to MAT. This will be required through a special general memo. Currently, IHS lacks the infrastructure to create inpatient and residential treatments, and we partner with tribes to increase access to these services. Additional resources are necessary to help facilitate, especially in our rural areas. Next, we need to encourage the development of integrated programs that include behavioral health, traditional healing, and cultural practices. An integrated care model for opioid use disorder provides a holistic approach with the full continuum of care. IHS is evaluating the impact of integrated behavioral health and collaborative care models currently. And lastly, to provide guidance for American Indian and Alaska Native pregnant women and women of childbearing age with opioid use disorder, IHS has collaborated with the American College of OBGYN to create a guideline surrounding care specifically for American Indians and Alaska Native pregnant women and women of childbearing age with opioid use disorder, as well as partnered with the American Academy of Pediatrics to create a best practice guidelines surrounding the management of neonatal opioid withdrawal syndrome. So as mentioned in the previous slide, integrated programs should include traditional healing and cultural practices for American Indian and Alaska Natives. American Indian and Alaska Natives combine traditional healing practices with allopathic medicine to promote health and well-being through psychosocial and spiritual wellness models. These practices vary by tribal community, remember 573 federally recognized tribes, and the access to these services can vary as well. However, these integrated practices have qualitative evidence that demonstrate improved addiction outcomes. Some examples include healing ceremonies that integrate prayer, sweat lodges, songs, music, and dance into wellness, talking circles to share resilience and empowerment, storytelling and prevention activities that blend a connectedness to the earth and environment and overall healing and wellness. Next is workforce development, which as we've talked about today, but it does play a key role in improving access. So expanding staff capacity within IHS to support MAT services is currently being done through a required essential training and pain addiction online module. IHS provides a weekly tele-echo video conference allowing frontline clinicians to consult with experts in pain management, addiction, and behavioral health. And additionally, IHS has partnered with the American Society of Addiction Medicine to provide provider booklets on MAT and offer half and half training on pain and addiction for our providers. Next, we need to create a culture of trauma-responsive care, and this is vital to our workforce and the patients we serve. IHS has partnered with the University of New Mexico to develop and implement a training curriculum related to trauma-informed care. Providers working with American Indian and Alaska Native populations should have a basic understanding of the impacts of colonization, Indian relocation, and boarding schools, and the impact that they've had on our patients. Our workforce needs to still be trained on early identification and screening with such tools as DAS-10, NIDA, 4Ps for substance use disorders, along with brief intervention and referral to treatment. We're developing software enhancements to the electronic record to capture substance use screening results and track referrals to treatment for pregnant women and those of childbearing age to really continue that follow-up so that we're tracking them throughout their entire care. And lastly, increasing both patient and community education and awareness about opioid use disorder and medication-assisted treatment is necessary to connect to services, reduce stigma surrounding opioid use disorder. We partnered again with ASAM to develop a culturally appropriate patient booklet discussing opioid use disorder and medication-assisted treatment, and are working on developing brief educational videos to continue that decreasing the stigma surrounding this. In conclusion, there's still a lot of challenges to accessing treatment. For American Indian and Alaska Natives, one of our biggest challenges is that we're in very remote locations. Many of our healthcare facilities are in rural locations that are considered hardship sites. As we talked about earlier with the Internet Eligible Controlled Substance or the Ryan-Haidt Act, we're working additionally on drafting legislation to address some of those barriers contained within that, to expand access to telemet models for our rural and remote American Indian and Alaska Native communities. And lastly, it's data extraction. We still have barriers to extract real-time data on our opioid metrics. This still continues to remain a challenge for us. So despite the barriers and sometimes lack of access, our American Indian and Alaska Native population has a long history of resiliency and strength. And we know that when we partner with our tribal partners, we facilitate a model of collaboration that extends that access and expands that to our populations. So thank you for the opportunity to share with you today some of the things Indian Health Service is doing to increase access.
All right, thank you very much for having me. And for bringing in the Rhode Island Department of Corrections. I think people often forget about prisons and jails. Mostly we want to forget about it, I think especially in the United States. Oops, backwards, sorry. Because we do such a great job incarcerating people. I have no financial disclosures. I work for the state of Rhode Island. State employee. So while the United States, so I'm going to take the conversation in a slightly different direction. While we only have 5% of the world's population, we have 25% of the world's incarcerated population. And it's not even. We have incredible racial and ethnic disparities in how we incarcerate people. So you can see from this slide, while 1 in 9 men will have a lifetime risk of incarceration, it's 1 in 17 for white men and 1 in 3 for Black men, 1 in 6 for Latino men. So these differences cannot be explained just by behavior. There's really, what we have in our system is some institutionalized racism. We have laws that affect African Americans who tend to use crack cocaine more than regular powdered cocaine. We have laws that have different sentencing rules for different drugs, which make no sense when you think about how these drugs work. You know, there was always the crack cocaine makes people crazy and makes them want to rape and steal. So we really have to get away from that. Fortunately, we have changed a lot of the laws. But another thing we need to reflect upon is we've really criminalized addiction, which is so much of what the stigma is. And we've talked a lot about stigma, so to really address the stigma, we have to address our laws. So I will sort of step off of my soapbox now. It's really hard to get off. So we've seen huge increases in the a number of people who are incarcerated. Fortunately, it's sort of plateauing and decreasing, mostly because we found out that it's really expensive and really a terrible way to treat addiction. And who is behind bars? You can see this first bar here is mostly drug-related offenses. And why is it so important, particularly with opiates, to treat people while in corrections? This is an article from, I think it was 2005, looking at the death rate from an overdose post-release. And what we find is people in the first 2 weeks of release are 129 times more likely to die of an overdose than the general community. So really, when we see people in corrections, it's so important, especially as they transition to the community, that we make MAT available. Another more recent study also looked at the time from release to an overdose death, and this just sort of shows risk in person years. It's highest right after people get released. It continues to be higher than the general population, but decreases over time. A lot of people have told me, so people are incarcerated, they're in for a year, they're cured. I know this population, or this audience doesn't have that belief, but really we have data to show that people who come in and start treatment while they're inside do much better in the community. This study looked at methadone continuation versus forced withdrawal. That's what the vast majority of prisons and jails do across the country. So if we have people coming in on an FDA-approved medication, we take them off because they're incarcerated, they're not as likely to go back on treatment in the community. And so the red versus the blue bars there shows the difference in follow-up as randomized. This is from Rhode Island, where we have a sort of a slow withdrawal protocol, or we had at that time. So that has randomized. The second graph looks at as for people who actually came off versus that people who were still on. There you can see the difference is even greater, so that if people come off, less than 50% are going to follow up after release. So these are people who were in treatment. They might not have been doing fantastic, but they were in treatment, engaged. We take them off. They're not going back to treatment. This shows a similar result looking at buprenorphine. So I work at the Rhode Island Department of Corrections. I've been there for about 20 years, became the medical program director 3 years ago. So I went from doing primary care to taking care of the whole facility. We're a little unusual in Rhode Island, mostly because we're so small. We're a unified system. There are no county jails. Everybody comes to the same campus. I can walk to each one of the facilities, which really helps in providing continuity of care, and that we'll see people throughout their whole incarcerations. In other states, the jail system and prison system are completely separate, so that one has to be careful what you're doing in the jail because they might not continue it in a prison system. We have about 3,000 people at any one time, with over, 12,000 people going through the system every year. So historically, we took everybody off of MAT when they came in. We had a protocol, except for pregnant women, which I always find amazing that this is the one medication where you'll say, hey, it's effective, we have to keep pregnant women on it, but we're not going to make it available for anyone else. Generally with pregnancy, we're saying, let's get the women off of any medication. You know, we won't let you take a Motrin. But here we're saying, this population is so, and this medication is so beneficial that we're going to have to give it to pregnant women, but everybody else, we're going to take you off. So we were taking people off up until about 2 years ago, when the governor put together a task force to address the epidemic. And from the task force, we decided that we need to make MAT available in the prison. It's just one prong of the overall state plan, but it's the part of the plan that I'm in charge of and that I'm going to share. So we have three populations that we look at. The first step we took was people who come in on MAT. The first thing we did is we stopped taking them off of MAT. So that was pretty much a no-brainer, very easy to do. I shouldn't say very easy to do. There was a little resistance. We worked together as a team, and we made it happen. Second population is people coming in and withdrawing, feeling sick. We offered them MAT. Final population that had the most resistance from people was people who'd been in for a long period of time, were vulnerable when being released. We would offer MAT before people got released in the community. And here you can just see how our numbers have increased since we changed our practice. The green is people on methadone, the blue is buprenorphine, and the red is naltrexone, which is a very small line, not appropriate for most people. Most people don't want it. Everybody asks me, how do you decide what the right treatment is? Basically, the right treatment is the treatment somebody's going to stick with. So it's totally like in the community, we work with the patient, provide the most appropriate medication. And so we're discharging over 100 people a month on treatment. Vast majority would not have been on treatment in the past. So we're getting people trying to use the unfortunate event of incarceration as an opportunity to engage in treatment. So what have we found so far? Majority of people are on methadone, and the majority of people are continued from the community. While it's the majority, we're also getting, in this less than a year period, we started over 600 people on treatment that wouldn't be on treatment had we not had this program. So what did we find? Findings, oh wait, that's the follow-up. Follow-up was great. For people who we now continued on treatment, over 93% follow-up in the community. For people, and this was early data, when we're just starting them off on treatment, lowest follow-up rate, 35%. So we know that that's the population we have to work with more to try and keep them engaged in treatment in the community. And you have to remember, they're not coming to us saying, I want to get on treatment. They're brought to us, they don't want to be there. We're using that as an opportunity to say, you've never tried buprenorphine before. Maybe they're only there for 2 days. They try it and they're like, actually, I feel all right for the first time. And that might be what gets them into treatment in the community. So we looked at the results of the study, looking at overdose deaths. We looked at the 6 months. We looked at a 6-month period before we had the expanded MAT program and 6 months during the MAT program. And what we found was a 65% decrease in mortality from an overdose for those who'd had a prior incarceration versus a 3% decrease for the rest, clearly showing we need to make MAT available for this population. And with that, I have to stop. Thank you very much.
Thanks so much to each of our panelists. And you know, you all could go on individually for an hour and we would all learn so much. So now I'm supposed to read what the polling question is, perhaps. There it is. Could someone tell me what the third thing says? Because I can't read it. I know someone else can. Improving, so it was improving care coordination, or transitions to care is the first answer. So do our panelists want to address that issue? Agree, disagree? It's basically whether or not improving coordination of care really would address the issues that your populations are facing.
Yes. Yes. So really the most critical component for my patients in my clinic has not been which medication to use or those type of things. It's been how do I continue treatment for a person whose treatment episode began with the temporary condition of pregnancy and continue her treatment postpartum, and including all the people who become involved in her life and her child's life during pregnancy and beyond. And so that has really been incredibly important for my clinic to work closely with our county social service departments. So every county is a little different, right? And when we talk about correctional care, right, for us in Colorado, every county jail is different and different than the prison system. And so same with social services. And so really making key connections with not just within the medical community, but the other people who will be involved in our patients' lives has been incredibly important.
Great. Any other?
No, I think you're right. I think it has broad applicability across all of these special populations and across all patients. We are so much oriented towards acute crisis-driven episodes of care, whether bed-based or not. It's very easy, all too easy, for patients to run out of steam and providers and delivery systems to run out of steam. And our retention across the board, as good as our tools are, our retention is alarmingly crummy. That's a technical term.
I don't think any of us are going to disagree that care coordination is a key point. Treating patients with opioid use disorder is not a silo. We all are a team. So the more points of contact that patient has for that care coordination are going to be continued opportunities to check in, to follow up with that patient. Utilizing integrated care models to help facilitate that in that team model to give that care coordination is extremely important.
One of the things that I think has made the Rhode Island program successful is there is a community OTP provider or a set of 7 clinics that actually has a licensed site within the prison. So everybody who is enrolled in the MAT program is already enrolled in their clinic, so they are still a Kodak patient both inside and outside, so there's no need for a new appointment, there's no need for a new intake. They just go the next day, show up with a picture ID at any one of the 7 sites, and they can continue on treatment.
I'd add one other thing. I might have voted for the one that says patient reluctance also, so just to put in a plug for that, as good as our tools are, if people don't come or we don't go to them, it doesn't matter. And I would say we've got to look at our marketing or our engagement or our welcomingness, because if people aren't buying what we're selling, it doesn't do them a lot of good. And I think we have to do some very serious self-reflection about this issue of uptake, given that this is a motivational illness at its core in large part.
Great. So we'll take some questions now from the audience. Sir, if you want to say your name and what your question is.
Yes, thank you. Kevin Webb with Mallinckrodt Pharmaceuticals. This question is from Ms. Clark. You answered the first part as far as whether the OTP was actually within the prison system. But in line with the coordination of care concept, how much coordination needs to take place within all the other institutions that are involved within the prison systems, judges, the legal system itself? Were there other elements that you needed to coordinate with to bring in that type of services within the prison system, or was that a decision that the prison system within Rhode Island was able to make on their own?
The prison system was able to make that decision on their own. We make it very clear that MAT is a medical decision and not a legal decision. So the judges can't say somebody has to be on MAT. It's a decision between a patient and their provider. There were many security issues within the prison, many challenges that we had to address, whether or not somebody could be bullied into or manipulated into cheeking their buprenorphine and sharing it with somebody else. So we have to make sure the patient is safe and that everybody within the prison system is safe. So we had to do a lot of medical security work, but we didn't need to get the approval of any judges.
Go ahead. Hi, my name is Kathy Longerbeam, and I have a question. For one thing, I was not aware at all about the pregnant women having this addiction problems. I hadn't heard of that really at all. It's a big, terrible surprise. And my question, and it kind of follows up with pregnancy and then also preventative measures, like what preventative measures could be approached? I know you're talking a lot about the MAR, is that what it's called? The MAT, I'm sorry, to treat all this. And I understand the gentleman there said that it's such an acute problem that you're so caught up, the providers are so caught up in trying to help people or treat people the best that you can, but what preventative measures, like especially the pregnancy, could be allocated? What I'm bringing up is because yesterday in the paper I read where President Trump's Senate had not just proposed, but apparently passed big allocation of money to fight the opioid epidemic. I think that's correct, what I read. And those funds, do you think those funds could be utilized to kind of address some of the problems, the issues you brought up today? Not just your panel, but the panel before, and to include paying providers more, making it more known, like social media. I don't know much about social media. Honestly, I don't use it myself, but I don't even know what Twitter is. and I don't really care about it. But the pregnancy women, no, this is not a joking matter to me, honestly, it's not, folks. That the pregnant women, you mentioned before social media might help reduce stigma. I can't imagine when a pregnant woman, if she's addicted and never was before, or this happens, or whatever happens, and she has to face that alone or with her husband, or however it works, what she's gone through and what she could lose, what she faces to lose within the system that apparently is constructed now.
Thanks. Your
That's the question.
is,
What preventative measures?
Great.
Okay. Are there any that you can think of that could be in place that brings this out to the forefront? Because I had never heard of a lot of this.
Thank you
today.
for your
Oh,
question.
absolutely. I'm like salivating when you're like, what should we do with all this money? I'm like, I'm like, here's my list. So yes, are there preventative measures? I think yes, and specifically for pregnant women, I know it becomes very dramatic to talk about substance use in pregnancy, but I can't emphasize enough that pregnancy is often the event that is highlighting a person who already has a substance use disorder. And so any of the preventative measures that we would think about for anyone else, non-pregnant people, would be absolutely worthwhile. With respect to women of reproductive potential, I can't emphasize enough that I hope that my spirit is coming through correctly, that I'm not advocating for past atrocities that have occurred, such as coercing women into sterilization who have a substance use disorder. Absolutely not. But helping women who may become pregnant, make decisions about their desired or intendedness for pregnancy, and putting those types of reproductive health resources in a co-located or integrated way that's accessible. When we talk about trauma and truly healthcare associated trauma, asking my patients who experienced severe sexual abuse to go get an IUD is a really large ask. And so making sure that we have not only a wide variety of reproductive health care available, but that we have reproductive health care available in a way that's accessible and is not going to be re-traumatizing for our patient could not be more important for me.
Thanks. Anything else about prevention?
Just real quickly, prevention in youth, since most people who progress to an opioid use disorder have initiated with other non-opioid substances, most typically in young people, cannabis and alcohol. I think it's important to talk about intervention in cannabis and alcohol use disorders as an OUD prevention strategy, and we don't spend enough time doing that.
Thanks.
I'm sorry to follow up, because it seems like the sustainability of the economy is not going to keep these programs going. So many lives are going to be destroyed permanently, because the state of the economy is not going to be able to sustain this forever. So I'm just wondering if the allocation needs to be smart and fair and equitable. Does that make sense?
So Ingrid, and then we'll move over to Sharon.
Question for Dr. Clark. So you mentioned that in Rhode Island and the DOC, there are now all three options that the medications are being offered. Do you have any protocols, or do you, is there discussion around protocols of switching from medications from one to another? So for example, from methadone to buprenorphine to naltrexone, or methadone to buprenorphine, or that came up earlier, and just kind of curious as to what you all did.
So in corrections, there's a lot of moralizing around MAT, where naltrexone, long-acting naltrexone, is the morally superior option. We aren't here to moralize, although we are corrections. Although we are a prison, I know, it's weird. So that is not our goal. Our goal is to have people get on a treatment that they will stick with. Thank you.
Thanks. Sharon.
A question for Dr. Clea.
You're right.
If you could say a little bit more about the universal screening for pregnancy. I mean, right now the U.S. Task Force does not recommend universal screening of anybody. And I'm wondering if you would say for all substances, or if you could flesh that out a little bit more.
Sure, yeah, and that screening recommendation, so universal screening for, although many people probably should be screening for pregnancy in your patients that you're treating for a substance use disorder, what I meant to say was screening for substance use among pregnant women. And that's come out of ACOG in collaboration with ACM and the AAAP and AAP as far as a recommendation to use pregnancy as an opportunity to find out more than just about what your blood type is and, you know, are you up to date on your PAP, but finding out more about people's overall health, including potential substance use. And so the screening recommendation really is to find a tool that works for that clinic. They haven't said, this is the tool you have to use to screen. But I just want to make sure that we have very carefully separated in our mind screening for substance use as a verbal tool or a written tool with, let's say, the audit or the NIDA quick screen or something like that, compared to either consent or non-consented biological testing for a presence of substance. And so that recommendation is most commonly comes from ACOG, but also collaborating societies.
Imagine that, talking to the patients.
Yes, face to face.
Do you have a question, Dr. Wally?
Hi, my name's Alex Wally from Boston Medical Center. I have a question for Dr. Clark about Rhode Island and corrections. So it's specifically about diversion within the facility after the medication was implemented. We're in the neighboring state in Massachusetts. I've been to other panels with you and heard our colleagues in corrections speak, and I've heard the Rhode Island administrator say, yes, there's contraband, that's our job. That's what we deal with every day. You know, buprenorphine isn't any different than cigarettes. Whereas in Massachusetts, the corrections officials put up this evil specter of buprenorphine as contraband. I will say that my own patients have told me, some of them, a few of them, have told me that they've purposely been incarcerated in order to bring buprenorphine in, because the value of buprenorphine, the so-called street value of buprenorphine inside a Massachusetts incarcerated setting is 10 times what it is on the street. And so there's a big business, a big gray market or black market business that exists in smuggling buprenorphine in and out of incarceration that I think not only prisoners but also corrections officers have a vested interest in. And it's really a perverse reason for why there's barriers to the expansion of medication. So now you're on the other side of that, and I want to hear what your comments and thoughts are on my impressions from the other side of the state border.
So there's a great thing about making a service available or a medication available, the demand goes way down. So we are in the process of looking at urine screens to see if we can quantify it. But right now I just have one of the wardens who's told me that she believes that the amount of contraband buprenorphine has gone way down since people now have it if they need it. So people aren't trying to get it if they're coming in sick. We are providing it. That's the short and simple answer.
That's good, because I know they're doing a pilot in Massachusetts, right? So that's what the legislature passed, so that will be helpful information for them to have. So I apologize because we are running up against the break and I've already gone a few minutes over and I'm getting the high sign. So if really, really fast, but we could let your colleagues see if you want to take away their break, but go ahead, really fast.
This is really quick for Caitlin. Would you characterize the screening of pregnant women as screening for the risk of use rather than actually screening for the use of substance? Because would that be a good way to characterize what you're trying to say?
Let me make sure I understand. So screening to find out about potential risk for use in the pregnancy.
Right, as opposed to a biological thing which detects the actual use.
Yes. So when we use a screening tool, right, we're using a series of questions to assess for, like an example for a marijuana screen, you can use the one question screener. Have you used a marijuana product in the last year, right? Like you can ask these questions to get the information you want rather than relying on an irreliable, often non-reliable test.
But it's
such
still
as urine.
screened for use, not
Yeah.
possible use.
Yeah. And then if you detect use, right, then you can ask questions to determine, does this person have a use disorder, right? The vast majority of women who use substances and get pregnant stop, right? But then there are some women who cannot without help.
Okay, thank you very much to our panelists. This is a great discussion. And we have a break until 2:55, so 9 minutes. Thank you very much.
Okay, we're going to go ahead and get started in the next session. If I could ask you all to start taking your seats. And I'll ask the panelists for this next session to join me up here on stage. Okay, welcome back. This session will be examining the future directions for treatment for OUD through defining success and meaningful outcomes for patients. We've had a great discussion throughout this morning and this afternoon around the various treatment modalities, the barriers to access, and a lot of very thought-provoking ideas that have come. In this session, we're going to talk about, okay, so what are the outcomes that we're hoping to achieve? And we heard this morning by Sarah Eggers from the FDA that although treatment efficacy has traditionally been measured by reductions in drug use, more meaningful outcomes for patients and caregivers and patients suffering from OUD might also include reduced symptoms like cravings, but the drug-sick symptoms that Sarah talked about, skin crawling and other issues, potentially reduced mortality, reduced need for medical intervention, improved social functioning, and other potential measures that we'll hear more about from our panelists in this session on what some of those outcome measures might be. As the healthcare system also increasingly moves away from fee-for-service methods for paying for our services to more value-based methods that try to link payment for healthcare services to outcomes of quality, patient-reported outcomes, other measures of potential value, so much emphasis is becoming on, well, how do we measure those outcomes, and what are the most important outcomes given the condition that a patient might have? So as we look at OUD, the question is, as we move to those better measures of quality and outcomes, what could those be? And then also what is practical in terms of measuring and collecting from a data perspective. Presentations in this session will address current challenges to these kinds of measurements, new approaches for measuring quality in OUD treatment, and how improved outcome measurement can facilitate quality improvement, innovative payment approaches like alternative payment models, and access to effective care. With our earlier sessions, we're going to go ahead and do one of those online polling. I'd like to invite the audience to go back onto your phone or computer, and those watching on the video to do the same through the chat box. The question is, based on your own experience, what patient treatment outcome might be considered the most meaningful for OUD treatment? Clearly, you might actually answer a couple of these, but pick the one that you think is the best. And as with the previous sessions, we'll keep this running throughout the session, and we'll come back to the results at the end of the session. Again, with all of these, there might be important outcomes related to OUD treatment, and there are many more that we could include. So this clearly isn't an exhaustive list. As you're thinking about that and logging on, I'd like to introduce our panel, who all have valuable insights on how we might think about success in OUD treatment and how understanding these outcomes are crucial to understanding some of the payment barriers that we discussed in earlier sessions. So joining me here are Alexander Wally, Associate Professor of Medicine, Boston Medical Center and Boston University School of Medicine. Sarah Hudson Scholl, Vice President, Research and Analysis at the National Committee for Quality Assurance, NCQA. Maddie Chalk, Principal and Managing Director, the Chalk Group, and Sean Ryan, President and Chief Medical Officer at Brightview. So I'll go ahead and turn to Alex for some opening comments.
Great, thanks so much. I'm really excited to be here. And So I'm at Boston Medical Center, Boston University School of Medicine. I see patients there as a primary care doctor doing addiction treatment in primary care. I learned a lot of what I know from Colleen LaBelle, who spoke earlier. I'm also director of an addiction medicine fellowship program. One of the things we didn't talk about today was training the workforce, which is a major, major issue. If no one's there to deliver the treatment, then we're not going to deliver much treatment. And I also work with the health department in Massachusetts on overdose prevention through the naloxone distribution program. And one of my mentors also was on one of the other panels, Sharon Stancliffe. And so I'm excited to be here with them. This is supposed to be about outcomes. I'm going to talk about 2 or 3 or 4 outcomes that wasn't on the question that you just asked. And also, I'm glad you mentioned Dr. Eggers. And I didn't participate in the FDA session, but I think it really is important that the FDA conducted that, and I thought that was a really nice way to start out the day. And so I hope folks will keep that in mind through this session. So first thing I'm actually not going to talk about as an outcome, it's actually the pool of people at risk for a bad outcome, the people with opioid use disorder. So what this is an analysis that we did in Massachusetts using a new database that is individually linked actually across 13 or 16 statewide data sets. It's the first time it's really been done in the US at the state level. Some administrative health insurance databases can do this, but this is really a Scandinavian style linked data set. And we looked through the data set to find who had opioid use disorder. And we came up with a quite strikingly high number of over 4% in 2015. Now, Massachusetts is a big opioid state. We have a long history of opioid use disorder, and we're up in the top as far as overdose deaths and so forth. But 4% that's a high percentage of adults. That's like I think it's more than the prevalence of diabetes and asthma. And so that compares with the National Survey on Drug Use and Health, which is only 0.6%, okay? So, and that's a survey. We're using a data set that's individually linked, where we're looking at we're looking at their insurance claims, we're looking at their access to treatment, we're looking at whether an emergency department, they went to the emergency department. So, knowing how many people actually have opioid use disorder is one of the biggest issues, right? Because it's highly stigmatized condition. Most people who have a highly stigmatized condition are not going to raise their hand and declare themselves and go into healthcare and seek treatment right away. It's going to take a while. So that, I think, is one of the just biggest conundrums that we have to deal with, is that I think we're underestimating the number of people who actually have the condition. And perhaps studies like this we'll see more of in the future. Okay, so if you look in another database, which is national, it's a commercially available database that has over 200 million people in it, the TrueVen Market Scan database. We looked at in succeeding years and saw that there was a 4-fold increase. And now here the prevalence is quite low, actually lower than it is in National Survey in Drug Use and Health. So maybe not as accurate, but we're seeing it grow by 4-fold from 2010 to 2014. That's a 4-fold increase, okay? And so that actually it fits that as the awareness of the opioid use disorder crisis is coming to light, that more diagnoses are going to be made in commercially insured people. That makes sense. What we would also hope is that you're going to see an increase in treatment, the proportion that were treated. But in 2010, only a quarter were treated, whereas in 2014, only 16% were treated. So we actually saw a decrease in the proportion of people were treated as we saw more and more people diagnosed. So that's quite concerning. We really want to move in the opposite direction of that. We want to have more and more people be treated as more and more people are diagnosed. And then there's a third piece of bad news that we see in this commercially available database, which is that discontinuation is common, okay? So you've heard a lot. I'm a huge proponent of medication for opioid use disorder. And I thought, we've heard from a lot of the speakers how effective it is and how it's life-saving. But one of the big problems with is people that are started on it don't stay on it. And so we see that here. So this is days after initiating a treatment. The best treatment was buprenorphine, where at about a year you had a little bit, let's see, in this commercially available, if you go out to 360 days right here, we got about a quarter of people still on buprenorphine. So that's not fantastic, right? For that quarter of people who are still on buprenorphine, that's actually is really good news. But that's a quarter full, three-quarter empty glass. If you look at other treatments, like this dark gray line here is injectable naltrexone, you see really rapid decay, and oral naltrexone, which we didn't really talk about, is even worse. Okay, so what I'm getting at here is I think that discontinuation actually or retention in care is an important outcome that we need to look at when we're thinking about medication. So I also think that when we think about outcomes, we need to think about special populations. The way in that original database where we found that high prevalence of opioid use disorder, we were looking at places where people hit the healthcare system or the criminal justice system and they had obvious signs of opioid use disorder. Those are touch points. Those are places where we can identify them and ideally treat people. Or if they're not ready for treatment, we can offer them some safety advice, some harm reduction, some overdose education. Okay, so this is looking at one of those special populations. The number one risk factor for an opioid overdose that's fatal is a non-fatal opioid overdose. And those, while we hear a lot about fatal overdoses, non-fatal overdoses are actually quite common. So in that, going back to that linked database I was telling you about, we identified 17,000 people who had a non-fatal overdose in Massachusetts. And then we looked at what happened a year before they went into a year before they had the non-fatal overdose and a year after they had the non-fatal overdose. And the first thing that was clear was that very few of them were receiving buprenorphine, methadone, or naltrexone, either before or after. So in the 10% range. Now, we're going to zoom in on this y-axis. Okay, 10% here, same graph, just different scale, and you see what happens. There's 6% of people on buprenorphine, and then it rises up to about 8% after the non-fatal overdose, so some people are increasing. Methadone dips right before the overdose. That kind of makes sense, that people are getting discharged from treatment, and then maybe they overdose, and then naltrexone is low before and after. Okay, if you look at the time, this 12 months after, if you add up all the time that people were on, 17% received buprenorphine, 12% received methadone, only 6% received naltrexone. So these are the highest risk people in Massachusetts, a state that has universal health care coverage, that's probably far out and ahead of other states in delivering treatment to people, and we're still not getting treatment to people. Okay, so just getting treatment to people, that's an important thing. And then when people get on treatment, they don't stay on it, especially naltrexone. This is the months that you receive the treatment if you got it. You only get it for 1 month if you're on naltrexone, okay? Methadone's better. 5 out of the 12 months you get on methadone, and buprenorphine not quite as good. Okay, so this looks at what happens when you're on the treatment. If you're on the treatment, like many, many other studies before, guess what? You survive, right? So here's the death rate if you're not on any medication. It actually is quite high. It goes up to 5% at 12 months. That's 1 out of 20 people who has a non-fatal overdose is dead at 12 months if they don't get a medication. If they do get a medication, while they're on it, that death rate goes down by way more than 50% with all 3 medications, okay? So that shows what we already know, that these medications save lives. I'm arguing for mortality as a very important outcome in a condition that is very fatal. Now, this changes things. What we know is in the month after people stop their medication, their overdose death rate actually goes up higher than it was while they were on the medication, and it even goes up higher than it was before they started the medication. Discontinuation is deadly. That's what this graph is showing you. So that benefit, which was down here, has now been pushed up because we've taken that month of discontinuation, we put that risk into the medication. I would argue it is attributable to the medication. They wouldn't have had that risk if they hadn't have gone on the medication in the first place. And because people are on naltrexone for such a short period, the death benefit or the survival benefit is completely erased if you include the discontinuation time in the risk for the medication. So there's still a benefit with discontinuation, even from buprenorphine and methadone. It's still there, okay? But it's attenuated. Okay, so I'm arguing for, first of all, let's figure out how many people there are. That's really important. Think about the fact that discontinuation is deadly. And who are the people who are discontinuating? It's these people that are in these high-risk population. Okay. Thanks very much. I look forward to the discussion.
Thanks, Sarah.
Good afternoon. Thanks so much. So I think my slides, which are just as hard to read, actually tell a similar story to Alex's. We've been measuring at NCQA, we measure the quality of care. We have about 800 health plans that report data to us every year. And you can see we've been measuring the initiation and engagement in substance use disorder treatment for actually close to 2 decades. But I'm just showing you a time trend from 2005. And typically, what we've seen with quality measures is that when we measure, things improve because there's a focus and attention. And that has just not been the story for drug treatment, and actually not even for mental health. It's a problem in both areas, but this is a measure where we're actually seeing declines. And the only difference is that we see just a little bit of an uptick in 2016 data for Medicaid, which might give us a little bit of hope that there's some more attention being paid to the first step of initiating treatment. And this also includes, the 2016 data for the first time includes the use of medication treatment, as well as the use of other kinds of visits. So overall, terrible story. Maybe it's going to get better. But what's contributing to this, and you've been here all day, so you've heard about all the barriers that we could imagine that have to do with the lack of data sharing, the lack of integration, the lack of payment and incentives. So where we've seen the diabetes quality measures go up and up and up, we see that for controlling blood pressure. We see that's even harder, right? That's another patient adherence measure, and we see it go up and up and up, and we see that it's improving for all, across the board. We haven't seen that in drug treatment. And part of the concern is about accountability. Who is accountable? The health plans say, well, is it the primary care? Is it specialty? How do we put them together? How do we get our networks to focus? A lot of attention on what is the outcome? What are we really driving to outcomes? So as we've been thinking about this issue at NCQA and thinking about where do we need to go to try to improve outcomes for addiction, and in particular for opioid use disorder, we go back to the Donabedian model about how do you measure quality. You think structure, process, and outcome. And part of the structure is to have organizations, healthcare clinics, primary care, specialty care, emergency departments that are prepared, that have the capabilities to actually provide high quality care. And so what does that mean in addiction? That means people that are waivered and prepared to deliver medication treatment, but also all the other systems you have to have in place to find people who get that first medication and engage them so that somebody's reaching out and helping them to get back into care and to come back for the next treatment. So you need registry systems, you need electronic systems that allow you to go out and do that. You need somebody whose job it is to do that. You may need peer navigators to go out and work and do some help with all the other factors that contribute to ongoing addiction. We think process measures like this initiation measure, it's based on claims data. It helps us to understand access to care and access to evidence-based treatment. And it's easily available from claims data. That's what we've been using almost exclusively for mental health and substance use quality measurement. We use those claims data, they're easily available, and from that we can dig in and look at some other measures, and we're actually working on adding more measures to our armamentarium that look at specifically at the use and continuation on medications, that look at follow-up after, whether people have follow-up after emergency department, or hospitalization or detox, so that we can have more measures that help us to focus in on the opioid use disorder group, but also to understand where are the patterns of care. But we can't stop there. What we really need to do is look at the outcomes. And as we've been talking with stakeholders, what we've been hearing is the outcomes that matter are overdose, death, but also, as we think about the young population, we're looking, are they back in school? Employers are telling us, are they back to work? Are families back to work? But where do we get that information that would allow us to understand, are we moving the dime on outcomes? Well, it's not in claims data. And it really means that we have to make an investment in thinking about where the data come from, right? So currently, when we can look at structural measures, we have that at NCQA. We've about 20% of primary care clinicians are in an NCQA recognized primary care practice. And so we understand what kinds of structural capabilities they have to help with screening and identification. And now we have a distinction for integrating behavioral health, including medication treatment, coordinating with specialty treatment. So we know how to measure that. We have tools for doing it. We know how to do the process measures. Using claims data is an efficient way to do it, and we think that we can actually use those claims data from states or from plans to get at the addiction treatment provider settings and to understand where there are providers that are keeping patients on medication treatment and what are the patterns of follow-up. But to get to the outcomes, we're really going to have to think about the future and create and link together new data sources. The kinds of being able to know something about overdose and near overdose, Massachusetts can do that. I know in Arizona, they have a way that if you use Narcan, you have to, a registry to say you've used it, but that's not a nationwide tool for us. We think that registries like the American Psychiatric Association has a clinical registry that will get information directly from patients. For this population, does it also need to be a registry that would get information from families or caregivers so that we have multiple ways to get information about, are there overdoses? Are there symptoms? What are the symptoms? What's happening with school? And also to try to use that information to help engage and motivate patients. We've got work going on where we're working with people with functional disabilities, people with serious illness, and we're saying, what matters to you? What matters most? And using goal setting and work to capture symptoms, functioning, and to help motivate and guide the treatment care plan. We think maybe that's an option here, but it's going to require that we develop new data systems. We link the data that we have so that we understand who's on the streets, we understand who's involved in the justice system, and we begin to look at those outcomes as well as information that clinicians and care teams can use as they're doing their care planning to say, hey, you're doing better. How does that feel? I look at this information, I can see that your symptoms are going down. What can we do to improve that? How's school going? Are you back in school? We need that information integrated in care so that it becomes something that is useful for care planning. It's useful for the patient, for patient engagement. It's something that we can use to improve care. So we need this to be aligned across all the different settings. And part of what we think about is we measure at the health plan today. We want to measure at the provider level and then all the networks. Pulling together these data across all these settings, it's a challenge. And at NCQA, as we think about where the future's going, we really want to focus on beginning to pull data from all the electronic sources where it sits so that we can come up with a clear understanding where we apply the same measures and specifications and where we can begin to create some joint accountability on patient-centered measures that can really help us achieve the outcomes we're looking for. So thank you.
Maddie?
I can see. So I'm going to jump this up a level and try not to be repetitive. Keeping in mind that what we're really all here about is the person at the end of all of this, which is an individual human being with a problem. And I may differ with some of the previous speakers. We really have a paucity of measures. We've got a lot of homegrown measures that lots of providers are using and lots of states are using. But at a national level, there are currently 3,000 measures for all kinds of conditions, of which 7 have are process measures related to substance use disorders and opiate use disorders, and 1 outcome measure. The 1 outcome measure, which was approved and endorsed by NQF last month, or 2 months ago, has to do with retention on medications for opiate use disorder for 6 months. And where I think I differ a bit with Sarah is that the current framework that we're using that has to do with structure, process, and outcomes has not yielded us at a detailed level what we need to know to track individual patients and groups of patients through treatment and recovery. Reporting by providers, whether they're commercial or in the public sector, is at extremely low levels. No less use of measures at the provider level to help people design quality improvement strategies. It is apparent now that simply requiring that plans and providers implement measures and report them doesn't seem to be producing the results that we would like to expect. We need to begin to think about new accountability structures. And I think I'll move on. So I want to talk to you about a new framework for measurement. Some of you may have heard of the term the cascade of care, which was implemented by HRSA, the Health Resources and Services Administration for HIV/AIDS, some years ago. What the cascade of care is a framework that gives us the opportunity to set goals at every stage of treatment over time to trend outcomes, identify critical gaps in care, and develop systems improvement strategies. This is the cascade but let me make it easier for you to read. What the cascade does is begin with what Alex was talking about identifying populations, at-risk and at-risk populations, diagnose of those who are identified, so you have to go through each stage successively, of those who are identified, what percent were diagnosed, of those who were diagnosed, what percent, for example, were engaged in treatment, including tracking patients throughout care for however long they are there, of those who are in treatment, what percent initiated medication, of those who initiated medication, how many were retained and continued on medication, including the clinical services they needed to support that, for at least 6 months, and then of those, how many entered either remission or recovery. That's what the cascade of care is. For substance use disorders, for HIV/AIDS, they have established a baseline, and they established goals. And the goals were that 90% of the population that has HIV/AIDS should be identified. Of the ones identified, 90% should initiate treatment, and of those 90% should be able to be maintained in the community. Clearly, for opiate use disorders, we are very far from anything close to that. It'll be a long time before we can get there. But we don't even have a baseline. We don't have goals that are set that way for opiate use disorders. And what I am proposing is that we need to think about outcomes in this way. That an outcome of initiating treatment should be that you get evidence-based practices. An outcome of getting evidence-based practices, including medication, ought to be that you move on to the next set of goals. So we know that there are a number of challenges in implementing a cascade of care, not the least of which is that you can't find all of that data, as Sarah mentioned, in claims data. But we need to begin to work on that, and there are places that are working on it. The state of Washington, for instance, has an ability to identify. They have patient identifiers that can connect with all the services that a patient receives in that state, from and identify where people are, whether they have jobs, whether they're back in school, and that sort of thing. Now I'm going to shift topics. Assuming that we've thought about those kind of outcomes, what can we do to encourage people to plans to implement this kind of reporting? Alternative payment systems have begun. Experiments with alternative payment systems are now operating in a number of states, and I want to talk about a couple of those. I'll move quickly. So let's begin talking for a moment about bundled services for medication-assisted treatment. Increasing access to medications for treatment of addiction rests heavily on our ability to support physicians and patients throughout care. And what I mean by that is that there has been a notion around that all we need is more waivered physicians. I recently took a hard look at the percent of waivered physicians that are prescribing medications in particular states. And without naming the state, in one particular state there were 117 waivered physicians, and of those, 7 were prescribing medications. So you know what the percentages are there. Okay, I'll move more quickly. Administrative, in the states that I have been involved in looking at, it's clear that administrative and clinical supports need to be provided to physicians if we're going to expect them to prescribe medications and thereby increase access to medications. Bundled arrangements and bundled services that include the clinical and administrative services to support physicians as well as patients is being experimented in a number of states, and we should be able to have those results fairly soon. In other places, health homes for individuals with substance use and opiate use disorders are being experimented with by OTPs, opiate treatment programs, using incentivized payments. So opiate treatment programs and other treatment programs that are able to provide intensive services and intensive clinical and administrative supports are provided incentivized payments to increase the level of services that they are providing severely ill patients in those health homes, and as appropriate, move them into community settings with primary care physicians and waivered physicians that can continue to treat them. A third experiment that is going on now is pay for reporting and pay for performance, tied to quality services. As I said when I started, reporting is very low, and performance measurement is even lower. With that in mind, several states and health plans in the commercial sector are beginning to pay providers to report. As sad as that may seem to some, that should be necessary, it seems to be, and it's clear, it should be clear to all of us that unless we get providers to report and to measure, we're not going to be able to get to the point of improving outcomes.
Thank you. Sean?
Afternoon. Actually, I'm going to move straight from Mady's point on through and transition all the way back to the patient at the very end, which Dr. Wally started off so nicely with. I'm going to talk just briefly about the issue. I'm going to primarily present a fair bit of information about the alternative payment model that ASAM and AMA worked collaboratively on, and then I'm going to go back to, again, focusing on patient access. Oops, sorry. I do want to go ahead and say that most of these slides, at least the content of them, was produced by the American Society of Addiction Medicine, and I did not spend all of my time making these fancy graphics. So this is a very pretty graph saying basically only 1 in 5 individuals, and we all know we see measures all the time. I'm not sure if this is just jumping around. We all know that we see measures all the time related to how few patients are getting access. I don't think I need to belabor that point. Dr. Wally presented some fairly concerning evidence, especially in the high-risk population, of how few people actually get evidence-based treatment, including medication-assisted treatment. I will go back to Ms. Chalk's point and say that although it may sound potentially ridiculous to some that we have to pay providers to report measures, I will tell you the American physician is overworked. We have a record high burnout rate. Some primary care physicians have approximately 6 minutes to see. I just don't know what's going on today. I'm not touching it at this point. we have approximately 6 minutes to see patients on the day. I have colleagues who, I'm a board-certified addiction and emergency physician, but I have primary care folks who see 20, 30, 40, 50 patients a day with an advanced practitioner. To perceive that we're going to convince them to see a very challenging patient they were never trained on, using a controlled substance that they could potentially get in trouble for misprescribing, and then report on that without increasing reimbursement is ridiculous. I cannot name a single physician. In fact, I will tell you that we in Northern Kentucky, across the river from our Cincinnati practices, I had a friend who years ago said, well, I'm just going to get retired physicians to come on out of retirement and provide medication-assisted treatment, and they'll come because they feel like it's the right thing to do. How many people do you think showed up for that program? Okay, so it is not at all ridiculous that given this current environment of physician overworking and burnout, et cetera, that we should expect we need to improve, the reimbursement. And you can see here some measures or some comments on unnecessarily complex billing and paperwork, et cetera, all else. And so alternative payment models are one version of doing everything kind of at the same time. I'll tell you, we did spend, and Ms. Cindy Marks in the back from the AMA, and we appreciate the AMA's collaboration on this model. We spent an inordinate amount of time, a couple of years and thousands of hours of work between ASAM and the AMA getting this thing done. So one of the reasons that I was so intensely focused on producing the model was really the fact that we have the broadest bell curve, and I was describing the lack of standardization of treatment in the United States, period. Right, so you literally might see me and one of our board-certified triple addiction psychiatrists, right, in Cincinnati, or if you call the wrong number, you're going to end up riding horses on the beach in Florida. These are not even on the same planet. And so one of the reasons to do an alternative payment model is to jump the quality and care and standards that we're seeing in the United States forward by saying, does anybody else know what's going on? Is it just me?
It might be on a
timer?
Presentation
I
timer.
talk really fast. I'm
Yeah,
not really
just
sure why.
The people in the back are trying to get you.
Yep.
Yeah.
So anyways, the medical, psychological, and social model is what we have to apply. So not every patient needs exactly the same medication. Not every patient needs exactly the same psychosocial intervention. But not conceptualizing the medical psychosocial model is incorrect. And we need to standardize that so you don't end up riding a horse in Florida. Although if you can pay for that and you happen to get medical, psychological, and social care and ride a horse at the same time, that's okay. Can I go on now? Do I have permission? Please. You can see down here the key areas of focus. Guys, paperwork. At one point, there was a 4-page diatribe of a prior authorization in Kentucky for medication-assisted treatment. It was the most ridiculous thing I've ever seen in my entire life. I probably could have gotten a patient a kidney transplant faster than buprenorphine. And it was unreasonable. They've changed it since because I've said that probably 50 times in the past 3 years. But it was the most asinine barrier to getting a patient something that's life-saving and not even that expensive and very safe. And so reducing this administrative burden of paperwork, et cetera, all this is really going to increase and improve the access to care. And we have to think about co-pays for patients, by the way. So if a patient is in a high level of care as dictated by the ASAM criteria, and they are placed in IOP plus medication-assisted treatment, and they have a $50 copay for the approximately 15 visits they're going to have to get that month, what do you think happens? They don't show up, right? They don't do it. So we focused on outpatient treatment. We did this for a multitude of reasons. I know there's other models out there talking about the full spectrum from inpatient, residential, and on down through continuing care, but the problem with that was actually that is unbelievably complicated to try to drive a bundle towards, especially to do it efficiently, effectively, and actually make it happen. So for those in the audience who might know me, I'm all about execution. And as we looked at this and we molded over with all the professionals on the team that I ran, evaluated this program, we just could not possibly think that we were going to get it done in a reasonable time frame with any payer, no matter how hard we tried. And not only that, but outpatient focus. So I say this clearly as others have said it. Residential and inpatient care is necessary for some patients, but they all need outpatient continuing care, period. And so we really should be focusing on what I would describe as limited dollars, despite the Senate's, and I do appreciate the congressional passing of all these things, or close to passing of all these things and the money associated with it, but that's not that much money. And so we hope to get more money through multiple resources and spend it wisely, but in order to spend it wisely, we have to focus on the most cost-efficient levels of care, and that is outpatient care. So we focused on that. We talked about initiation and maintenance. So IMAT and MMAT, I did not make these terms up. I don't remember actually who did. But they were meant to be saying it's a little harder to see a patient and get them initiated and get them engaged and kind of get them hooked into treatment so that they're going to stay. And then hopefully after that initiation of treatment, they're going to stay and do maintenance therapy for whatever duration of time is necessary. And approximately 90% of the time, patients will need to stay on medications for quite some time. We talked about the ACEM levels of care, both IOP and outpatient, that's 2 and 1 respectively, and just focus on that part of the spectrum. And then we also wanted to make sure that we evaluated for places like where I work, which is a completely integrated care delivery model or a coordinated care delivery model, because you might have a counseling center or a social support network that works with a primary care physician who's willing to provide medication-assisted treatment. So we built the model to allow for flexibility, because far be it from me to dictate what was going to happen all over the place in the United States. That wasn't reasonable. These are the measurements of quality that we put forth in this model. It's things that you might think are reasonable and that you have already been talked about at this point. Starting with, what were the percentage of patients who filled and used their medications? Medication saving lives, they need to fill it, they need to use it, and they need to stay on it. We talked about the treatment compliance, so who stayed on their medications is number 2. And then the 2 utilization of service measurements were around using drug testing appropriately. We all know there's been too much waste, fraud, and abuse in that space. We've lost millions, if not billions of dollars in inappropriate utilization for toxicology testing by urine. And so we were measuring the appropriate use of those things. And then finally, things that people really care about at the end of the day, which is reduction in average number of emergency department visits per patient. These are the measures we put forth. I know everybody is looking at some things, but I would also say, as I stated before, we have to think fairly simply about this so we can execute sometime in the near future, because we are losing time. We did include performance-based measures so that patients will, so that the providers will be focused on doing a good job, and there will be some incentives or disincentives depending on how they do. And I'm going to go back to patient access. I really wanted to bring this home by saying that this is why we're here. This is why I'm here. As an emergency physician, I was extraordinarily frustrated with what was going on in the ED, basically just drowning in overdoses in Cincinnati. I had a colleague and a friend both fall victim to opioid use disorder. At the end of the day, when I'm thinking about these things, I make up all these fancy slides. It's them. That's what I'm worried about. They needed access to treatment years ago. They did not have it. One of them is dead. And when we in Cincinnati decided that we were going to make a difference by making access to care 24/7, you call, you get an appointment same day, next day, the people thought I was out of my mind. Well, we did it, and I'd like to see it done again. And I think this alternative payment model and all these other efforts we've talked about today are key and critical to making that difference. And I don't want to be back here in a few years talking about how we still haven't improved access. I hope Alex and I can have a different conversation next year or the year after. So thank you.
Okay, great, thank you. Okay. So thanks to the panelists. I've got a couple questions, and I know that I've been watching this group all day, and you're sort of very attentive, and you tend to have a lot of questions, so I see people usually lining up at the end of these sessions, as opposed to other topics that we engage on where you might get like 1 or 2 questions, maybe, if you're lucky for a panel. But you all have been very great, and I'll leave time for questions from the audience. But I'd like to see some of the results of the original poll that we, I can't see that, so I think, yeah, okay. So patient well-being, some of these, I guess what I would classify as some of the more difficult to measure outcomes. And I do want to ask the panel, I got one question around the outcome measures itself. What I expected to hear from the panel was overwhelmingly we need to get to measures like what we see the audience responding with, functionality, decrease in symptoms, things like that. And I heard Sarah did mention a couple of those, like getting back to work, getting back to school. Really important measures from a patient's perspective, it seems like. But and usually in other therapeutic areas, we hear things like we do too much of measuring process and we never get to the outcomes. However, I think what I heard from this panel is that some of the process measures, we're not even doing that yet. No. And especially, Alexander, your presentation where you actually linked process measures to mortality and showing that these process measures are meaningful, especially in the cascade. And Sean, your measures in the AMA model kind of mirrored the cascade where it's like, let's get a handle of who's getting treated, who's staying untreated, who's getting to the next stage. Those are all kind of process measures, but it seemed overwhelmingly from this panel that those are not usually recorded, and those would be a good place to actually start. So can you guys comment on this sort of process versus the more patient-derived functioning and symptom measures and where we should be with that?
Absolutely.
Okay.
We need them both. And, you know, the process measures, actually, we've got data on them now. So that show that we're doing a lousy job. And the reason we're doing a lousy job is because we don't have the payment systems and the accountability and our thumb on the places where there are opportunities to improve. So we have to, I think we have to measure those. And then I hear you, Maddie, saying we need to set some goals for where those numbers should go. And I was impressed this morning about, you know, we're decreasing mortality, and because we're doing a lot of work to try to rescue people. But if we want to do, if we want to improve, we really need structured efforts at every level of the healthcare system and working with individuals to do that. It's not going to be easy. As we've talked about trying to move to outcome measures, or to try to raise the bar for providers, what we've heard is until I get more service, until I can improve access, I'm reluctant to require additional efforts because, you know, one kind of, any kind of treatment is better than no treatment. So I think that's a, and that's a question really that I think we have to get over.
Yeah. I don't agree that any care is better than no care. Any care is not better than no care. Evidence-based care is better than no care. And I have heard, as recently as yesterday, a group of treatment providers get up at a meeting and say, well, you can't expect me to deliver evidence-based practices to everyone in this program. Oh, well, yes, I do expect that. And so while I think there are two, I agree that there are two levels of measures that we're talking about. You're talking about individual clinical outcomes that have to do with functionality. I used to have I had four crummy outcome measures. You have a friend, you either are back in school or you're back at work, you've reduced your use, and I can't even, and you haven't beat up on anybody recently. I mean, those were my four measures, and I figure if somebody is coming out of treatment that way, it's not so bad. On the other hand, then you have the measures of how the system is functioning. And if the system isn't functioning to get you to those points, we need to identify how to change that.
So I would say this is a very smart group here, well, that side of the table anyway. So we know this. We know, so where I work, we do measure the CORTOS. If you've never seen the KORTOS, the Kentucky criteria for outcomes, which are basically what Mandy just described, is what we really care about at the end of the day for patients, no question. But what you heard us describe, I think, is born out of frustration and lack of standardization. So why the four of us primarily described that we would just like to see people initiate on medications is because we know the mortality is piss poor. So, and we know how to fix it, but we can't seem to get there. So I think that the focus, what would seem a little bit bizarre focus on the process measures, is born out of frustration more than lack of understanding that we need to get to those meaningful outcomes. I know that I think we could all identify 4 to 6 that we would drive towards, but we don't know that we're still riding horses in Florida.
Yeah, it seems like the system itself isn't functioning for the patient. So if we don't measure where the system is failing, like through the cascade and those, then any lack of responses or challenges in collecting the patient outcomes, we won't know where to go back and try to fix on the system side. So I understand the sort of need for both, I guess. Yeah.
the legacy or the culture of addiction treatment, I think going back quite some time, and also just sort of the culture around addiction, was this concept that the patient needs to work for their treatment.
Yeah, right.
That the way to really succeed in getting to recovery is to work for your treatment. And so I think that has really allowed treatment providers to put it on the patient rather than put it on themselves. Patients fail treatments. Well, no, treatments fail patients. And ideally, rather than making the patient work for the treatment, we need to figure out how to make the treatment work for the patient. So these medications are great. They work if people take them, but they're not working for patients who don't take them. And we shouldn't blame the patient. We need to figure out how to deliver evidence-based treatment in a better way. Ideally, using the patient-centered outcomes that the FDA was trying, to elicit during their meeting. But I do think we're not even there yet.
Well, and it also seems to me, taking off from your point, that if we don't figure out ways to pay for the additional work that needs to be done, so that we don't say, well, the patient needs to be motivated, which I got so tired of hearing from providers, that we do what Mark Fishman was talking about earlier, which is build in assertive outreach to find what will motivate that patient, not ask them to be motivated, but there's no patient that is not motivated, no person that is not motivated in some way. We just don't know what it is, and we don't want to pay to find out.
So one question, and Larry, we'll go to Larry next after, but I do have one more question about alternative payment models. Sarah, you focused on sort of the organizational competencies and the infrastructure for collecting, not just collecting the data, but sharing the data with a coordinated team or integrated team. And Maddie, you talked about, like bundling or medical home or, paying for performance, just on like bundling. And I'm not sure how this works, Sean, with the AMA model, but one of the things that was back in the back of my mind is like, what triggers the bundle? If it's an OUD sort of condition bundling, then there's once there's a diagnosis, then that sort of triggers the care and services, but that, doesn't really incentivize going out and finding those patients necessarily, whereas if you had symptoms or utilization patterns that actually triggered the bundling of services, then the provider system might be more incentivized to get those patients in, get them diagnosed, and then get them sort of on that cascade. Any thoughts as you're thinking through the alternative payment model designs? Does that factor in? Does that come into play?
I'm not actually entirely sure that I know the exact answer to your question. I think Nina and I were talking earlier about how the RT of ESPER is broken.
Yeah.
And so there's primarily an issue with identification. So we're doing a better job of that. We've done millions more ESPER screenings than we've ever done in the past few years, but little to no actual execution on the treatment side. And so the trigger could be either, basically, but they have to, again, the patient has to be referred, they have to be screened and then referred, the treatment has to be provided. So I'm not sure that I understand exactly which part of that would be the trigger to initiate payment.
They can the trigger can be, okay, you were screened in primary care, your physician asked you the 2 questions that they asked.
Yeah, so that's exactly what I'm getting at, like a payment reform that incentivizes the primary care to identify these patients and screen them versus the more sort of specialized care that might kick in once there's a diagnosis.
But that assumes that you've got a payment model that is actually focused on a network rather than on an individual clinician, right? Because if it's the clinician and I'm the treatment provider, when does my accountability begin? Does it begin when the person calls me, or does it begin when the person comes in? And at what point am I responsible? And for how long am I responsible? Am I responsible for, till the person says I'm not coming back, or am I responsible, say, for the next 6 months? You've got to try to work to bring to an end. So the way that you create that, and whether you're creating these, virtuous cycles of referral and connection, because that specialty provider needs the primary care to help out with everything. And if you create a payment model that's too narrow and too short, then you're not creating that incentive for joint accountability that is so critical when you've got people whose problems aren't single dimensional, they're multidimensional, and they often require a lot of outreach and ongoing work. So I think that's part of it, is if we need to think about a broader payment model that's looking over time across settings, and that is encouraging joint collaboration, coordination of data, and coordination and collaboration and joint accountability.
Great, thank you. Larry?
Larry Greenblatt from Duke. I'm a primary care physician, but also waivered. I have a brief comment that's quick, and then kind of a complicated or a difficult question. So my brief comment is, I think it's important for us to keep in mind as we think about identifying people that need treatment for opioid use disorder, with the epidemic really shifting heavily to overdose deaths from illicit drugs. Many of these people have minimal interactions with the health system. So it's not like we're necessarily aware that these people are in our community. They're purchasing from somebody who's delivering, who they text. It's a cash business. They're not coming in and trying to get prescriptions anymore. And so I think that makes it much, much harder to identify the truly at-risk individuals. So that's my comment. My question is...
Can I just respond to that?
You can.
So I agree with you, but non-fatal overdose is an interaction with the health system, and absolutely nothing happens at that touch point. And hospitalization for endocarditis, no addiction treatment is offered for that person. They're extremely expensive, and they get a ton of health care. And likewise, we know that people who, we've criminalized drugs to the point where we filled jails with people who use drugs, and so there's a big fraction of that population that is identifiable, and we're not offering them anything. So I think I would just argue that's a place to start.
So speaking on behalf of Duke Health System, I'll say guilty as charged. But it's exactly what we do. My question, so a few people talked about a couple things that are kind of near and dear to my heart. One was decreasing the bureaucracy and the administrative burden of initiating treatment. Another was making sure that people are paid more fairly, because now it's often perceived as being under-resourced for the amount of work. And I think that those things are true. But other things that I hear from, particularly in primary care, is I'm so busy, my practice is busting at the seams, I can't see the people that I'm already committed to in terms of who's in my panel. And then another thing I hear is people raising a concern that if I had a patient with another condition where their condition got more complicated and I needed help, I have lots of consultants. My cardiac patient decompensates, I have a cardiologist who could see that patient very quickly, help me straighten things out, get the patient back to me, et cetera. But for OUD, I think a lot of clinicians feel like, I don't have that kind of backup. I feel like if these people get to be very challenging to manage, what am I going to do? I feel kind of stuck. And that's particularly for office-based, buprenorphine treatments. Comments on those things?
I'll tell you two things that we've done. We've done a Project Echo, which many people are familiar with, to provide that ongoing case review. But that's not the immediate. And so at our organization, we've actually started an addiction consult line. So we've been very blessed to amalgamate so many addiction specialists. We have extra capacity at least to get on the phone for 10 minutes. And so we've initiated with multiple local health systems, primary care networks, et cetera. They can call this hotline. It's only 8 to 6 Monday through Friday right now, but we're looking at a 24/7 hotline. But it's a heck of a lot more than was available a year ago before we did it. And so I've taken innumerable calls from the hospital. I've got a post-TBI, which was actually a result of an overdose, et cetera. And that has made so many more physicians more confident in their practice. And actually, you're right, Sean, this is not that hard. I'll get them started and you can see them in 3 days. Perfect. And so I would advocate for, in any situation that's actually possible, to people start looking at that. Again, it's different than the Echo, but can be part of it if there's any sort of large group of addiction specialists that can make that available. It's a wonderful service.
And there are other places where physician mentoring programs have been established that are doing quite well, where there is a group of addiction specialty physicians who make themselves available throughout a state, in different parts of a state, for people to contact. So for physicians to contact to mentor them.
Great. Question over here.
Yeah, hello, hi, I'm Peter Strum from Amygdala Neurosciences. It's been a great conversation on increasing utilization of evidence-based care for treatment of opioid use disorder. I'm a little bit surprised that we didn't even hear about the concept of the cascade of care until the very last panel of speakers. So it's a question to the group. Is the cascade of care, which was really a very productive way to think about utilization opportunities and progress for HIV. Is that construct being applied to opioid use disorder? Is there something unique about opioid use disorder that that explains why we don't hear more about the cascade of care in the context of opioid use disorder?
Yeah. Maddie?
We did talk about the cascade, actually. I talked about it. But
here until the very end. I was happy that you did mention it, so thank you.
Well, we don't, I think there are a whole lot of reasons why we don't hear about it. I think about a year and a half ago, I held a meeting with health plans and providers and payers about the cascade and why it was not being applied to substance use disorders or opiate use disorders. And the issue was that they felt that HIV had set such a high standard they couldn't reach it. And my response to that was, okay, but can we start somewhere, please? If we start, no, we can't do 90, 90, 90, but how about, since we know that only 20% are getting identified even, or 3%, I guess, are getting identified in NCQA data, maybe we could say the goal could be 10%. We could start with that as a baseline and then start moving. There are some of us who are continuing to work on the cascade. There will be, I published in the Health Affairs blog a couple of months ago, and there's another one to come, and we are going to just continue pushing it.
Quick comment, Alex?
Yeah, sure. So I'm an HIV primary care doctor. The concept of the cascade, I don't know where you went, but the concept of the cascade is familiar, and it fits really well, along with a lot of other parallels to the HIV epidemic, like stigma, like the fact that we had development of medications which were effective but didn't work because they couldn't get to people until there was Ryan White, which was a massive investment. There's HDAP, that every state in the nation, if you have universal health care coverage, if you have HIV for medications, or you should anyway, there's actual extra funding for that. So I think cascade is just one concept that we can take from HIV and apply it to the opioid crisis. The opioid crisis is killing just as many people as the HIV epidemic did at its peak. It deserves the same sort of approach and investment as we put into that. And 90-90-90 is the goal now, but that wasn't where we started in 1993 or in 94, 95 when they initially thought of the cascade, like when effective medications came out. They were dismal, and there still are now. There's huge disparities in HIV success rates in the United States still. So while overall it's a good picture, we still have major issues. So.
Okay, question over here.
So Ingvild Olsen from Baltimore. I just wanted to also make a comment about the PCSS, the mentorship, and really using not only PCSS, but there are absolutely Maryland has what's called the Maryland Addiction Consultation Service, which is actually run through the University of Maryland, which is a warm line for physicians to call and get kind of real-time advice about kind of buprenorphine and patients, challenging patients. So Yes, absolutely. There are some of those resources out there. My question, I guess, actually has to do with the data and the data measure. So in Maryland, we are held to the National Outcome Measurement Systems. And the NOMS measure things like admission to treatment, discharge from treatment, discharge planning. And for a chronic disease, those are words that don't fit in kind of my lexicon. And so, I love the cascade of care. I love kind of all the various different measures. But if those are the national outcome measurements and measures, how does that kind of fit with where we're really going?
I agree with Maddie. She just said it doesn't, and I agree. I think, what we're trying to do in both in mental health and behavioral health and across as we think about difficult populations where we can measure some evidence-based treatments where we can, but we also need to have the outcome measures be part of what we monitor and track. In depression, we're using the concept of measurement-based care, and we have measures that say, did you track symptoms over time? And if they didn't get better, what are you doing about it? And that's the same way that I think we need to be thinking about these measures, like, do you have a friend? Did you hurt anybody or yourself, school, work, symptoms? I think that piece of really trying to incorporate that patient-reported information, and maybe we need some caregiver-reported information as well to help us understand what's going on. That information in our processes, we think about capturing the information once, using it for multiple purposes. We want to use it to engage the patient. What really matters to you? What would help you get better? Where do you want to be? And then for the clinician, it becomes part of the care planning. It becomes part of what's reported out. But it requires a whole new way of thinking about where we get data and how we use it for measurement.
And we do know that there are tools out there. There are automated tools now. There weren't 5 years ago.
Yeah.
That can track, that a clinician can use to track during treatment with a patient. How are you doing? And what can we do to help you in a better way?
Okay, I got 3 minutes left to do wrap-up closing. 3 minutes left to do wrap-up closing, thank everyone and all of that. And then we just got 2 more questions. You've been standing really quickly, and we'll get to a very fast answer.
Okay, great. Thank
If
you
there is
very
a
much.
question.
Yep, I'll be as quick as I can. My name is Matthew Iorio. I'm the president of 88 Pharma. I'm also working with the research project out of MCPHS University out of Boston on withdrawal. I've got 2 comments and 1 question. The first comment, I just want to plug, if you're looking for a nice novel that sort of encompasses the opioid epidemic, Junkie by William Burroughs. It's actually written in 1953, but I think it's got amazing perspective if you like books and whatnot. The other thing, I haven't heard anybody comment on PDT, prescription digital therapeutics, in this entire discussion, which is something that it's part of that clinical package of treatment options that hasn't been discussed. My question for the panel, Matt, it's a lifelong commitment, and so that's I can understand why a primary care physician would be hesitant to make that leap with somebody who might be sort of on the fence. Is there a way to salami slice OUD into a way that's not a lifelong commitment? Is there any sort of hope in that direction, or is it one or the other?
No.
Okay.
I'll catch you afterwards.
Okay.
Okay, sure.
You're going to say no too? Okay. Well, I was going to adjourn. Apologies. There was a question online. We're going to go ahead and skip to the end. I'd like to thank the panelists very much for all of your comments and presentations. Really helpful panel. I'm going to ask you to leave so that Mitra can come up and give closing remarks. So thank you very much. Okay, now let me welcome Mitra Adapur from the FDA to give some closing remarks for today's conference. Thank you. Yeah.
No need to.
So thank you. I had put 2 pages of closing remarks. I'm not going to look at it at all because I know it's at the end of the day and everyone wants to go home. So forget about that presentation. Just really on behalf of FDA, I wanted to thank all of you, the wonderful speakers, and the Duke Margolis team. A special thank you to Dr. Woodcock, Admiral Giroir, Katie Green, Isha Sharma, Dr. Emily Deng, and Dr. Nancy Chang. We've been working on this for a few months, so I really appreciate all of your help. It has been an amazing day. For me personally, it has been very valuable, very informative. So I really appreciate all the comments, all the topics that we discussed. I heard a lot of challenges that we are facing, but a lot of opportunities. So I am personally very hopeful that together we will be the generation that will end the opioid epidemic. So thank you so much for everything, and I give the mic to him.
Exactly who I was going to thank. So thanks to FDA and Mitra, the Duke Margolis staff, especially Katie Green and Isha Sharma, who have planned this event from the ground up. Excellent execution. We can't thank you enough for your help on this project, to the FDA and all of the panelists and speakers that we've had, and everyone in the room. Most of you stayed throughout the day. That's hard to do, and I appreciate all of you staying, and we've had great viewership online as well. So thank you. Look for next steps on our website. We're looking forward to following up with FDA. The video will be archived on our website, and we'll be also producing the PowerPoint presentations as well. Thank you very much, and have a great day.